To our summer school. I know that many of you have planned your vacations around this event because it was so popular last year. Unfortunately, we could only make a day out of it this year. It's not 2 days long. I'm going to miss the second day, I tell you. But a lot of you got to get back to bill an hour, so we're not going to keep you that long. There's a big accident. Nice haircut, Chandler, looking good. Nice. There's an accident out on 95 where some of my key staff is behind a lot of cars right now, so they will be coming late. And if there's any members out there, please come on up. We have a special guest today, Laura Jane Cohen. You want to introduce yourself? Everyone knows the rest of us on. She asked permission to come to this because, like I said, everyone wants to come to the boot camp. This is where we learn the basics. We're not going to try to be hard on anybody. There may be a question or two if we just don't understand how things are moving along and going along. And you're welcome to text me anytime. Most of you know my number, and we'll ask those questions. Just kidding. Okay. Welcome, Dr. Karen Shelton. She's our health commissioner. She's got a big job over there, lots of things that they do, and she's going to tell us about them right now. Good morning. Oh, no, I'm so sorry. It's my favorite. I just talked to Dr. Shelton earlier, so it threw me off. Welcome to our Pardon me? No, we never. We want you first. We want you first. You're working hard, or at least that's what you tell me, over there on the third floor. Welcome to our Secretary of Health and Human Resources.
This is payback for being late to a meeting.
Yeah, no, I'm sorry about that.
What that was. I got your number.
Secretary Kelly, thank you for coming. And you know why I'm messed up here? This is the truth. On my screen it says the Virginia Department of Health. Mm-hmm. So I have an excuse.
I don't have a slide.
I have to, But
right. You're forgiven. You're absolved.
Thank you. Thank you. Welcome. You have some good news for us?
Yes, I do. I have lots of good news this morning. Good morning, Mr. Chairman and members of the committee. I'm Secretary Janet Kelly, Secretary of Health and Human Resources. Thank you so much for inviting us here today. Thank you to Chairman Sickle and his staff for putting together this boot camp in hopes of partnering together better with you all. We may not be wearing combat boots today or scaling walls, but I do think it's ironic that the uniform that soldiers wear during boot camp is called fatigues, giving the breadth of our work and the vast nature of our work. HHR is the largest secretariat by far. It covers 12 agencies, over 15,000 employees, and comprises over a third of the state budget. I wanted to share this morning a little bit about what we've accomplished together, and then I want to talk through some things that we are going to get done before the end of the administration, and then look even more forward into some things that the next secretary and the next General Assembly may be interested in knowing. Does that sound good? As far as the structure, great.
Please proceed.
Thank you. So sometimes in this job, I learn something new every day. I'm surprised a lot in this job. And sometimes it's by the difficulty of the problems that we're tackling. By the time an issue comes to my desk, it's gone through several layers of really smart people who either figured it out and have recommendations or couldn't figure it out and need my help. The sheer magnitude, you all have heard me say before, the Secretariat covers everything from obesity to oysters to opioids. And that's just one agency that you'll hear from next. Sometimes I'm surprised by how ill-equipped we are as a government to solve the problems that are before us, and that is due largely to workforce challenges that create capacity issues. I've been a public servant for about 25 years, and it dawned on me when I first took this role that it wouldn't matter how much money I had, I still couldn't find the right number of people to fill the jobs, and I think that you all can empathize with that. Most days I'm really impressed with the impact of this work. We do work hard. I will share some stories offline with you that indicate that, but one of them is when we first came in at the Youngkin administration, the janitorial staff was very frustrated that we were not out of our offices at 5:30. And I said, look, I'm not sure what you were used to before. It was COVID. There was a lot of working from home, but we're not going to be leaving at 5:30. And so we had to negotiate with them and work with them and say, just come in and get our stuff. It's fine. You're not bothering us. You're not interrupting us. And we were able to work something out, but we do work very hard, and so do all of our agencies and the state employees in this secretariat.
Well, we could lend you some of our custodial staff over here because they work hard. They're here late at night in this building.
Sure, as do you. Okay. It's like, I mean, it's especially, all the time. You work very hard. I get calls from you and early morning texts, and yes, we're all working hard, and Virginians are very lucky. All right. On that note, I'd like to take just a minute of your time to talk about looking backwards what we've accomplished together. We've had some really amazing accomplishments, and my team will tell you in meetings, we talk about glass balls, rubber balls, and paper balls to help us prioritize. So glass balls are things that if you drop, they're gonna break and it's gonna hurt somebody. And in this secretariat specifically, hurting someone can be fatal. Paper balls are balls that are really important that can turn into glass balls if you don't pay attention to them well, but they're gonna bounce back. If you go home, take care of your family, and you didn't get that checked off on your to-do list that day, it's gonna be there tomorrow. So I'm gonna talk about a few of those things. Paper balls are sort of sins of omission that you really wish you had time to do, but you may not get to because the glass balls and rubber balls are just bouncing at you all the time. Paper balls can turn into rubber balls. Paper balls are like a trip parent call. Like if you don't call him back, he's gonna call you again the next day. So you kind of rely on other people
Madam Secretary, he comes to these meetings without a tie on.
I know, he's ready to play golf.
This is how Virginia has changed over the years. Back in the old days, they would have thrown him out of here before they let him in the room, but please proceed.
Sorry, Trip. I gave him a heads up that I was going to make him the butt of my joke. I didn't know that also meant he would be the butt of your joke. I apologize. So let's focus on these glass balls. These are big things that we had to handle well together, and I'm proud that we have. Behavioral health, through the Right Help Right Now initiative, we've invested $1.4 billion in our behavioral health system and passed legislation to accompany it that would transform the way that patients in need of help get it. The Right Help Right Now initiative, we're going to be talking about this a lot the next 5 months. It has saved over 5,600 hours in law enforcement time, created a new position in order to expand our workforce, behavioral health tech. We have done so much on workforce. I can't even get into all of the things. We probably need our own boot camp just on Right Help Right Now because it's been so successfully implemented. Created 5,440 more waiver slots for people with IDDD needs, and successfully procured the most meaningful contract in Virginia history, our Medicaid contract, which went live July 1st. The reason that you haven't heard a lot about it, if you haven't, is because it is going well. Trust me, if it weren't, you would be hearing from your constituents. So the fact that you haven't heard a lot, or at least I haven't gotten a lot of calls from you, is a big deal. Child welfare is another glass ball. Within the first 6 months of the administration, stopped the phenomenon of kids sleeping in offices, ERs, and hotels through the Safe and Sound Task Force. And we worked hand in hand with so many of you, so many of your local DSS agencies, and you all were kind enough to give the task force $3 million without a lot of structure around it because it was such an urgent problem, and we were able to do some really creative pilots with that money that helped us continue that work. The number of kids who were displaced was reduced by 89% the first year of the administration, 76% the next year of that 89%. So we're going to just imagine that we'll just keep chopping it down, and then 50% after that, making this phenomenon the exception, not the rule. We virtually eliminated it. We also unanimously, you all passed a first of its kind kinship care system focused on child safety and belonging to ensure that the first option for kids before foster care is someone familiar. As a mom of a kiddo that we adopted out of foster care, I can tell you that every sleepless night and every stress-filled day is worth it because now other families will not have to endure what we did. We also carved out kids in foster care in our Medicaid contract, which is huge. I hope somebody asks Director Roberts about that this afternoon. So we've got 5 MCOs that are giving care to all of the Virginians on Medicaid broadly across the Commonwealth, but every kid, 5,500-ish kids in foster care will have their own contract Anthem won that contract, and we have met with them, and we could not be more excited about the potential of what that means on the care coordination side and the quality of care. Child welfare, like a lot of these glass balls, is also a rubber ball, so I will come back to that later in my presentation. Fentanyl, we took an all-hands-on-deck effort, including interdiction, prevention, and an awareness campaign called It Only Takes One, spearheaded by our wonderful First Lady, Mrs. Suzanne Yunkin. This work led to an astounding 44% reduction in the number of overdose deaths in the Commonwealth, making us a leader in the nation. You all passed legislation to give us more tools to prosecute criminals who sold fentanyl this past session. It just went into effect in July, and we could not be more grateful for that partnership as well. Maternal health. At the beginning of the Youngkin administration, Virginia was struggling with some very bad outcomes. Black and brown moms and those living in rural areas were not faring well. So we got to work, and guided by Governor Youngkin personally, his mom was an OBGYN nurse. She literally wrote a book on obstetrics. We took a targeted approach. We looked at every case and said, what would have saved this mom's life? DMAS and VDH took the lead on this. We worked across agencies, across branches with you all on this noble work. We passed safety bundle, you passed safety bundle legislation. We relaunched a task force on this topic. We highlighted solutions as simple as aspirin. We made sure that moms were going to see their doctors if they had troubling symptoms. We asked our MCOs and insurance companies to open clinics after hours and on Saturdays to make it easier for moms to get to an appointment. And as a result, Virginia has seen a 49% reduction in deaths due to maternal mortality. Truly astounding work, and we are so grateful for your all's partnership, especially on your Momnibus bills this past session. Children's mental health is the last glass ball. EO 33 was signed last year that directed on just an executive order side schools to develop plans for cell phone free education. We have visited many, many schools and talked to many, many parents in the intervening months after that was signed by the governor, and just continued to hear about the driving force that cell phones and social media and addictive algorithms that power them are to children's mental health. 57% of teen girls say that they are chronically hopeless or sad. Suicide is the second leading cause of death for 10 to 14-year-olds. 59% of Virginia's children report being bullied online. And so we knew we had to do more, and we did. We launched a Reclaiming Childhood Task Force to accompany the EO 33 work via EO 43. And that work continues, and we'll invite all of you to it, a Commonwealth Day of Play, talk about some simplistic solutions, but the data shows that playing is the best antidote to taking something away from kids, introducing something else instead. So I'm happy to send you more studies on that. But again, in partnership with you, you all passed a bill this last session to limit social media usage to 1 hour per day. And so we're very, very grateful for that. And so while the news media likes to focus on things that divide us sometimes, I've just listed 5 things that we worked on together in a bipartisan fashion. Most of these things passed with overwhelming majorities. It wasn't even close. A lot of these things I get calls from you all on to help with, and I hope you have found my staff responsive and professional in those efforts. Let me add a bonus round on the glass balls, because this is government. The stuff that I've mentioned is just the stuff that makes the news. The operations side of government is the secret sauce that actually gets stuff done and allows those of us who appear in videos at committee hearings to get stuff done. And after COVID, as you can imagine, the operations side of government and many of our agencies needed a lot of attention. I mean, we were in crisis mode. We were just trying to get the job done in Virginia. We got the job done. But when the Youngkin administration came into office, it was apparent in a number of ways that that side of the house needed attention. And so we've reorganized agencies and offices within agencies to make things work better, cleaned up troublesome financial operations, made some very much needed but tough personnel changes, improved our procurement processes, and worked hard to push technology projects over the finish line. We're still pushing technology projects over the finish line and probably will until our last hour in office. But I highlight all 6 of these things, if you count the operations piece, for a few reasons. First, the practitioners in HHR call highlighting accomplishments first a strengths-based approach, if you've never heard that term, and it has rubbed off on me. So I try to start every conversation with at least one positive because goodness knows we need it. But secondly, and more importantly, to show just how much we've accomplished together despite the increasing partisan nature of politics and public service. And then lastly, to highlight that accomplishments are still possible and often not as complicated as we make them out to be in our complex world of healthcare. We do have plenty of work remaining for the last 5 to 6 months in office, so those are the glass balls. Let me talk about some rubber balls. These are the things that are just going to keep bouncing back until there is a solution that is a holistic one. One of those is nursing homes. I get a lot of calls from you all about nursing homes. I can tell you that it is a huge priority. There's been a lot of work behind the scenes on those over the last, actually 3.5 years. We had legislation passed this past session that gives VDH more tools, and you will be hearing more on this topic in the coming weeks. And also Dr. Shelton, I'm not gonna steal her thunder, she is gonna speak about this today as well, so she can get into more detail on nursing homes. Secondly, child welfare. I told you it was gonna keep coming back, and the child welfare system, I think we've done a lot of big things in Virginia over the last 20, 25 years since I've been in politics, and I think it is child welfare's time. Or turn. And the reason that I say this is because when I was Secretary of the Commonwealth for Governor McDonnell, about halfway through my term, you know my story, we got a kinship placement, and that sort of took me out of the political side of public service and into the actual public service side of public service, right? And that will do it. And I remember writing a top 10 list for Dr. Hazel because he was staying on into the next administration, and number 10 on the list was, I think it's time to reevaluate how well our local administered system is serving children and families. And it's not their fault. We have amazing local agencies. I hope you know your directors. I hope that there are not rules that prevent you from talking to those directors, because sometimes there are. I understand Delegate Cole's a foster parent. Are you still fostering? Bless you. How's it going? Can you share anything?
I got to think about this.
I need a sip of tea, so give him a minute.
Delegate Cole, continue with your campaign speech.
Thank you, Mr. Chair, and Secretary Kelly, thank you so much. I have to absolutely give a shout out to Henrico Department of Social Services, because they have been absolutely amazing during this year. And we've just hit a year a couple months ago that my wife and I have had custody of our nephew. And the whole process has been amazing. They've provided support for everything that we've needed. We've never had any questions. And I'm really grateful for the help they're giving my brother-in-law as well, to make sure that he's prepared to take our nephew back. And so I have no complaints. It's been an amazing opportunity. And I'm sure I'm a rarity, but it's been an amazing opportunity. And I'm really grateful for all the hard work that you all are doing. Thank you.
Well, thank you for sharing that. And my goal is to make sure that your experience is the rule, not the exception. And I know that we all share that goal. Unfortunately, and you're going to hear from DSS later this morning, specifically on the child safety side, we've got some real challenges. I see Mrs. Cohen nodding her head. She probably has some stories that she could tell. These stories don't often make the news. They are invisible. So you're taking a subset of children who are already invisible and making them more invisible by not revealing the details surrounding their endangerment. And so we are going to do the best we can to gently and in a trauma-informed way shine some light on some of those cases in the next 5 months, so that you all have the information that you need to act accordingly. Because I think that if you had more information, that you would be doing more on child welfare. Secondly, on the child welfare piece, back to the locally administered system, the local state balance, I gently would say, and I'm saying this so carefully, that we have the worst of both worlds. In other states, we've done an analysis. You all may know we hired a consultant this year to come in and help us determine next best steps, similar to what we did on Right Help Right Now. And the huge takeaway, the study's not done, but the big takeaway, at least in the intermediary, is Virginia has the most number of localities and the least amount of accountability. And so, again, I'm just preparing you for what's coming. You're going to hear a lot about this in the next few weeks, the next few months as you lead up to session. I do expect that there will be some kind of legislative package that comes out of the McKinsey study similar to Right Help Right Now, and you will hear more. But consider this a preview of DSS's presentation. So that second rubber ball is child welfare. Third is infrastructure. Those are just ongoing operational stuff inside government, procurement, technology. I mean, you all know better than anybody, but I mean, some of these agencies are still using paper-based systems. Truly unbelievable in 2025. And they are really contributing to some costly errors that are finally now catching up with us, which you'll hear more about today as well. That's just on the state government side. On the local government side, it also gets back to the local administered system where, let's take hypothetically the Richmond water situation where people think the state has a lot more authority than we actually do to fix it. We don't have the authority to fix it. The governor is encouraging a regional approach and has met with each of the 4 counties together to encourage that regional approach. They've met on their own, as you know, Delegate Carr, I'm sure you've gotten those reports as well. But those are things that are going to keep coming back until they are dealt with. And then lastly, just what we're spending our time on the next 6 months is institutionalizing a lot of these priorities that we've talked about. I'll flag a few things for next session, and they're going to sound awfully familiar to you all, and then I'll close. Water, human services, both the child welfare and the benefit side, and then adapting to the new normal of the One Big Beautiful Bill. I know that you've had a lot of presentations on those. We're still analyzing it and coming up with what exactly the implications are for Virginia. But that is how we are spending our time in the remaining 6 months, in addition to answering your questions and constituent requests. So thank you again. It's an honor to serve in this role. It's an honor to serve Virginia alongside you to accomplish big things.
Thank you, Madam Secretary. We'll take questions from the committee. First, I want to introduce Delegate Carr. She's joining us from the Appropriations Committee and on the Health and Human Resources Appropriations Subcommittee. So welcome to the Health and Human Services Committee. Okay. It's a lot of words there. Okay. So do any members have a question for the Secretary? A lot of the stuff she mentioned that we're going to go over with the agency heads coming up in health and in DSS.
I think if you let me go, it catches up on time from starting late.
If I let you go right now without any questions?
Yeah.
Well, I'm going to give you a softball if no one's going to answer.
They're the worst.
So you mentioned this, but I think that our biggest challenge, us and the rest of the country, is where our workforce is going to come from. You mentioned that briefly, because we could spend more money on this stuff, and we don't have the counselors, LCSWs, the advanced practice psychiatric nurses, psychiatrists. We don't have them, and we especially don't have them in rural Virginia. And then in the psychiatry area, we don't have them that take insurance. So there's so few of them, and so they've got a market advantage over us in a big way. So we've got several initiatives to try to boost our 16 universities and all of our community colleges in producing a better workforce. So can you tell us what is working the best, what we need to put more money into?
Sure. And are you referring specifically to behavioral health or all of health?
No.
Okay.
That's probably a critical need that we hear most about, but just generally for the healthcare system generally, we don't have enough people going into the various allied health fields, nursing, the huge nursing shortage that we have.
Sure. So we do have some good news to share. This is the toughest nut to crack just about of anything that's on our plate, not just in our secretariat, but in every secretariat. We do have a lot of job vacancies in healthcare, and we do have a shortage of almost every single profession that we need. That's the bad news. I think at one point I heard we had 271 child psychiatrists for 2 million kids in the entire Commonwealth, just to give you some idea. And you can't create a child psychiatrist overnight. I mean, that takes years, 8+. And so we have taken a all hands on deck approach. I think Director Owens, are you going to touch on any of this in your presentation? Okay, great. We've done a lot on universal licensing that he can talk about with you. We've created several new behavioral health tech type professions that are brand new. They pay really well, considering, and the credentialing on those is not as high as you would think. I've thought about doing it myself because they are so needed. And it is, we've done that. There's stuff we've done on nursing, and I would just ask, Deputy Secretary Mills is gonna kill me if I call her up here, but I know I'm gonna forget something. So would you mind popping up and listing off in short order 3 or 4 of the things that we've done beyond what I've listed on workforce? Leah is our workforce guru, so I'm gonna make sure I don't forget anything.
Welcome.
And we're also happy to condense this and give you more information offline if you would like.
Okay, terrific. And so could you tell us what we need to invest more? I'm going to put my appropriations hat on here. What we need to invest more in, what's working the best of the programs we have, and what's not working as well. So thank you, and please introduce yourself. Welcome.
Yes. Good morning, Delegate Chairman Sickles. Leah Mills, Deputy Secretary of Health and Human Resources. So Secretary's right. We recognize the shortage and the need, and so definitely grow your own is the best way to go. And so I think also, I don't know if Commissioner Shelton is going to mention our Earn to Learn program with nursing. That has been successful, and I think that also Director Owens will talk that we're starting to see some success in our numbers with nursing. There is a little bit of a bump in nursing. We know we have a bit of a way to go, but also working with our community colleges. And you all have, and we passed some regulations with clinical placements and nurse preceptors, and those are the things that we know are successful. And we're looking at regulatory reduction is also one of the things that is working. So we will be happy to come back with you with more recommendations.
So is it fair to say we just need to do more of what we're already doing these things?
We are.
Yeah. Right.
But we also need to look at community colleges, high schools, and looking at our pathway approach, partnerships with.
We have waiting lists at Northern Virginia Community College Medical Campus. We have waiting lists to get into several of their programs.
Healthcare?
At the medical campus, in my district.
We are looking in partnership with the Department of Health with clinical placements seems to be a barrier everywhere. And so that is one of the nuts that we're trying to crack with that. And so we're hoping that we can do more with that, because I think that if we can really tackle that,
So
that would really
over in this corner over here are a bunch of hospital people, that whole side over there, and they can help you with clinical placements, okay?
They need
to work together.
mentors.
Yes, and preceptors. I love that word.
Preceptors.
Right. So it's the partnership with our agencies and with the institutions. And so we're having those conversations.
Okay, terrific.
But short answer to your softball question, we will get you a list of things that are working, that we know are working, for consideration for your other hat.
Terrific, thank you. Anybody here have a question? Yeah, Delegate Willett.
Thank you, Mr. Chair. Just following up on that note, I just want to make a note wearing my Virginia Health Workforce Development Authority hat. We are going to be announcing next month the executive director for the newly formed Nursing Workforce Center. And what that center is doing, it's not completely starting over again. As you just heard, we're doing some great things in developing the nursing workforce, but it's to coordinate, to gather data, and basically leverage best practices across the state. We've got all our partners at the table. We have the private hospitals, we have the community colleges, we have the four-year colleges, all doing great things. But what we've seen in the states that do have this program is that the coordination yields better results. So stay tuned for that announcement next month.
Thank you, Mr. Chairman. Appreciate that. Okay. Any final thoughts here? We can. Okay. Are you going to stick around for the rest of it? Or you can go and watch it in your office. I'm sure you turn it on.
I'm going to stay for most of the day. Yes,
Oh,
sir.
wow.
And or observe for most of the day while I'm not on my phones. So
But
thank
if
you.
there's anything that gets you upset, don't hesitate to jump up.
Thank you, Mr. Chairman and members of the committee. Thank you.
Thank you. Thank you. Okay, now we're moving on to the Health Department. We're lucky to have the commissioner here, Dr. Karen Shelton. So this is, this is Education 101. So what we want to do and share with the Commonwealth's people that are interested is what you do. What do you do over there? And how's it funded? Thank you.
Well, thank you, Mr. Chairman and members of the committee. Thank you so much for having us here today. We appreciate the opportunity to present to you today about the Virginia Department of Health and what we do. Our scope is very vast, and we're excited to share that with you. We have a formal agenda for today. As we look at when it comes to health, we have a large scope of what we do and our responsibility for the Commonwealth. You interact with some key functions of the Virginia Department of Health every single day. You may or may not realize that. We have many partnerships that guide and support our services, and we will focus today on a few of the areas, topics of interest. So the mission at the Virginia Department of Health is to protect the health and promote the well-being of all Virginians as we strive in our vision to become the healthiest state in the nation. Public health is both the prevention of disease and the promotion of health. Health encompasses not only the physical, but also the mental, social, and spiritual health, often called well-being. Public health foundationally begins and continues with the prevention of disease by keeping whole communities safe, by promoting things like clean drinking water, proper sanitation, and safe food in public places. With vaccines, we have further prevention of disease. Public health also looks at our communities, our regions, and the state, and through the lens of our chief health strategist, looks to evaluate healthcare resources and gaps and facilitates partners working collaboratively together to promote health. We know that healthcare is necessary for good health, but there are more factors that contribute to our health, such as the availability of nutritious food, good education, good jobs and economy, safe neighborhoods, walkable communities, adequate housing and transportation. These are also referred to as the social determinants of health because they are factors that contribute to the physical, mental, social, and spiritual well-being of our persons and our communities. At the Virginia Department of Health, we're made up of kind of two different organizations that two different factors that come together. One is our central office, which is located here in Richmond, that has our offices of subject matter expertise that oversees many of our state-level functions, things such as vital records, licensure and certification, things of that nature. But then we have our local health departments, which are organized into 35 health districts, which serve each locality within the Commonwealth. And they kind of serve as the boots on the ground to know their local localities and to be able to administer services locally. We'll go into a little bit more detail about that. But first, we'll focus on our senior leadership and critical functions. The Virginia Department of Health was one of the agencies, as you're well aware, that the Secretary referred to that had some administrative difficulties as a result of COVID, where we went through a time where we worked extremely hard throughout the COVID era with all the challenges that it represented in helping to save lives, but also had to sacrifice some of our administrative functions during that time in order to get all the work done. Since we've been here over the last 2.5 to 3 years, we've been rebuilding the agency, the Virginia Department of Health, and we're very proud of the rebuilding we've been doing. So we'll focus on some of those rebuildings and senior leadership positions at this time. The Chief Operating Officer is served at this time by Christopher Lindsay. And this was a newly created position 2.5 years ago that was created to help increase our operating efficiencies as well as our accountability throughout the organization. This position oversees several of our more vital offices of the Corps, as well as it was instrumental in rolling out our monthly operating reviews that we started doing with each of our offices to help look at budgetary resources, human resources, as well as looking at our objectives, key results, and employee engagement. We have our Office of Human Resources as well under this umbrella, and this helps to serve as we look at our growth of our public health and the need that we have for our healthcare resources there. We also have our Office of Information Security, internal audit, and workforce development. This workforce development engagement was a new position that we brought on board to help us in the aftermath of COVID with our rebuilding, renourishing, and revitalization of our own healthcare workforce, as well as, so that's the internal component, and then the external component department is to look to see how we can interact with other agencies and state functions to help build the healthcare workforce in general. We also have a community relations position that helps to increase public health visibility, as well as champion our internship program, which has received some national awards. One of the other offices that is new to us is the Chief Financial Officer, served at this time by John Ringer. And this was a new position that we created in order to be able to have better accountability with our financial compliance. We have created several new offices within this function as well, including our Office of Grants Administration for an agency with over 160 federal grants and over 50% of our funding coming from federal grants. This was a vital position in order for us to be able to work with these financial areas. We also have now a newly created Office of Budget, which will help with our financial resources, as well as our traditional Office of Financial Management and Procurement and General Services. This is one of our offices that is benefiting from the ARPA money, where we have the extended monies and the ability to increase our technology to help modernize some of our financial systems. This is largely overseen, this modernization of our public health infrastructure is largely overseen by our Chief Information Officer. This has been elevated to the chief position. Suresh Ranjanjan is our Chief Information Officer, and he oversees the Office of Information Management, which really does help to maintain and develop our new systems that we have now with our ARPA project to be able to modernize our public health systems. We've been able to place broadband in each of our 140 locations of the health departments and WIC offices throughout the state to be able to accomplish this, as well as we're now expanding into an electronic health system, going from a paper health record into electronic health record. This was something that before was not achievable because it's a multi-million-dollar and a multi-year project that was only achievable, so we're very appreciative of the ARPA monies that we've been given. Thank you for that. Our Office of Vital Records is also within this umbrella, and it handles over 1 million vital records per year, things such as birth, death, marriage, divorce, and other vital records. And then we have our Center for Public Health Informatics, which handles our all-important data infrastructure. The Office of Virginia Department of Health has a large data infrastructure that is used to inform the decisions that we make, not only within our office, but within many healthcare things throughout the Commonwealth. So we have a new Deputy for Population Health and Preparedness, Stephanie Dunkel. She's been in her role almost, I think, right at a year, coming up on a year next month, and we're excited to have her in this role. She oversees 9 of our programmatic offices, so this is a large bulk of our subject matter expertise across the state. Some of these offices handle more statewide functions, and some of them do partner very closely with our localities across the health districts in the work that we do. You're very all familiar by now with the Office of Drinking Water and what it does throughout the Commonwealth. We also have our Office of Emergency Medical Services, which we'll highlight a little bit more in just a moment. Our Office of Emergency Preparedness is there to help coordinate and facilitate coordination of disaster, and we certainly have had our share of responses this past year, including Hurricane Helene, the Richmond water crisis, as well as some other community disasters that we have focused on. We also have our Office of Environmental Health Services, and you may not know, but they not only do restaurant inspections and the on-site, in charge of on-site within the rural communities, but they also are in charge of our shellfish inspections, as well as milk inspections, pools, marinas, and camps. So they have a wide variety and scope of everything that they tackle. Additionally, we have our Office of Epidemiology, which we'll focus on a little bit more in just a moment, but this is one of our biggest factors in our promotion and prevention of disease, and specifically communicable disease and the things that we carry out throughout this office. Our Office of Family Health Services is in charge of many things, such as our maternal child health initiatives, which the Secretary highlighted, as well as a lot of our work in substance use disorder. Office of Health Equity, you mentioned this is our office where we do house our workforce development programs, and these are the loan and scholarship programs that we have not only for nursing, but for their healthcare sectors as well, including behavioral health, dentists, physicians, and many within, and pharmacists as well. So one of our biggest programs here you mentioned was the Earn to Learn program. This is a program that we're very excited about because this the nursing profession took a big hit during COVID. We had people coming through school who weren't really able to do their rotations properly in hospitals and healthcare settings throughout that time, and there was a large gap in what they learned and what they experienced when they came, and we had a lot of people not continue in the nursing profession. So we really are excited about this program to be able to mentor nurses as they are training to actually have a payable job that they can have so they can sustain themselves. This allows a greater opportunity for people from all sectors to join into the nursing profession. And then they are paid during that time and have mentorship so that when they come out as nurses working out on the floor in the community, they're much more skilled and confident in their abilities and more likely to stay on the job. So we're very excited for this program. Also, the Office of Chief Medical Examiner determines causes of manners of death. And we also have the Office of Radiological Health, who, if you have a dental x-ray or mammogram, our office does oversee some of that work, some of the regulation of that. So you may have interacted with these things, like I said, each and every day. One of our other offices is under the Deputy Commissioner for Governmental and Regulatory Affairs, Joe Hilbert. And Joe is our most seasoned Deputy Commissioner at this time. This office advises and assists the Commissioner on a wide range of operational, policy, and legislative and regulatory issues, as well as administration of the State Board of Health, in keeping with our HIPAA compliance, language access, and many other things. This also office helps to lead us through our General Assembly session, and so you're probably well versed with Joe Hilbert and his team as we navigate the legislative session each year. The Office of Licensure and Certification is our office that works to make sure that we have quality and safety of care in our health care facilities, both hospitals, nursing homes, hospice, and other health care facilities. The Secretary mentioned in our nursing homes, we do have a lot of work going on to increase our presence there. We do value the safety and quality of care that our nursing home, these very vulnerable residents, receive, and so we have a huge focus going forward. During COVID, it was difficult to get the inspections in, and we lost a lot of staff, but we have a very large staffing and aggressive staffing campaign going on right now to hire in more of our medical facility inspectors. We also are very thankful for the legislation that was passed this past year. We have taken the fees from our nursing home applications from code from the 1970s and put it now into regulations where we can keep up, and this will help to fund more consistently our needs there. Also very thankful for the legislation that went through that gives us more tools in order to address. We've had an increase in complaints as well as findings and immediate jeopardies in our nursing home facilities, and as we focus on what we can do to hold these facilities more accountable, we're looking forward to the regulations that will come forward based on that legislation. In the meantime, because regulations take a while to develop, we're also looking to see what we can use in our state regulations, and we're developing things to be able to address things in a more timely fashion with some of the tools that we already have. So we're very excited about our work that continues in the nursing home area. We also have our public health policy and planning, as well as our VDH Institutional Review Board within this office. One of the biggest parts of the Virginia Department of Health, and you may be more familiar with this segment of our agency in your localities, is through our community health services. Our Deputy Commissioner for Community Health Services, Dr. Susan Fisher Davis, is new to her role about 1.5 years now, and so we're very thrilled to have her leading our health directors across the Commonwealth. We have 35 health districts across the state. 3 of them are locally administered in Fairfax, Arlington, as well as Loudoun. But this organizes each of our locality with a health district into these with our health departments into these larger health districts. Each district is unique, but does have a similar structure. We have a district director in place who then is typically supported by an environmental health manager, nurse manager, district epidemiologist, business manager, population health manager, and emergency planner. We're very grateful that in 2022, the General Assembly passed legislation, thank you all, for allowing non-physicians to serve as health directors. We had quite a few gaps. Almost 1/3 of our health director positions were not filled, and we had health directors who were co-leading 2 districts, which is very difficult to do. So now we have hired 10 non-physician local health directors, so each of our health districts now has a health director in place. We actually are interviewing one at this time that has turned over recently, but we're very excited to have this infrastructure, a leader for each of these teams. We do have 3 medical officers who do work with those districts who do not have a physician health director to make sure that all of our medical needs are covered at that time. We'll speak a little bit more about the work of our health districts in just a moment. So looking at some of our federal, state, and local health partnerships, we collaborate.
Maybe this is a good time
Yes.
for people to ask questions before you move into the partnerships, and you'll be talking about the federal contracts or that we might be losing during this section. maybe. Does anyone have any questions about what we've heard so far about all the scope of work that, on the nursing home front, how is your backlog of responding to complaints at this point?
We still do have a backlog of response to complaints. We have been able to hire up contractors to help respond to these complaints. So we triage them such that the ones of the highest severity are responded to in a timely fashion. Some of those with lower severity, we'll go in and take care of several of those at one time.
Are the staff that do that the same staff that issue a license to somebody to operate a nursing home?
Generally, they are able to do both, but where we are having these contractors come in, we've been able to concentrate some more on the complaints, and then we have staff that go in to do the regular licensing and certification. However, we are able to combine some of those. It depends on, as they work through an area, what are the greatest needs at that time.
Okay. I was unaware that you're using contractors for this. I guess I'm happy about that because of the backlog we have.
Yes.
But I've heard complaints that people can't get a license. The reason they can't get a license is the same people that are doing that are responding to an enormous number of complaints about the industry across the Commonwealth.
Two things. One is the contractors generally are paired with regular VDH employees. They help to multiply the work at the time. And the second is there are different things that we license and certify. So generally the nursing home licenses certifications are fairly straightforward, as well as the hospitals are fairly straightforward. I know that sometimes I have heard of some hospice, and we are working to make sure that we have adequate staff in order to get the hospices licensed. We've had an explosion of home health services that have led to actually a backlog in those licensing because they have exploded all over the state. So we're working to increase our healthcare workforce in that area as well.
That's terrific.
This is part of our aggressive hiring campaign.
It's generally the policy. What we're trying to do is keep people in their homes as long as possible. So I'm glad you're increasing the workforce to do that because we want to make sure everyone's safe.
Yes.
We started a value-based purchasing program and a couple years ago, and I know that's a DMAS thing, but as inspectors, do you see it working? Do you see that the incentives that we're offering skilled nursing facilities are helping up the the quality a little bit?
I would probably need to ask my staff a little bit more details and get back to you on that specific answer.
Okay. Mm-hmm. Okay.
Mr. Chairman.
Yeah. Delegate Walker, thanks for.
All right.
Thanks for.
So you mentioned a few moments ago in one of your slides here, workforce is very important when it comes to the nursing, the CNA, and things like that. And some of our localities, we have community colleges that do this. Did I hear correctly that the health department also offers scholarships toward nursing or funding in that regard there? Because I think this is a big thing as far as trying to recruit people or individuals into nursing, because certainly there's no question of shortages. And I have some facilities in my area that are really struggling. And so anything along the workforce funding, I think, is going to be important as we continue to work forward here. So I just want to make sure I understood that correctly.
Yes,
You all do have scholarship funding there.
We do, Mr. Chair. Delegate Walker, thank you for that question. We do have scholarships and loans available, and we'd be happy to get the committee a greater listing of some of these opportunities. It is so critical that we have these. We want to reduce all the barriers to having people enter into the workforce. One of it is monetary, making sure if they're not able to pay for it, that we have these scholarships and loans available. But the second is location. Not everyone can afford to travel to a place and live in a different place in order to get their education. So bringing in our community colleges is such a valuable asset to be able to have people stay locally to receive their education and reduce those barriers. And the other thing that I always like to mention for workforce development is it's important to start early. Kindergarten is not too early to get people excited and incentivized about healthcare and about entering the healthcare workforce, whether it's in nursing, as a CT tech, an ultrasonographer, a behavioral health tech. So anything we can do to encourage and expose our young people to this possible career one day, we're excited to do.
Thank you very much. Thank you, Mr. Chairman.
Thank you, Delegate Walker. I wanted to ask, if this is not the appropriate time for this question, we can postpone it until later in your presentation, but we had a rural healthcare task force, and there are a lot of problems we're trying to solve across rural Virginia, access, and because there are not providers in much of rural Virginia, we put $1 million in the budget to help with transportation, to help move people from a more rural place to Roanoke or Charlottesville or Lynchburg or someplace where they can find care. How are you doing with that $1 million? Has it been, we wanted to put it out through the FQHCs and they haven't seen anything yet. Can you tell me where that is?
Thank you for that question, Mr. Chair. I would have to look into that further. I don't know that came to VDH specifically.
Well, we directed the money to go to the FQHCs to manage it.
Okay.
To manage the money. So if anyone knows the answer to that, we need, the new year started, so we want to make sure that this initiative is being implemented.
Okay. So if this is believe this is a. Okay. We have started the contractual process with the association that represents the FQHCs.
Okay. They didn't know that. Okay. All right. Okay. All right.
We'll make sure that we follow through on that.
Okay. Thanks. Great. Appreciate that. If there are no more questions, please continue.
Okay. Thank you, sir. All right. So as we look at our federal, state, and local health partnerships, we do collaborate with both federal and local partners in a number of ways. We have state and local relationships. We support each other. And our public health infrastructure seeks to work with both locality stakeholders as well as our statewide stakeholders as well. When it comes to funding, VDH does receive general funds as well as federal funds, and then we have our special and dedicated funds that come through a combination of revenue, locality match, which I'll go into in just a moment, as well as some funds that are specifically designated, such as through the DMV, where that helps to fund the Office of Emergency Medical Services. So in years past, just over 50% of our budget has come from federal funding, and especially with an influx of the ARPA and COVID funds, which are not represented here. We do have a lot of pass-throughs that are part of that general fund as well, and we have a stable number of FTEs at just over 3,800. If we look at it on a year-to-year basis, again, this does not include our COVID and ARPA funding. You can see that our federal funding has been fairly stable. The increase that happened from 23 to 24 was due in large part to the Office of Drinking Water bilateral infrastructure partnership on the federal side with some statewide matches. And you can see we've had also some increases within our state funding for personnel increases and due to the budget bonuses, which we appreciate. We work with a large number of federal partners, and we receive monies from these partners. Some of the work we do directly through VDH. Some of the work we do pass through to other stakeholders throughout our communities, both on a statewide and a local level. We also receive additional funds from other state agencies for the work that we do. So it really is a cross-collaboration across the entire board to make sure that we are covering the public health needs that do occur. As we look at our funding at the local level, so we have the state general funds that do go to each locality, and then there is what's called the locality match. And this is a formula that is established within the Code of Virginia. It was reworked just a few years ago, and so we call this our cooperative budget. But each locality does give a percentage of match to the local health districts. We also have some local localities that fund some extra things as well, and then we have the revenue that we earn at the locality level through our clinical services and some of the other services that we provide. Some of the local health department services that we provide include our work on the community health assessment as well as our community health improvement plan. This is led in large part by our population health team. Our local health director serves as the chief health strategist to oversee the health needs of the community and help coordinate with both our federal and state and local stakeholders to be able to assess the resources and gaps within a community, to be able to fill those as needed. Our localities also serve as our boots on the ground when it comes to much of the public health functions, such as your restaurant inspections, well and septic permitting, environmental health services, and then our clinical services. We're a safety net clinical provider. We provide things such as family planning, STI work, but we also work very closely in our communities on our maternal child health. In some of our localities, we actually provide maternal health services. In all localities, though, we do help to coordinate and care navigate other maternal high-risk healthcare needs. We also, in the clinical realm, serve as the state TB control, and we provide a wide variety of immunization services as well. Some of our population health and family and well-being in our community, we look at our chronic disease within our community and see how we can navigate and help to reduce both mortality and morbidity within our communities. We've had some great, strong work in our communities for the substance use disorder, as well as the work that's been gone on across the Commonwealth. We are very involved with our localities, as well as with the behavioral health and many of our initiatives, including naloxone distribution, working with community partners to provide comprehensive harm reduction, as well as making sure we just educate our communities about substance use disorder, making sure that everyone's aware. Most everyone's lives have been touched in some manner, and to make sure that they're not alone, but to look to see what are the resources that we can provide in our communities to increase our treatment availability, our harm reduction availability, as well as we found that working with our peer counselors has been a mainstay of our work in the communities. These are people with lived experience in addiction who are in long-term recovery, and they are a linchpin as far as being able to reach those who are in active addiction and bring them into long-term recovery. We also know that some of the initiatives, as were earlier mentioned, such as the First Lady's One Pill Can Kill, are very important. When we look at our overall mortality from substance use, there's a segment of people who have been long-term in a state of addiction and then have an unfortunate overdose situation. But then we have those who don't have really a history of addiction, but they're experimenters and they will go out and try anything. And so making sure we have the education for both of these and the resources has been very critical. I was going to see if there's any further questions on this, and then we're going to get into some of the more specific
Delegate Hope.
agenda items.
Thank you, Mr. Chairman. Commissioner, I guess you mentioned the partnerships we have with the federal government. You listened to all these agencies, and with the mission and the goal, and this is a boot camp, we're trying to figure out how we're going to function as a Commonwealth, anticipating that there's going to be some federal cuts that are going to now become the new baseline. That means we're going to not be able to do as much as we had originally had hoped. What is the department doing to mitigate that, working with the General Assembly to figure out how we can prioritize what we need to replace at the state level? Because somebody's going to have to take up that slack.
Yes. Thank you for that question, Mr. Chair, Delegate Hope. We have been working all year long to look at our funding very specifically and the impacts that we have. As we have looked at what a funding reduction would look like within our agency, we have been looking to make sure that we're understanding the impact to the health of Virginians and all our communities. We're also looking at our public health infrastructure because we don't want that to get lost again. And we're also making sure that we look at our workforce both within the agency and again with healthcare workforce in the communities. So as we look at these three different angles, we've been evaluating each of our funding streams and looking at what exactly they do and prioritizing them within the agency as far as what are the things we know we have to continue, what are the things we could possibly set aside for a time and come back to, and what are the things we don't need to do any longer because we need to make room for some new things that may need to be done. So as we look at the impacts, when we have further numbers, we don't have any specific numbers yet. We've been able to receive all of our notices of award ongoing thus far, and we're waiting to get further insight into what will be the specific impacts to public health funding going forward. We don't have any line item list on that yet, but we have been teeing up and strategizing within our agency, our operations, along with our office directors and our health directors across the Commonwealth to make sure we have a good understanding of what our priorities are so that when we see what the specific impacts will be, we'll be able to then come to the table and say, these are the things we see, these are the things we feel we need to prioritize going forward.
Good hope.
Just to follow up, just to put a finer point on. So when will we get that, your recommendations? When will we see that in the governor's budget? Will that be sort of the de facto prioritization for the agency? Because I'm sure the legislature will have its own ideas as well, too.
Yes, well, as we see the federal budget unfold, that's really what we're waiting for first, is to see exactly how the federal budget unfolds, specifically in the public health arena.
Okay.
We know that there are impacts in other health and human services areas that are more well-known, but as we look to see what the specific funding implications are in public health, we'll be working with the Secretary's office and the governor's budget, and then with you regarding what we see as what becomes definitive.
Okay. Looking forward to seeing
Yeah, I'd like to follow up on that a little bit. The previous slide has our partners at the federal level right here. Most of these agencies give us grants to do things. And your agency is 70, 80% funded by these federal agencies, something like that?
Over 50%.
Over 50%. So none of these agencies were hurt by the DOGE process or the rescissions that just happened?
We have seen some changes come through, but to date, we have not seen all the implications that are going forward. We know that some of the agencies may be consolidated, but we have been able to get the notices of awards for our ongoing grants at this time, so we are continuing the work we are doing. And when we get more definitive specifics on what has exactly been cut, then we will be able to delineate and see that up.
So you're just to put a fine point on here, nothing has been cut yet. So when you have complaints coming from Ryan White funding or the CDC funding on AIDS prevention that they're not getting out there now, that's not because of a cut that the federal government has made?
We have had some small grants cut. We, at one point, had our tobacco funding cut, but that has been reinstated. There was a small HIV grant that looked at, I'll have to look, it was more of a assessment grant rather than funding of healthcare workforce. When it comes to Ryan White, we have received a 75% on our notice of award at this time. We have had some reduction in our rebates there, which are voluntary rebates from the manufacturing companies. And so we are working within this framework.
Okay. Well, that was hard to understand, but if you can help us with that as we go forward, as the Delegate Hope was saying, we sure want to know what we need to backfill or try to backfill. Not saying we can backfill everything for sure, but we need to prioritize, and your help with that would be greatly appreciated. Yeah, Delegate Cohen. Oh, I'm sorry. And Delegate Gardner, please go first before my neighbor here. I don't see it, Russ. I do see it. I do see it.
Yeah.
Yes, Delegate Gardner.
Thank you, Mr. Chair. Just a quick question. You said you got notification that your current grants have been re-upped. What time period is that for?
The federal grants come in throughout the year. So we have grants coming in almost every month. So when we get our notice of award, then those are for the year.
Okay, so you're pretty good through 2026. Sorry, Mr. Chair. Are you good through 2026?
We have received our current notice of awards, and ongoing funding will be subject to federal impacts, approvals, the appropriate.
So it could be tomorrow they say, okay, you've been funded this, but we're rescinding this, or we're not going to fill this. So it's not certain.
That is our understanding.
Thank you. Thank you, Mr. Chair.
Well, your job is very hard. Delegate Cohen.
Thank you very much, Mr. Chair. Sort of, I guess, to follow along with that, when you look at guidance that's coming, when we look at HHS, for example, and some of the guidance around vaccine protocols, and when those are in direct conflict with what VDH has been doing, how do you handle that?
That's a great question. When we look to our vaccine protocols at this time, within the Code of Virginia, we do have vaccine requirements related to school attendance, and those are also have a regulatory component, but those are within the code. And as those determinations are made, we use a variety of sources, including the CDC, the ACIP, which is the American College of Immunization Practices, as well as the American Academy of Pediatrics and the American Academy of Family Practice. So we rely on all four going forward. Where there may be discrepancies, then we'll need to look at the best science at the time to inform us as we make those protocols and decisions going forward. Thank you.
Delegate Tran.
Thank you so much, Mr. Chair. Just following up on that, I think that, our seniors are also interested in certain vaccinations as well. So it's not just our school-aged children. And I've heard from constituents who are concerned, for example, about the changing parameters on COVID vaccinations moving forward and such. And can you speak when things are not as legislated in terms of the science-based evidence that needs to be considered when making Virginia's recommendations, how you will be moving forward on that?
Yes. So while the school vaccines are the only ones that we have as required, we certainly do know that we have a variety of recommended vaccines and a schedule that has traditionally come through ACIP and the CDC. Going forward, we will need to make sure the healthcare providers are able to, citizens are able to talk with their healthcare providers regarding what are the best vaccines for them. We still will continue to follow the science for that as we look to make recommendations going forward.
Delegate Willett.
Thank you, Mr. Chair. Just since we're talking about vaccines, following amendments. So have you heard of other states trying to get in front of this, saying, all right, we're not going to see the same levels of approvals that we've had in past COVID years. So are they trying to put a public fund in place? I'm thinking for folks whose insurance, I may be able to get this, I may be able to pay for it out of pocket. I'm going to get the shot, but I'm thinking of folks who can't do that. Are states trying to get in front of that with some sort of fund or some sort of public administration of the vaccines? I'm just trying to think what's going to happen when we don't see the widespread approvals that we've had in the past.
Mm-hmm. Mr. Chair, Delegate Willett, thank you for that question. As we look to the funding, certainly we know that insurance companies can dictate what they will or won't pay for. And so as we look at the options that are there for those who wish to have a vaccine but their insurance may not pay for it, we do look at other options and resources for where that funding may come from. Some of it has come federally in the past, and some of it has come from state, and we could look at what our best resource is going forward, depending on how many are impacted.
Thank you. I don't see any more lights up, so please continue. Thank you.
Okay. As we go on with our presentation, then we're going to look at the 4 items on our agenda that we were discussed working through. So the first will be on Certificate of Public Need, and Joe Hilbert, our Deputy Commissioner for Government and Regulatory Affairs, will take this topic. Thank you, sir.
Thank you. Welcome, Joe.
Good morning, Mr. Chairman and members of the committee. My name is Joe Hilbert. I'm the Deputy Commissioner for Governmental and Regulatory Affairs at VDH. I'm going to give you a brief overview of the Certificate of Public Need program. So the COPN program is a regulatory program requiring certain healthcare facilities to obtain approval from the health department before introducing new services or facilities or undertaking capital projects above a certain expenditure threshold. VDH staff review COPN applications against a number of statutory and regulatory criteria, which are summarized on the screen. These criteria are intended to address cost, accessibility, and quality of healthcare. The Commissioner reviews staff recommendations and makes the ultimate determination whether a public need exists for a particular project. So this slide identifies the types of medical facility projects that require COPN approval. These include general hospitals and bed additions, as well as neonatal special care services, open heart surgery, cardiac catheterization, outpatient surgical hospitals, the addition of operating rooms and organ transplant services, also psychiatric facilities and services, substance abuse treatment, and some types of intermediate care facilities for individuals with intellectual disabilities. Another type of project requiring COPN is diagnostic imaging facilities and services. That would include CT, MRI, and PET. There's also a group of projects involving medical rehabilitation hospitals, beds, and services. Then we have a batch dealing with radiation therapy, gamma knife surgery, linear accelerator-based stereotactic radiosurgery. And we also have a final group of projects dealing with nursing home facilities and bed additions and nursing home capital expenditures. And for that, there's actually those applications are submitted in response to a request for applications that we issue annually in consultation with DMAS. So this slide summarizes the application review process. So the first step is a letter of intent. So this serves as public notice. The letter of intent identifies the project owner, the type of project, and the location of the project. The application is submitted. There is a 190-day application review cycle, beginning on the 10th of each month. If the application is determined to be complete, it's accepted for review. If it's not determined to be complete, the applicant is given the opportunity to complete by the start of the next appropriate cycle. There's a public comment period. Public hearings are optional, and public comments are accepted by email, mail, fax for 45 days. Our staff in the Division of COPN provide a written analysis of each request based on the 8 required considerations that are in the code with a recommendation to the commissioner. Any recommendations for denial, along with those formally challenged by other parties, are heard at an informal fact-finding conference by a VDH adjudication officer, who will also make a recommendation to the commissioner. Approval of COPN applications are conditioned on the applicant's agreement to provide a specific level of charity care to indigent patients and to accept patients with Medicare, Medicaid, and TRICARE. I would also note, Mr. Chairman, that the last session, the 2025 session, you enacted legislation requiring the department to establish an expedited review process for certain psychiatric facility expansion projects. This slide shows some trends in terms of the numbers of COPN letters of intent, applications, and decisions over the past 10 years. During the pandemic, many capital projects that would have sought COPN approval were put on hold by health systems, hospitals, and others. And when the pandemic started to ease, those projects started to resume, those applications resumed. That's why you see that big spike going from 2022 to 2023. There was a result, was an increase in decisions made that year. Chairman, the last slide that I have is dealing with the State Health Services Plan Task Force. This was created by the General Assembly and tasked with recommending revised criteria for COPN reviews. This is comprised of a number of volunteers from various aspects of the healthcare sector. Task force first met in February of '24. The task force has now implemented a committee approach to tackling the various types of facility service categories. We find this approach is functioning smoothly and providing good momentum. We anticipate completion of recommendations for the State Health Services Plan by July of 2026.
Mr. Hilbert, I know I probably voted for this bill, but I hope you did. But you know, if if there's no services in remote, rural, or medically underserved areas, there shouldn't be a need for an expedited process. That's the whole point, is to find out whether it's, if it's underserved, why does it need extra help? That's what that should be rubber stamped and allowed to happen. So I guess that was a bill that is going to be on someone's brochure, I guess, but I don't know. I don't know how it's going to help a lot, because those things should go faster. And same thing with the psychiatric hospitals. I mean, if we need more services out there, I can't imagine you turning one of those down if somebody wants to do that. I mean,
I believe Eric Bodine is here, can help me answer this question, but we have denied very, very few of those ever.
Yeah, of course. Yeah, thank you. Okay, just wanted to clear that up. Yes, Delegate Hope.
On that, your last slide that you had with the graph, do you break those down to the different categories of applications or decisions that come in by, what was the request was? I'm talking about the last slide before with the graph and the spike. I'm curious if you break that down by categories that people are coming in asking for a COPN, and also which ones were approved and which ones were denied. Could you get that information to us, or do you have that?
Yes, Delegate Hope, we can absolutely get that information.
Thank you.
Thank you, Delegate Hope. Delegate Walker.
So, Mr. Chairman, I don't think that's going to be included in one of my brochures as far as the COPN bill.
Well, you need all the help you can get, delegates. You might want to use it.
We'll discuss that after this meeting here, sir, how you can help me. But, I think the intent of the bill, when we refer to as a desert area, and I do appreciate your statement about why do we need more regulations when we're trying to serve a very needed area. And certainly there's a lot of challenges when you get out west of my area here. I am glad to see in this slide right here that there's only been a very few, apparently, applications have been denied here. We're just trying to make the process smoother, more efficient as far as operating and getting in a timely manner the medical needs that people have in certain areas of the Commonwealth here. So that was part of the intent of my bill. And Mr. Chairman, I think you did vote for that. And if you did, I do appreciate that. And hopefully we can continue down that path.
We found out whose bill it was now.
I'm sorry?
We found out whose bill it was.
Well,
yeah. Very good bill.
I enjoy this committee. I think it's a great committee, and it does a lot of great things.
Well, I'm glad two of you showed up from the other side to participate in this.
Well, that was not the intent of being here today, Mr. Chairman, but I think we do accomplish a lot of good things here.
Thank you.
Thank you, Mr. Chairman.
We appreciate your very active participation in this committee, seriously.
All right. Thank you.
Give me 5. Okay.
We're going now.
Mr. Hilbert, please continue.
Mr. Chairman, I just wanted to clarify my one response. In responding to, I think, what you said about the psychiatric facilities and the expedited process, when I said we've rejected very few of those, I was referring specifically to the psychiatric projects. The other aspect with the medical deserts, which, again, the General Assembly tasked this task force to examine, we're still looking at that, figuring out how to actually operationalize that within the program. That completes my presentation. I'm now going to turn it over to our Chief Operating Officer, Christopher Lindsay.
Mr. Lindsay.
Mr. Chairman, members of the committee, thank you for having us here today. Excuse me. I'm going to speak to you this morning on the Office of Emergency Medical Services. So I'm going to slide forward here. Again, I'm speaking to you today as the Chief Operating Officer of the Virginia Department of Health, but I'm also speaking to you as a longtime provider of emergency medical services here in the Commonwealth. I've been an EMT in Virginia since 2006. I've been an ALS provider since 2013. I've been active with the Tuckahoe Volunteer Rescue Squad in Henrico County. I rode just last Wednesday night. and I've been a member there since 2009. So coming into this role at VDH, there was a tremendous amount of opportunity, I believe, to have some impact across the agency, but specifically what we uncovered and then have had the opportunity to correct in the Office of Emergency Medical Services has truly been a passion of mine, and I'm proud to be a part of this team. You may recall just over 2 years ago, we started a new budget process looking at all of our offices across the agency. In one of those particular meetings with the Office of Emergency Medical Services leadership, one question led to another question, which eventually led to $33 million of misappropriated funds, including over $4 million that was fraudulently sent through a former assistant director's private company and has led to him being in federal prison. And so it unearthed an incredible amount of opportunity to look across the leadership structure and across the office structure to not only have a better performing office, but set up a better structure for emergency medical services to providers all across the Commonwealth. What led to that? A lot of different things, but I wanted to put a few highlights on the slide here today. A lot of disregard for state procurement processes. Direct contracting outside of state procurement was one of the significant issues in which you all and the governor, of course, are very instrumental in helping us to correct that over the last 2 years with the appropriation of the $12.5 million for the last 2 fiscal years that traditionally is special revenue that reverts back to the general fund. We've been able to use that to make substantive progress towards correcting the sins of the past. I do want to highlight our new Office of EMS Director I have here today, Dr. Maria Bierman-Fote with us. She's just the 4th Director of EMS in the state of Virginia history, and so we're excited about her new leadership. Along with that, we've got a nearly fully new leadership team in the Office of EMS. 4 of the 5 senior-most EMS leaders in that office are new. We have made some incredible strides across the business of the Office of EMS. We created and implemented a dedicated business manager to oversee the finances of that office. We've put new practices around the 4 for Life program, and again, that's the special revenue that comes from the DMV into the Office of EMS, particularly around the Return to Localities and the Rescue Squad Assistance Fund. Return to Localities is a percentage of that 4 for Life that goes directly back to localities across Virginia to use towards EMS in their home communities. And then the Rescue Squad Assistance Fund are grant programs that agencies across the Commonwealth can apply for and to fund such things as equipment, ambulances, and other approved items. We've worked to redesign the trauma fund and move that from a once-a-year payment to a twice-a-year payment. We've put a lot of transparency around that, so every hospital, when they get their funds now, can see exactly how we calculated their payment and exactly how we calculated every other hospital's payment across the organization. Yes, sir.
Commissioner, is that fund funded well enough now?
I believe the model for the 4 for Life program is somewhat of a stagnant model. It was developed years ago. It does not allow for inflation. It is a set dollar amount in code, and so I think that's something that we would welcome the opportunity to discuss.
And the trauma fund, is that the same?
Trauma fund is not part of the 4 for Life.
Okay.
It is similarly funded, though. It is special revenue that comes from the DMV, and that is penalties for reinstated licenses.
But when we changed the law on the driver's thing, it cut into that fund, and we haven't backfilled that funding, right? And my question is, do we need to?
There was a reduction in that trauma fund, yes, sir.
And so you're going to not give me a value judgment on whether we need to have more funding in there in the trauma fund?
I believe that trauma hospitals across the Commonwealth would appreciate the opportunity to have that conversation.
That's a good answer. That's true. Okay.
Again, we worked towards internal restructuring, put in a new leadership structure, and completely redid the org chart in that office. 2 of the things that we're really working to do are greater alignment of the Office of EMS into the overall public health functions across the Commonwealth, and I'll get to more of that in the next slide, as well as reimagining the EMS Council system. I'm happy to say, because of the efforts of a lot of different folks at VDH, as well as funding from this body and appropriation through the governor's budget, we entered FY26 at a budget neutral standpoint, which is an incredible accomplishment, and I'm very, very proud of our team from doing that. We've worked very closely with the EMS stakeholders across the community. We have worked very closely with the Governor's EMS Advisory Board. The chairman, Kevin Dillard, has been a phenomenal leader in that effort. We redid a lot of the way we did the Rescue Squad Assistance Fund, and we were able to move funds into that, increasing some funding, particularly to some of the casualties of the sins of the past. I'm thinking about the way that the technology for the EPCR program that providers used, we were able to fund part of the Rescue Squad Assistance Fund directly to that. We were also able to move some of the Rescue Squad Assistance Fund towards some of the pharmacy challenges that providers across the Commonwealth have encountered over the last 2 years with hospitals moving away from that program. We've put much more transparency around the Return to Localities dashboard. We created that so that any locality can go onto this public-facing dashboard and, again, see exactly how much money they are owed and exactly how much money every other community across the Commonwealth is being allocated. And, again, we've looked at the regional council infrastructure. You may recall there was a budget item in this past year that removed the stipulation that there be 11 EMS councils and removed the stipulation there be no changes to the geographic boundaries. We made that decision hand in hand with stakeholders across the Commonwealth. We worked with the presidents of the existing 11 councils, worked very closely with the Governor's EMS Advisory Board. A work group was created out of that we met regularly with. And so that was a decision made as a community that this was the way that we needed to go. Beginning January the 1st, 2026, we will reduce from 11 councils across the Commonwealth to 7 councils across the Commonwealth. And I'm going to go to the next slide that will give you much more detail around that timeline. The map on the left is the current EMS council system in Virginia. There are 11 councils, and they're denoted as you see here, and they've been like that for decades and decades. Beginning January the 1st, 2026, we will transition to the map on the right. What's key about the map on the right is it reduces it to 7 councils. But we made the boundaries align for 2 different reasons. One, with the current healthcare coalitions, so the way that we fund emergency preparedness with our healthcare partners, we also created the boundaries based on current VDH health districts. I talked a minute ago about alignment with VDH. We want to make sure that the EMS councils, we will see them going forward as a direct extension of the Office of EMS. We want to make sure that they are partnering with VDH localities, with our health districts and health district directors. In fact, just this week, we had our new EMS director on a meeting with all of the health districts across the Commonwealth, introducing that idea and a commitment to go forward to work for greater alignment of EMS and public health across the Commonwealth. We did a 6-month extension on the current EMS council designations. We are going through a formal RFP process that has not been done in the past. It is posted on EVA. It's open and live right now. It closes August the 14th. And so any of the existing councils, as well as other organizations, have the opportunity to bid to be the council of record for these 7 new geographic boundaries. We'll make that decision here in the fall. We are inviting localities, whether that be representatives of the Fire and EMS Service, whether it be municipal leaders, to participate in the panels judging the councils of record for their home boundaries. And then again, beginning January the 1st, 2026, we will begin with 7 new councils across the Commonwealth, and we're very excited about that. I just want to touch one more time on the alignment of VDH. Traditionally, the Office of EMS seemed to operate somewhat outside of the bounds of VDH. And so not only from a compliance standpoint have we brought them into the fold, but our leadership team is very involved in the business of EMS. And I think operating the council as an extension of the Office of EMS, and by that an extension of VDH, will have much greater alignment in public health and EMS services across the Commonwealth going forward. And that concludes my slides, and I'm happy to take questions.
Thank you. Since you're up here on a different topic that you're involved in, we have our own auditing unit in the legislative branch, Auditor of Public Accounts, and they've had a hard time getting a clean audit from VDH, and they're going to work on it again this year. And all the you made a lot of improvements. Agency had Dr. Shelton, you responding to the JLARC study. I mean, you worked on that list really well, but we still can't get a clean audit yet, and we're hoping for that for next year. What do you think our chances are?
I think our chances are improving every day. And John, correct me, I believe APA is with us right now. So they are in the building, actually, as we speak.
Okay.
And we're excited about that. I do. And
I bet.
Now, to your point, we have made some incredible strides, and I would ask you to allow me to highlight one win that we had recently. I know Deputy Commissioner Dunkel is going to highlight this a little bit more in her slides, but I'd like to take the opportunity to do right now. In September of 2022, This was just prior to I came into this role. The EPA, Environmental Protection Agency at the federal level, which they give us about $100 million in annual grants. They put VDH on what's called reimbursement. What that means is the state of finances in the agency had become so dire that they did not trust the agency to take the money up front and then spend it and then draw down. So what they did is put us on reimbursement, which means you have to spend your own funds. We had to spend general funds and other dollars and then apply for reimbursement on a line item expense to the EPA. And you can imagine on a $100 million grant, that is a lot of work on our end and a lot of opportunity for them to look at it with a fine-tooth comb and find an incredible amount of detail where things could have gone wrong. Just after I started in this role, Dwayne Roadcap, who I'm sure that's a name you all recognize, as our Director of Drinking Water for the Commonwealth. I often refer to him as the hardest working man in Richmond, at least this year. And one of the things he told me is that we've got to get off reimbursement. Not only does it hurt our credibility, but it allows, it adds an incredible amount of work to our team and our financial management team. And so this leadership team really committed to making that happen. And so we put the program staff and the finance staff in a boardroom every Monday afternoon at 4 o'clock until we started to see substantive strides. That moved to every 2 weeks they were in there. And now we're at every month. About 6 months ago, we created a plan and we wanted to be off reimbursement by June the 30th. And John Ringer, our CFO, and I both communicated that to the EPA leadership. And just last week, July the 1st, they communicated to us that they are so happy with the work that we've done to change the way that we manage grants in the Virginia Department of Health that they have taken us off of reimbursement. This was, I referred to it as bumpers when you're bowling. It allows you to stay within the lanes and not make mistakes. The bumpers are off, and we've applied those same lessons across the entirety of our grants management at VDH. And we're really excited about that win and super proud of our team for making that happen.
Okay, terrific. Are there any questions? Oh, I have Delegate Cohen.
Yes, ma'am.
I would be uninvited from this. Thank you so much, Mr. Chairman. And thank you so much for this presentation. My question was, this year in our own locality, we saw as a cost-saving measure, putting not just ALS, but BLS on the chopping block. And so, as you know, that creates these huge deserts for any kind of emergency response. And so I wondered, first, are you seeing this across the Commonwealth? And two, what can we do to ensure that localities don't continue to put these essential services on the chopping block, even as they're continuing to lose federal money?
Yes, ma'am. Mr. Chairman, Delegate Cohen, thank you for that. And I appreciate the question because it is super timely. And we're seeing that occur in communities, across, particularly in Southwest Virginia. Dr. Bierman-Fote and I had the opportunity maybe 3 months ago to spend a couple of days in Southwest Virginia. We visited Lee County and Scott County and multiple areas out there. We were in Wise County, we were in the city of Norton, and we were meeting with agencies that are having this very conversation. In fact, we were in the Pennington Gap Rescue Squad the day that they, I believe, were going to vote that evening to remove one of the squads from that. And so we are seeing that. One of the things that we're looking at is, of course, Delegate Sickles, from your question around the 4 for Life funding, that funding is meant to enhance services. It's not meant to be the basis of providing services in a community. That is a function of a locality. But what we can do as a state agency is to help them almost consult on how are they providing services in the county from a cost-effective standpoint, from a leadership standpoint. How can we take best practices in maybe Chesapeake or Virginia Beach and share that across the Commonwealth? And we've shared this in our EMS Advisory Board meeting, some of these exact conversations. And we've had leaders across the state say, hey, we're willing to go help some of these localities to consult through their problems. So that's something we're very interested in doing, and I appreciate your question and happy to talk more about that another time.
To follow up a little bit, a lot of these, I'm told, and I've talked to some rural fire chiefs, and they can't afford to buy a truck or an ambulance. They just way out of their ability to fund, and have come to us for some help. And so far, we haven't helped them yet. And we have done some money for some emergency radios in some really rural counties on a one-off situation, but I don't expect you to answer this question, but it's something that the whole Commonwealth needs to look into on how we handle that. It's got to change somehow.
Delegate Sickles, to your point, the cost of doing business across the board has gone certainly high, but in emergency medical services, what, an ambulance may have been 150 to 200,000 just a few years ago. Throughout the COVID experience, it has gone close to $500,000 for a fully outfitted ambulance. And you can imagine that that is quite an expense on a locality.
Right. Thank you. Delegate Cohen, you finished, right? Okay. All right, thank you. Thank you so much for your testimony. You have more?
I'm going to introduce Dr. Susan Fisher-Davis. She's the deputy of all of our health districts across the Commonwealth, and she's going to speak to you on the next topic.
Thank you so much. Welcome.
Thank you. Thank you, Christopher. Good morning. Delegate Sickles and committee, very happy to be here and talk to you a little bit about some core public health work and epidemiology, which is housed at the central office at the Virginia Department of Health and the local health districts. And I want to give you some examples of what we do in our communities that really nobody else is doing. So these are some of our core priorities. Let's see. All right, let me see if I advance aside this one. Sorry. Thank you. So one of the core things that we do at the Virginia Department of Health is keep track of diseases that are reportable to us by law. These regulations for disease reporting and control describe what diseases must be reported, who is required to report, and how the report should be submitted. And on this slide, you can see a list of the reportable diseases in Virginia. I want you to note that some diseases that are listed on the left are reportable immediately because they are considered to be a public health risk or highly communicable, and the diseases and conditions reported on the right-hand side of the list are needed to be reported to us within a certain amount of time. So I just wanted to bring your attention to measles, which I'm sure you all heard about. That is a condition or a disease that is reportable immediately upon detection or diagnosis. The Virginia Department of Health also maintains robust public health informatics programs and data management systems. These systems collect disease, and we track things through these systems. And in state fiscal year 2023, to give you a sense of the breadth of what we are collecting, nearly 156 million electronic messages flowed through the Virginia Department of Health. These messages come to us through multiple surveillance systems, including a cancer registry, electronic case reports for the reportable diseases on that list that I just showed you, electronic laboratory reports, and immunization case reports, just to mention a few. On average, the Virginia Department of Health surveillance system manages over 50,000 reports in a given day. The disease surveillance systems and informatics teams that I'm describing here are over 90% federally funded. These systems are maintained at both the Virginia Department of Health Central Office of Epidemiology and through our Office of Information Management, and are extensively used in the districts. I wanted to give you an example of what happens when we get a disease report at the Virginia Department of Health. As I noted, these diseases are reportable by law, so we will hear about diseases through providers and through some of our surveillance systems that I mentioned previously. Upon receiving a report of a disease or suspected disease or an outbreak, district epidemiologists, in concert with epidemiologists that are at the central level, begin the investigation process. They interview patients with suspected reportable conditions and people potentially exposed or contacts to that patient. They gather information from healthcare providers, and then they will classify and confirm and report the disease to the Centers for Disease Control to assist in monitoring of trends at both the state and national levels. We also coordinate with other jurisdictions and other districts to manage the disease outbreak or case, and other state agencies as well. And to give you a sense of the scope of that work, in calendar year 2024, VDH conducted nearly 1,600 outbreak investigations. I mentioned measles as a rapidly reportable disease, and I think you're all probably aware of the resurgence of measles in the United States this year. This graph shows the measles cases reported in the U.S. from 2020 through July 15th of 2025. And as you can see, in 2025, we've had an unprecedented amount of cases or number of cases reported to date, with nearly over 1,300 cases reported nationwide. In Virginia, we've had 3 cases of measles reported. And I just wanted to bring your attention to 2 cases of those. 2 of the 3 cases were reported in the Blue Ridge Health District. And to give you a sense of the scope of work that occurs when we get one reported measles case, we obviously need to look at potential contacts or people who are exposed to that disease. And that is part of what our epidemiologists do in the districts and in the central office. For the first case of measles that we had reported in Virginia and Blue Ridge, we have had over 300 potential contacts to that case. So every one of those contacts needed to be notified, investigated, and followed. In the second case, fortunately, we only had about 10 contacts, but you can see the variability in the amount of work that would go into a potential case. You're probably also aware that in the United States and in Virginia, there has been an increase in the number of syphilis cases. In fact, we've experienced in Virginia a 14% increase in the number of syphilis cases between 2018 and 2018. And to date, in Virginia, we have had 728 early syphilis cases reported. What I'm showing you on this graph are not all syphilis cases, but all congenital syphilis cases that have been reported to date. Congenital syphilis occurs when a mother passes syphilis infection from herself to her infant during pregnancy or delivery. And you can see the number of congenital syphilis cases has increased significantly over the last 5 to 10 years. With a total of 35 congenital syphilis cases being reported in 2024. And year to date in Virginia, we've had 17 cases of syphilis, so we are on track to meet or exceed that level this year. There have been multiple initiatives throughout the state to address the syphilis epidemic. One of the most notable is in the eastern region, where the local health departments are partnering with academic partners and local community partners to initiate a Stop Syphilis campaign. And I've been down there twice related to that campaign, and it is very successful in raising an enormous amount of awareness in their community about the syphilis epidemic. I wanted to take just a few minutes to talk to you about clinical epidemiology in the Department of Health. The central office program supports both districts and community health partners through many of their programs in the clinical epidemiology group. Some of those partnerships include relationships with community partners around healthcare-associated infections and antibiotic resistance. At the district level, one of the biggest supports we get from the clinical epidemiology program is through our TB program. This is one of those things that I talk about frequently. What do we do in our communities that nobody else does? A lot of that centers around TB control and prevention. In our districts, we have robust tuberculosis prevention programs, and we case manage most of the TB cases that occur in the state of Virginia. Like syphilis and like measles, we have seen an increase in the number of TB cases over the last several years. In immunization programs, this is one of our core public health services. We function at all kinds of levels in immunization throughout the Commonwealth. I wanted to bring you attention to this landing page on our externally facing website and talk a little bit about the immunization record request program. For Virginia residents, we have a secure access to a portal that allows any Virginia resident to go through a HIPAA-compliant process of securing and seeing their own vaccine records. That's something that we maintain here. And the other thing I wanted to mention is a new platform, or a recently enhanced and newly launched platform, our Virginia Immunization Information System platform, which is a statewide registry that combines immunization history for persons in all ages from both the private and public healthcare sectors across Virginia. These are systems that are used heavily by both our health department personnel and by people in the communities. In the Office of Epidemiology, they have an infrastructure that allows the Virginia Department of Health epidemiology team and the districts to conduct STI surveillance, prevention, testing, and treatment of reportable sexually transmitted infections. The central office also assures support to districts' clinical services through providing clinical guidance and funding and resources to local health communities, partners and also to our local health departments. And with that, I'm happy to take any questions. Just wanted to give you a quick overview. In the interest of time, I can't cover everything.
Great. You've got a big job, and I'll just ask you one before anyone else puts their light on. But I was going to ask quickly about the funding situation. Have you had grants that have been have disappeared in this little bit? Epidemiology. We get grants from the federal government to cover your office, correct?
Yes, so I'm over community health services, and the majority of the funding in community health services is actually state funding, revenue, and the local match. That's our primary source of funding at the locality level. I would say estimate approximately 7 to 10% of our funding at the local level is through federal grants.
Oh, okay, so it's the local level that gets the federal grants.
No, the federal grants come into the Office of Epidemiology.
Mr. Chairman, if I may, Stephanie Dunkel, Deputy Commissioner. To your question, we have received and talk with our project officers in the Office of Epidemiology regularly and anticipate receiving our awards. We've been told that and received partial awards, which are not abnormal for us this time of year. So we have been receiving our funds.
So they're not behind at all?
It's not behind. What we receive are partial awards, which that's happened in many grants over the years.
Okay, terrific. Delegate Hope.
So asking, since this is sort of a boot camp to understand the vaccine process for kids, there's the requirements to go to school, and then there's an exception, and I'd like some information on the exception of how much that is being exercised or approved for the kids, and then the adults as well too. I think there's separate processes, and so maybe it'd help the committee to understand both processes for approvals for new vaccines to be put on that list.
So I think there's two questions there. One's exception, and one is the approval, the vaccine approval process.
That's right.
So I can't speak fully to that, the vaccine approval process that occurs at the federal level. And the vaccine recommendations that we get for the Virginia Department of Health are usually coming down to us through the Advisory Committee on Immunization Practices at the CDC, but we also look very closely at the guidance that we get from the American Academy of Pediatrics and the American Academy of Family Practice. So that approval process comes before us, but we look at the data to make decisions about our recommendations here at the Virginia Department of Health. So.
And Mr. Chair, if I may, what I'm trying to ask is because for the children, there are specific criteria related, and there's all these different vaccines that are already in statute.
Right.
The process being that when there's a new vaccine that's approved by the federal process, that will be directed towards Virginia, and then there's a regulatory process that is triggered after that. And I think I want to understand that aspect of it and make sure all the committee members understand that aspect of it. But then there's also the adults. And the reason why this is important and where the state comes in is that if you're low income and you can't afford those things, what's that process like? What's available? I know it's so different between adults and different between kids, and I want to make sure everyone understands that there's these two, they're kind of apples and oranges. One's more voluntary, and the other one is required. And then, but the thing that when you say required, there's an exception, and the exception relates to there's all kinds of different, maybe religious reasons, there may be health reasons. I'd like to also understand how often that is being exercised. Meningitis is a good example. Mm-hmm. That's one of our newer ones that we've put into statute that's required for kids. But we're also seeing an increase in meningitis. And so is it because it took us so long to do that we're seeing that? I know it's a nationwide thing. And also the exceptions are people opting out or opting out, and that's why we're seeing an uptick. You mentioned hepatitis, or not, with syphilis, I think it was.
Well, for vaccine preventable diseases, I presented measles.
Measles, yes. That's right.
Yeah.
So you're seeing an uptick in some of these things, and I'm wondering, is it related to our inability to react to some of these things and making sure that people are vaccinated? And does our policy have some weaknesses? So anyway, so there's a lot there, but I just want everyone to understand that we have a statutory process that's in place, but there's also a regulatory process as well. And it's different for the kiddos and different for adults.
So I'll let Dr. Shelton speak to this some as well, but we do know that our vaccine coverage rates decreased during COVID, and we are trying to recover from that. So that may be playing into part of the answer to your question, but I'll turn it over to Dr. Shelton.
Okay, we've got 3 more delegates in line here. So Dr. Shelton, you want to make brief comments on this?
I'm happy to. It's complicated. So the regulatory process, we only have mandated vaccines for schools, for school requirements. For adults, there are no mandatory vaccines. Sure. So ACIP, through its guidance, does then determine who gets the vaccines for children, and that's the program you spoke about. Which vaccines will they fund to have free vaccines for children? And so we do keep a close eye on that, because that is federally funded then to have the Vaccines for Children program, which we are very active in Virginia on that. If vaccines are taken off of that, and we still want to offer that, we would have to look at other funding resources. When it comes to adults and vaccinations, these are decisions, there are recommendations available and decisions made with the healthcare provider. Things such as meningitis are relatively newer in their vaccine history than things like such as measles, which have been here for decades. So as far as things like meningitis per se, so one of the required vaccines for colleges is one certain meningitis vaccine, but there's another one, there's 2 meningitis vaccines, one is recommended. It gets very complicated in the details.
Okay, we have Delegate Tran, then Delegate Price, and Delegate Willett. Delegate Tran.
Thank you. I just have a follow-up question on the earlier conversation and this one on vaccinations. I mean, I was just on your website, and I think earlier you said, that you, my understanding is to continue to make information available for folks to read and make the best decisions for their families. I just want to point out, I mean, I'm on your website now, and you're referring folks to the CDC, and quite frankly, I'm concerned about the politicization of science and data that is being used to drive misinformation around vaccinations, right? And that's really going to harm our kiddos as they're heading into schools, and also our adults and seniors as they are trying to figure out and navigate. Can you let me know, is VDH undergoing any efforts to proactively inform families about MMR vaccinations and the safety of that, and the need to continue to vaccinate against measles?
We do have a communications campaign. Specifically, we have a back-to-school campaign, which will be coming out very soon, whereby we talk about vaccines and the importance of them, particularly in the school setting, and how that can help to immunize the whole community. When it comes to vaccine information and disinformation, that has been a difficult topic over the last several years, from the advent of the COVID vaccine forward through COVID pandemic and where we are today. We actively monitor the science of what is most important as far as our decades of research for certain vaccines and then newer research for other vaccines. And we'll be having to assess the impacts as they come down to make sure that we are giving the best scientific information possible going forward.
Delegate Price.
Thank you. I had 2 questions, Mr. Chair.
Yes, ma'am. Please make
one. When you were talking about the disease surveillance system, you mentioned a percentage of your federal funding. Can you repeat that? As you were going through one of your slides, you said that there was a percentage of your disease surveillance systems that was federally funded.
So I think I mentioned through Community Health Services, I was talking about our funding at the local district level.
That was in response to Chairman Sickles' question.
Yeah.
When you were going through your actual slides, you mentioned disease surveillance systems were federally funded at a particular percent.
I know what you're referring to. Yes. So the public health informatics and data management systems, I think you're referring to, 90% of those are federally funded.
Okay. And my second question, Mr. Chair. Since we're on the slide for HIV and STI, I'm hearing from numerous community partners whose funding for HIV and STI surveillance, prevention, and treatment has been absolutely slashed from the federal level. So if your grants are coming through and you're getting your funding from different services, what is your plan to partner with the agencies that might have a better reach than the VDH or, sometimes people don't necessarily trust governmental systems, but they might go to a center that's around the corner that they know looks like them, feels like them, that sort of thing. And just understanding that kind of an announcement of information versus actual outreach is different. So I'm asking specifically about outreach into communities where those services may have been depleted.
Happy to take that question. Thank you. Yes, we've had stable funding from the federal funding. So there are different parts to the Ryan-White or federal HIV funding. We, through the VDH, administer Part B. There are other parts that go directly through localities and for other different reasons. A large part of our funding for our HIV services and work is done through rebates, which are part of the manufacturer rebates. We have had a decrease of those over the last couple of years that has significantly impacted the funding. So we have been working to make sure that we have regional coverage for HIV services throughout the Commonwealth. We will be working further with our stakeholders going forward to make sure we are looking at more comprehensive HIV care. We have focused really on the medical services and the medications for people. In the past, there has historically been a lot of other services that are wraparound that are proven to be best practice to help make sure that there is better prevention for HIV and better care for those with HIV. And so as we look as a Commonwealth, as a whole state, we will want to be working with our stakeholders a little bit more in light of the funding changes to see what will be the best approaches to make sure that people do understand where the best places where they can receive their care and how we can make sure we are having comprehensive care.
Mr. Chairman, just one last question then.
Delegate
With
Price.
that answer, is there a specific contact that I can give some of these organizations so they can reach out to make sure that they're considered a stakeholder for the work that they've been doing over the years?
Let me make sure that I will send you the appropriate name for that contact.
Thank you.
Madam Commissioner, I think there's also an issue with 340B prices on HIV drugs, particularly from Gilead pharma company, that if the FQHC or the free clinic is not qualified, they're not getting their 340B price, which has been real important to some of these HIV services providers, I think. Delegate Willett.
Thank you, Mr. Chair. I'm going to come back to the COVID vaccine question I was asking earlier. I was focused on the funding part of that, and I appreciate your answer, the Commissioner's answer. I forgot to ask the threshold question. So CDC says that only these very limited groups of people are eligible for the vaccine. I know there are doctors out there that might, what they call it, go off-label and try to prescribe. But can you, as the Commissioner, say, I think these other groups should have it and authorize that? I mean, who can authorize, besides the CDC, who can authorize the shots?
Vaccines come as recommendations. Authorization has to do with payment. So that would be two different kind of questions. So the insurance companies get their authorization from the federal entities. As commissioner and as healthcare professionals, we can communicate with our clients what the recommendations would be for them based on their healthcare parameters.
Mr. Chair, just make sure, I'm not trying to be dense on this. So if a constituent who's 27 years old, CDC is saying we're not recommending shots, or I guess you're saying authorizing that, put aside the insurance part, just to go to the pharmacy and get the shot, you have to be approved at some level. It has to be a medical, doesn't have to be a medical. What I'm reading is saying you need some sort of medical approval for that.
At this point, I would have to go to the pharmacy and see, but if people would like to get a vaccine, they can go and request one.
Okay. I'll follow up on that because I was getting a different answer.
Thank you, Delegate Willett. Delegate Cole.
Thank you, Mr. Chair. Following up what Delegate Price stated about the Ryan-White program, and I just have a question if you could help verify the information. I'm being told from different organizations within my district that I'm glad to hear that we're receiving federal funding, but there was a problem with the rebate program which is causing people in the Commonwealth of Virginia to lose services in the Ryan White program for the funding to be slashed there. So that's not a federal funding problem. I'm hearing it's a state problem. If that is a program that we are losing funding due to a rebate program, what can be done to help these people? Because if they're on the Ryan White program, these are low-income people who need the services. And so if it's a problem that the state has done, why are we penalizing these people because of something that we've done? Can you verify if it's been a problem there, or what is the situation happening?
So we've received our Ryan White funding from the federal government. As I stated, though, we are looking at the rebates are voluntary from the pharmaceutical manufacturers. They can decide what are the reasons that they give rebate and how much rebate they give. There has been a general decrease over the last year with the rebates, and so as we are assessing that decrease and looking to see what the impacts are, this would be the work we would have going forward with our stakeholders and what other funding resources may be available in the future, depending on how this all settles.
Thank you, Mr. Chair.
Okay, Delegate Cole, we can follow up on that. This is a complex area, but we need answers to this stuff. I apologize for my contribution to us being 45 minutes late so far, and Dr. Fisher, thank you. And we'll get back to you if we have any more questions. And we have our next presentation is going to be on water quality, which has been very topical this year. The responsibility of the Department of Health. And if we could, hi, thank you. Could you reintroduce yourself, please?
Absolutely. My name is Stephanie Dunkel. I'm the Deputy Commissioner for Population Health and Preparedness of VDH and oversee the Office of Drinking Water.
Okay.
Yeah.
How's your year been?
I'm good. Yes. Well, in my first year here, water is my middle name. I'm going to cruise through this, but I know there's been some comments about water this morning, so I'm going to share with you about how the Office of Drinking Water assures clean and safe drinking water for all Virginians. So kind of the backstory and the regulatory function of how we work. All right, so the Office of Drinking Water employs 121 classified employees across the Commonwealth. We have 6 field offices and 1 central office. So this is a state office that has tentacles out into the community that serve all of your communities, and those field offices work with close to 2,900 waterworks. Waterworks that we serve and regulate in the Office of Drinking Water are public water systems. They come in large and small, so I'll talk a little bit about large systems look like Northern Virginia, Virginia Beach, Richmond, to the small water systems that serve restaurants or schools. We serve those public waterworks in Virginia so those 2,800 serve roughly 3/4 of the population of Virginia. So as you can imagine, the remaining are private wells. And private wells, we have a program in our Office of Environmental Health Services, so we work very closely across those offices. Our Office of Drinking Water sees around 110,000 samples of water. So many of you have heard about boil water advisories. Have you gotten the sample? Have you gotten the sample? That equates to these water samples that are part of the permit that they have to do regularly. We provide technical assistance daily. And we do issue, through our regulatory mechanisms, notice of alleged violations, consent orders. There is a mechanism for those if there are violations that continue. And we are also 24/7, as many of you know. So as you can see here, we actually are the lead for the Emergency Support Function 3 in the Virginia Emergency Support Team. So in the VEST with VDEM, we support this and lead this effort. And that includes all things flooding to water outages to damage to you name it. Here's a little bit more about our funding. So Office of Drinking Water is both state and federally funded. A good portion is federally funded through the EPA. These are our core areas of funding right now, and this supports our operations, so a lot of our staffing, sampling, things like that. We also have infrastructure funds. We have several buckets of money that are $100 million or more, pending the timeline or amount of money, so up to 5 years, that include bipartisan infrastructure law funds. The DWSRF funds you see up here also have infrastructure money. We also received $100 million here in the state through ARPA money, and then recent allocation of funds for water infrastructure in the last session that we're also distributing out to waterworks. And these infrastructure money, what it means is we run construction permit. People submit for construction to remove lead pipes, any technologies that they need, an upgrade system. So we have a large and robust construction work program team and work closely with the waterworks in that area. And we have more than enough requests than we have funds. very much. So on average, about $75 million out the door. We will expend all of our ARPA funding by the end of this year. Here's a little bit about our program. So it's about just shy of $16 million to fund the staff and operations of drinking water. This does not include the $1.8 million we received this last session, so thank you for that. That will increase our staffing by roughly 16 individuals that are absolutely needed across the Commonwealth, so we will work to staff across those field offices for the increasing waterworks infrastructure, but also just the increasing and technical assistance needs that we get daily. So I spoke a little bit about those large to small scale waterworks. These are what they're called, terminology, you'll see this out there, but a little bit about these just for your context in the communities that you serve. A community water system serves at least 15 service connections for year-round residents, or regularly serves 25 year-round residents. A non-transient, non-community water system serves 25 of the same persons over a 6 months period over the year, and a non-community water system regularly serves 25 non-residential individuals during at least 60 days of the year. So that's where you see campgrounds, marinas, wineries, things like that. All right, water. Water is everywhere. We have a focused function here with that water treatment. So I wanted to share with you, as all the events that we've navigated, we work very closely with our friends at Department of Environmental Quality on the water sources. So number one, surface water areas where water comes into the water treatment plant. And then we have a function in regulating number two and into number three. So this is just a picture of how things flow. And this is very much a coordinated effort between multiple state agencies when there is an issue or an emergency. And challenges. So many of you are aware of this, and just want to share a gratitude for navigating many emergencies over the last year and sharing constituent concerns and needs for us as we've navigated them. But as the Emergency Support Function 3 lead, we have a role in those emergencies regularly, and they can be as small as that small pipe break that requires boil water advisory due to low pressure. But up here, you're going to see a few things. So the lower left picture is a buried water line that's got a small leakage.
Back up one slide.
Oh, no. Pictures are important. There we go. So that bottom left there is the small leakage from an aged pipe. The bottom center is a leak from a very large distribution main that caused flooding, so kind of your water main break that you hear about. You also see in the top left harmful algal blooms. So this is happening, algal blooms on the surface water side, of which then our drinking water team pays attention to as those come into the water treatment plant and work with our waterworks. Upper left is around lead, so eliminating lead in our drinking water and contaminants like lead. Drinking water systems have made it possible in the last 20 years for improved public health. There has been a lot of incidents nationally and here locally that break confidence and trust in the public, and we take that very seriously, and it's part of our mission and communication, and work really collaboratively and closely with these waterworks to assure safe drinking water. And I want to share that our drinking water team is incredible. I've gotten to meet with them, the Southwest team who responded to Hurricane Helene and worked 24/7 and worked with that waterworks system to get them back online as fast as possible, and want to thank them publicly. They do a lot of work, and that's my presentation.
Thank you for that. I don't see any lights on for questions. Appreciate all your hard work.
Thank you.
People forget
So we don't
about.
need to bring any drinking water back for session in January.
No, we don't. I tell you that the Fairfax Water Authority, they get mad at you if you're doing one of these things right here. They think their water is better than you can buy in a store. They do. That's Fairfax. Yeah. They have an advanced water treatment process, they say. Okay. Yeah. Are you gonna Doug Carr?
So that was the Virginia Department of Health.
Yeah.
Broad scope, a lot of time, sorry.
Well, thanks. You got a lot of work going on over there. We thank you for everything you're doing. We know it's challenging. It's good. Delta Carr, did you have a question, being from Richmond?
Thank you, Mr. Chairman. Just a very brief compliment. I just wanted to compliment Dr. Shelton. We've had a number of kind of specific constituent issues, and she's been very responsive and helpful, and just wanted to compliment her on that. Thank you.
Okay, that's very nice. Thank you. Thank you. Okay, thank you for your presentation. We'll be in touch, and particularly on where you're not getting the funds or you used to getting them from our federal partners. Please let us know as soon as possible when those start affecting your operations. We greatly appreciate that.
Thank you, Mr. Chair. Thank you.
Yep. Okay, Department of Social Services. I think. Oh, Mr. Williams, you're here. Welcome.
Thank you, Mr. Chairman.
And okay, can you do this by 12 p.m.? Is it possible? Because this is some very important subject matter here.
I do appreciate the invitation to present this morning, especially being placed on the agenda after the Department of Health.
Yeah, well, you got to talk to my crack staff over there. Okay.
Well, thank you for having me. I'll be very brief with the overview of the Department of Social Services, just to ensure we have time for the federal changes, which I imagine is probably what you're most interested in. So feel free
as
to
you can. That would be helpful.
Stop me at any point. But just to give you a quick overview of what we will talk about today, I'll touch briefly on the DSS structure, how we're funded. I'll talk a little bit about what benefits we administer or interact with in the Commonwealth, the impacts of federal legislation that was just passed, and then Deputy Commissioner Carl Ayers will give an overview of our child welfare program, and then the Secretary of Health and Human Resources will come back and give an overview of a new initiative, Safe Kids, Strong Families, that was announced by the governor earlier this year. So DSS is organized largely in two buckets. We have our state programs that includes child support, background investigations, licensing of assisted living facilities and child care facilities. That's all state administered. Then we have the other part of the agency that is really state oversight, local administration. And that is where our child welfare system today largely resides. It's where our benefit administration and eligibility work resides, among other programs. And DSS is organized. We have 120 local offices. We have 5 state regions that oversee those 120 local offices that you see here today. And we have about 2,000 central office staff that are overseeing 12,000 local benefit workers, child welfare workers, et cetera. Our administrative budget, so this does not include all of the benefit payments, for example, SNAP payments or Medicaid payments. Our administrative budget is $2.9 billion. That's about 18% general fund and about 47% federal funds. We have a local match. We have our child support collections as well. Of the 18% that the General Assembly appropriates to receive federal match, a large portion of that, you can see here, about a third of that goes to local department operations. So we're largely funding a lot of those local operations, and that includes the eligibility work that I talked about before and the child welfare work. This is an overview of our benefit programs that we administer or share in the administration of. I could go into greater detail here, but we split, for example, administration of Medicaid with DMAS. We do the eligibility for the most part. They run the actual managed care contracts. Likewise, for the child care subsidy program, we do the eligibility for that, but the Department of Education actually administers the benefit today. We are redesigning the...
That's a new
Correct.
Thing this past year, because you used to do that, but we've given it over to the Education Department now to work on early childhood grants.
Correct. Okay. Yeah, the grants are at the Department of Education, but we still do the eligibility. We still do background checks for individuals who are working in child care centers, things of that nature. So we're still intimately connected and still collaborate on that program.
Yeah, thank you.
And then we have a number of workforce programs within DSS that most people don't realize. The TANF, Virginia Initiative for Education and Work, that's the workforce program. The training program is still within DSS. Our SNAP employment and training program that helps train individuals or families that are in the SNAP program are still all tucked within DSS. The next thing I'll just touch on very briefly is the summer EBT program, or Virginia Sunbucks. This will be our second summer launching that program and sending out essentially grocery supplement benefits to eligible households. And that's about $120 in grocery supplements that's going to a household to essentially offset any loss in free or reduced lunch programming that doesn't occur over the summer, so that kids can go to summer camps, et cetera, and be well fed. So I'll shift gears here quickly to talk about the impact of H.R. 1 at the federal level, the One Big Beautiful Bill Act. And at a high level, I'll focus on two areas. One is our Supplemental Nutrition Assistance Program and the impacts to that program and what we will be seeing at the state level. And then on the Medicaid side of it, I'll talk about where DSS interacts with DMAS on eligibility work and what we anticipate seeing operationally on the ground over the coming years. So shifting to the SNAP work in particular, the reconciliation bill that was just passed in federal fiscal year 2027, the Commonwealth of Virginia will see an increase in the share of administrative costs that we are obligated to pay to run that program. And what that means is today we share the cost of administering that program 50-50, so dollar for dollar. Every dollar that the Commonwealth of Virginia puts up to help administer that program, today the federal government matches that with another dollar. In federal fiscal year 2027, so October 1st of 2026 is what that means, we will shift and we will start to pay 75% of the administrative costs to run that program, so the federal government will only match 25%. So what that means, if we're looking back at historical data in federal fiscal year 2024, we paid about what would today, that 25% would represent about $87 million in administrative costs. So, if you fast forward a few years, we anticipate that the cost of that increased administrative burden will be about $90 million. And then separate from the administrative share increase, we have essentially a potential requirement to contribute a new state match to match the SNAP benefits. Today, that program is completely funded with federal funds, the benefit portion of the program. If the Commonwealth of Virginia maintains an error rate in payments and eligibility determination that's higher than 6%, then the Commonwealth of Virginia will have to contribute a state match. So this is a table here that shows you essentially how much the Commonwealth of Virginia would have to pay at different error rates. And so the reconciliation bill introduced this match concept so that if we have a below 6% error rate in eligibility and payment errors, then we maintain 100% federal funding. If we have a higher than 10% error rate in our SNAP program, then we would have to pay a 15% state match. And just for context, the SNAP program, the benefit amount itself is $1.8 billion today. So if you take 10% of that $1.8 billion, that's where we come up with the $180 million, for example, at 10% state match. So today, we just received our latest error rate for the Commonwealth of Virginia. That is from last federal fiscal year. So that ended in September of 2024. Our error rate today is 11.5%, and that compares to a national average of just around 11%.
Okay, could you clarify for us how the error rate is calculated? The number one, and number two is whatever we do in year X affects our cost share in year X plus one.
Correct.
Okay.
Well, I'll explain the rules around that, but essentially what these errors represent, I'll skip the formula itself, but the errors are primarily errors in the composition of a household how many people are in the household. And unlike Medicaid, which is usually primarily an individual eligibility, SNAP eligibility rules are around a household. And so the composition of the household matters. The benefit amount that a household would receive if you have 7 children versus 1, the benefit amount is going to be different. So the composition of the household itself matters in the determination of how much the family should receive. And that's one of the primary types of errors. And then the actual payment amount itself, if we overpay or underpay what the family should have received, and we discover in retrospect that they received the wrong payment, that's another very common type of error. And we see, really at the local level, the household composition information, the income eligibility information at a local level, the quality of those determinations should be higher.
So how much are we spending now to determine that we have an 11.5% error rate? How expensive is it right now to know what we know now?
Are you asking how many payments are made in error, and how expensive is that, or are you asking how?
I'm interested in the administrative costs of this. So what are we spending now, to find out that we have an 11.5% rate? And I assume because of the complications you just mentioned that we're going to really need to have more people focused on this so we can get our error rate down. Is that right?
To answer your question, I don't know the exact dollar amount that we spend to specifically do SNAP eligibility. We can certainly come back to that.
Is it true that people who are doing SNAP eligibility are also doing Medicaid eligibility?
Correct.
So, okay,
Correct.
It's just one of a person's job, one thing a social worker might do at one of our agencies.
Correct. Just to give you some context, we have about 6,000 benefit workers across the Commonwealth of Virginia that do this work. And so when a client walks into a DSS, right, we're using paper applications, or we're using the Common Help application. And I mentioned earlier that we're redesigning that right now, so that hopefully will help in lowering this error rate, but that will probably not roll out for a handful of years, probably 2 or 3 years at least. And so to answer your question, our period of influence on this error rate, the federal government has given us 2 options. We can either use our error rate from federal fiscal year 2025, that's the year we're currently in, so that's not a great error rate, 11.5%.
Actually, we're in 26 now. Oh, we're in federal year 25.
Federal, yeah.
We're in state year 26.
Yeah, correct.
Yeah.
And so the next federal fiscal year that we'll be able to opt to use as the error rate that they base this benefit state portion on is federal fiscal year 2026, which will begin this October. So we have about 3 months to gear up to lower our error rate as much as possible. And unfortunately, budget proposals that go forward, we'd have a limited amount of time to really influence this, and we'll have to move very quickly as an agency in order to do that. That said, if we are able to lower our error rate by 1.5 percentage points and get below 10%, then we're saving the Commonwealth $90 million per year. So that's a high return on investment. And so lowering the error rate, and I'll say this is one of the highest error rates that exists in any benefit program. By comparison, and this is a national issue, it's not just a Virginia issue. The SNAP program itself has very high error rates nationally. By comparison, a lot of investment has gone into lowering error rates in the Medicaid program, and in Virginia today, those are under 2%, right? And they were, I think, above 4% when the administration started. So, you can move the needle on these things. It takes a lot of work, and I think in particular, it will take a combination of technology and training at the local level to make sure that our benefit workers know what they're supposed to be doing in terms of composition of household, but we're also giving them better information to actually be able to do that, right? We can give them better data sets and intelligence about how to assess household composition so that they don't have to spend as much time trying to do that with paperwork.
Okay.
Any other questions on that before I move on?
I don't see anybody's light on.
I guess.
Delegate Hope.
Mr. Chairman, to put a finer point on this is that right now with our error rate, it's going to cost us $360 million.
The benefit portion of that is 270, regardless of what we do to lower the error rate, we will be paying approximately a $90 million administrative cost share. So the only thing we can change is the benefit portion
Well, that was
of the match.
last year, we weren't paying that, but this
Correct.
year, the coming year, we would be. So I look at it as a
Correct.
bigger error than what you're saying. But I think just for purposes of the appropriations process, we're looking at, and I should be looking at the general fund impact in millions, not the total impact?
The total impact is general fund, and that's maybe a little confusing there. That's all general funds. The differentiation there is the benefit amount, which is the column on the left that ends in 270 million, and then the 360 is the administrative plus the general funds for the benefit portion of the match. So that's the total that we would pay.
60 just includes the extra 25%?
Correct.
Or it includes the entire 75%?
It includes the extra 25%.
Okay,
Yeah.
so what, we already pay 50%?
Correct.
Okay, I got it. Can we have an order in the court here? Delegate Cohen, can you make this quick? Delegate
Sure, I'll
Cohen.
do my best. I guess my question is, you said you didn't want to take the time to deal with the formula, but I guess in terms of like really boots on the ground, figuring out what the error rate is what you're saying that sometimes we're over-calculating the amount of need and sometimes we're under-calculating the amount of need?
Correct.
Mr. Chair? So I guess, our concern, I think what we see is the number of families in our school systems who are afraid to sort of utilize any of our systems to make sure that they're feeding their kids and families because they're worried in particular about their immigration status. So I just want to make sure, of course, we always want to be accurate with what we're doing, but I guess my concern is the tendency to overcorrect by underutilizing SNAP. But you're saying the way the formula works, that there isn't an incentive to just take more people off of it to fix the error rate.
If you're specifically concerned about the eligibility based on citizenship status, that's in a future slide, and I'll get to that in a moment. But in general, this change at the federal level does not impact who is eligible. So I'll talk about that in a minute. This merely says if a state has a high error rate, and i.e. we're right, we could run the program better. The federal government is saying you're going to have to pay a portion of that because we think that the error rate is high nationally, and that's what they're saying. The benefit amount itself does not change for the household under federal law. If a state wants to maintain the federal SNAP program and a high error rate, then we have to pay the additional funds here from general state funds. That's what it's saying. So it's not changing the benefit amount in this particular proposal.
Okay, thank you. Please continue.
So now kind of getting into some of the eligibility changes that are not tied to that error rate directly. The federal reconciliation bill limits SNAP eligibility to those who reside in the United States, who are a citizen, lawfully admitted for permanent residence with no intention of abandoning their residence in a foreign country. And really, within that category, there are a couple of things that are changing. The primary one is the category of deportation withheld as a status is being removed to allow for SNAP eligibility. So someone who has deportation withheld as a citizenship status or residency status, they would no longer be eligible for SNAP today. And the last thing I'll just touch on here is the requirements are for all non-eligible, non-citizen financial resources and any SNAP household to be included in eligibility. The next thing here is a repeal of the National Education and Obesity Prevention Grant Program. So this is a wholesale elimination of this grant program and its funding. Technically, if Virginia Tech wanted to continue to administer this program, they could do that if they want to. But the position at DSS that exists to coordinate this program and the federal grant have been eliminated. but that will occur in a future year. The next modification here is around SNAP work requirements. So the bill introduces broader and slightly stricter work requirements for individuals in SNAP. So the able-bodied adults without dependents work requirement age range is going to increase, and it will be for individuals up to 64, so just before you're turning eligible for Medicare. And then there's a change in the exception for families with dependent children, and that goes from an exception that allows for a child under 18 in the household to one that is under 14. So essentially, if you have a teenager in the house, you're no longer exempt from the work requirements. And I'll talk a little bit more about one of those later, but if you have a two-family household and one individual is working and the other is not, there's still an allowance for the fact that that second adult is able to stay at home. Another limitation here is it removes a waiver that allowed localities to deem their locality without sufficient jobs. And so now you have to have an unemployment rate above 10% in order to qualify for that geographic exception. And then there's a general work requirement. The able-bodied work requirement has a higher standard for able-bodied individuals. This applies more broadly in the SNAP program. And just touching on what I just mentioned, creates a new exception, actually, to allow for dependent children that should be under 14 who reside with an individual who's in compliance with the general SNAP work requirement. In other words, if you have a two-parent household, one can stay at home, one would have to go to work. And it also expands the National Agency or Accuracy Clearinghouse. And what this clearinghouse does is it essentially eliminates the potential for individuals to have SNAP benefits in multiple states. So if someone moves from Tennessee to Virginia, they're immediately turning off the SNAP benefits in Tennessee, and once they've applied in Virginia, they're able to receive their SNAP benefits in Virginia. And so that's just allows for some more efficiency in the program, and it could possibly help us on our error rate calculations as well. Shifting over to the Medicaid eligibility space, the bill introduces work requirements, work experience requirements, and a different renewal process for Medicaid eligibility. So in Medicaid, they're not completely the same work requirement. They're similar, but again, it has an able-bodied adult without dependent work requirement for individuals enrolled in Medicaid expansion. And so that population would be required to complete 80 hours of work per month, very similar to SNAP. But that work requirement also allows for an individual to go receive education or training or volunteer and do community service, or a combination of those three. And then the next piece of this is the change in the renewal process itself. So today we redetermine eligibility for Medicaid every 12 months. The reconciliation bill requires that eligibility is done every 6 months for the expansion population alone, which is not the entire population, obviously. So that would exempt, children, pregnant women, all of those categories would still stay at a single year of redetermination requirement. So this point in particular on the 6 months for redetermination, that is going to significantly increase the workload at the local level in those 120 departments that I talked about recently. And so we are looking at how are we going to deal with the resourcing of that, because a backlog of Medicaid redetermination still exists in the Commonwealth of Virginia, even after Medicaid unwinding. And so this requirement we expect will increase the backlog. And I think the concern there is, right, you're paying Medicaid capitated payments through the Commonwealth of Virginia for anyone who's on Medicaid, but we're not doing their eligibility as quickly as we should. And it's very
everyone, they're only going to be covered by one of the MCOs. And when the MCO has an interest in making sure any eligible person is re-signed up again, is signed back up again. So wouldn't they be helping you to do that?
They are not entirely allowed. they're not allowed to do eligibility determination, obviously. They can't enroll their own
Sure.
customers. But there have been some changes on the marketing side in terms of what types of information they can share with their clients. So that might help a little bit.
So they can tell their client, hey, you need to get redetermined in next month.
Right. Okay. And more of that type of activity. But the fundamental workload itself of doing the eligibility redetermination today largely rests in local departments of social services that are already overwhelmed, and we already have a backlog. So, we're looking at technology solutions and staffing solutions to be able to do that. In the past, during unwinding, for example, we had a state level redetermination team that helped out local offices that were overwhelmed. Things like that are things we're looking at, but those proposals are not quite ready for prime time yet. Okay, and then the last item here is reducing errors in Medicaid. There's a requirement that states implement a number of processes, and I think a lot of this really came out of what states learned during Medicaid unwinding. During that process, we learned that there are a lot of people who were out of state, deceased, both patients and providers, and so there's a now requirement that every quarter we and DMAS will have to go through and ensure that we're reconciling whether individuals who are in the program or providers who are serving the program are deceased and then are still in the state, essentially. So that's one of those requirements. Another item here is a new definition of excess payments. And so if there's insufficient information to verify eligibility, then that will be included in this new definition of excess payments that CMS would hold us accountable for. So assessing eligibility accurately without a lot of presumption will become very important. And that is all I have. Any questions?
I don't see any. Okay, Delegate Price.
Yes, thank you. I'm sorry, can you go to the slide right before? So with Mr. Chair, with the new definition of the erroneous excess payments, I think in some instances payments were made, and then if they were found to have been insufficient information, then they went after that payment to get it back. Is that correct? What has happened maybe before these changes?
So it depends on where that excess payment went. If it went to a provider, that's true. They would go and get it back. If it involved the Commonwealth of Virginia providing a benefit to a client, that's not true. There's just a general waiver of, we gave you the benefit for longer than you were actually eligible for, but there's no general recoupment of that on a regular basis. Does that make sense?
Chair.
Delegate Price.
So just a follow-up. So then moving forward with this new definition, would that payment be withheld to the provider until the quote-unquote sufficient information was received?
So really the Commonwealth of Virginia, DMAS and DSS would be held accountable by CMS at the federal level. So that's more about accountability, federal to state level. The actual client or provider wouldn't be impacted by and large. Now, if they're found to be making the provider themselves or making, unnecessary billings or something like that, there's already a system in place to hold them accountable for that.
And one last question, Mr. Chair.
And
then can you remind me for the last few sections that you've had, the timing of when these new rules would go into effect?
Sure. So the most significant ones will take some time. All of the ones I just mentioned have slightly different implementation dates, but federal fiscal year 2027 is when the state administrative cost share increases by $90 million. Federal fiscal year 2028 is when the benefit portion of that would be due by the state, and that will be based on the state or the federal fiscal year 2026 error rate. So that's a little confusing, but operationally what it means for us is that DSS needs to get working very soon to lower our error rate, but the bill for that will not come due for 2 or 3 years, depending on whether it's the administrative portion the benefit portion.
Mr. Chair, I'm sorry.
Yeah, Delegate Price.
Thank you. So what about the work requirements piece? What was that timeframe?
Work requirements, if I remember correctly, are next year.
Next year. Okay, so then I'll withhold my questions on that part for a new administration. But I would, Mr. Chair, just not a question, but a statement. When you keep saying 90, I mean, maybe I think for accuracy, you could say at least 90, but if it were to happen today, I think what my colleagues were trying to point out is that we would not be at the increase of 90 million. We would be lower in the chart because of where our error rate is.
Oh, agreed.
So maybe just at least 90 would be a more accurate statement as opposed to an increase of 90.
We will increase what the state owes to the federal government by at least $90 million. Agreed.
Thank you.
So before Delegate Tran asks a question, the expansion eligibility today goes through Cover Virginia. We have a contract out with Cover Virginia to do that. And how will that operation be changed by this and its relationship with the local DSS office?
Yeah, I will leave that for Cheryl to provide you the discrete answer on that. I don't want to speak to that exact contract and how it will be impacted by the federal legislation, because I think that's really her call on Cover Virginia. But the ex parte process itself is going to be limited dramatically. I'm not sure that eliminated is the correct word for that. How that Cover Virginia contract can be still utilized, I think, is the question that Cheryl and team have to figure out. But that will also translate into more work for the local department.
Sure. Yeah, Tran, this is all good news. Yeah.
Thank you, Mr. Chair. I have two questions. The first is around SNAP eligibility changes. When are those expected to take effect?
SNAP eligibility should be, there's a little bit of a rolling change here, but if I remember correctly, these eligibility changes will be next year as well.
Clarification, Mr. Chair, next October of the fiscal year or program year?
Let me get you the exact date. I don't want to misspeak,
that would be really helpful.
I believe it is next year, but we'll make sure that we get you the exact date.
Mr. Chair.
Yes, Delegate Tran.
As you know, sir, Virginia resettled one of the largest Afghan refugee populations in the country. And I am very concerned about the removal of eligibility for our refugees. And can you let us know if you are in conversations with our refugee agencies about how we are going to ensure that these folks who stood side by side with American soldiers in Afghanistan are going to be cared for?
Absolutely. And as I'm recalling, these categories get very technical, and there are many of them, as you know. But my recollection is that there are still refugee categories that are included in SNAP eligibility. I specifically remember the Ukrainian refugees being included in eligibility. I can't remember off the top of my head if the Afghan refugees are. So that statement there is general. Unfortunately, general is not always completely accurate. But if it helps, I could get you a list of the exact refugee categories that are exempted from that.
Thank you.
Very good. And you're finished now. Secretary Kelly looks like she's anxious to.
She is. She's ready.
Now, Secretary, you're going to talk about child welfare initiatives.
Hi, Mr. Chairman. I was going to give a 30-second addition to his comments on benefits, and then we'll shift entirely into child welfare, and Deputy Commissioner Ayers is going to do that piece. But on specifically the SNAP error rate, and this is not my area of expertise at all, so I defer to what the commissioner said on most of the technical things, but I don't want to leave you with the impression that we are merely trying to get below 10%. It is our intent to fight for that below 6% with every fiber of our being between now and the end of the Youngkin administration, and we hope that the next administration will do the same.
Well, we need to get our error rate down to zero. Very
aggressive plan to, aspirational, but not out of the realm of reality. And that we have to fight for zero. And if you hit 1%, great. If you hit 5%, great. But every single dollar we spend to get that error rate down is savings later on the fine. So just wanted to make sure that that was
So
overtly
we'll be
said.
looking forward to your budget presentation
Well,
in
it's not
December.
going to, our budget presentation is not going to matter. We've got to do it now because we can't spend that money till next July.
Do you have the resources to do it right now?
We are being very creative, and I'm happy to, once we get the plan finalized, share more details about.
Can you please share that with
What that looks like. Of
Susan
course.
Massard and Amy Cochran, please?
I would be happy to.
Okay, thank you.
Thank you,
Okay.
Deputy Commissioner Ayers.
Carl, we want to eat some lunch sometime today, and it's my fault that we're this late, but yeah. Why don't you tell us, you are Mr. Foster Care, Virginia. You know more about that than any other person. That's your introduction.
Yes, sure. Thank you, Mr. Chair. Pleasure to be back with you. And just as a reminder, I get to oversee both child welfare and benefit programs. So, as you look at continuity of answering these questions and everything the Commissioner and Secretary were talking about, I'm going to be your coordination between the administration changes and making sure that we oversee this. So just as you have questions that arise and things along those lines, keep sending them our way. And I will do that. To the chairman's point, for those of you that have been here for a number of years, I have led our child welfare system in Virginia now for, last 4 administrations from that end of it. So was asked to talk about the child welfare side this morning and going into this afternoon. And what I wanted you to lead you with before we get into this is I'm going to really focus your attention in the short time that we have on the challenges that we have around keeping our children safe in Virginia. So I just want you to think about that whenever we go into this. And I want you to focus this time thinking about the 38 children that died due to abuse and neglect last year. So think about that. In my time leading this system, I have read more than 1,500 child fatalities, and the majority of those are preventable. So whenever we lean into this conversation, I know it's lunchtime and I know we're getting into that, but I don't want to miss this point when we're talking about our child welfare system and what's at stake with the conversation I'm going to lead you through. When we get into this piece of it, when you think about our child welfare system, it's really 4 large components. One of them is the prevention. And whenever we're talking about prevention, we're really talking about prevention of abuse and neglect, how children are cared for by their parents or caregivers, child protective services, which is the safety piece of this conversation. How do we keep those children safe? Foster care for those children that we can't keep safe in their home, and they must be removed from their caregiver and placed in an outside entity. And then adoption, which is then we were unable to get those children reunified with their families, and so we find them a permanent home with somebody that can be related to them, not related to them, but the adoption process. That's what we're talking about when we're talking about the child welfare system. So it's 4 really, really large components that are operated throughout the state. When you look at this, I wanted to focus your attention on 3 large areas. And so I'm happy to walk you in. I know it's a boot camp, so I can walk you down in detail for each of those programs. But in the short time, I wanted to kind of focus your attention on 3 major pieces. One being the passage of the Family First Prevention Services Act at the federal level in 2018, what those impacts have meant to the child welfare system across the Commonwealth, what our focus has been on moving towards a kin first culture, and how that has played out and what do we see within our kinship supports. And then I want to then direct you really on the safety piece of this conversation. So I'm going to walk you through those 3 major pieces of this. But in order to do that, you have to understand where the money comes from. And so at the federal level, Title IV-E of the Social Security Act is the major federal funding stream for child welfare programs. So when you look at the Child Abuse Prevention Treatment Act, which authorizes child welfare services throughout the country, Title IV-E is really your major federal funding stream. Prior to the passage of the Family First Prevention Services Act, you could really only use Title IV-E funds after you removed the child from the home. So there were no federal funds that were in the safety piece of this conversation, and there are still almost no federal funds that are in the safety piece of this conversation. So when we talk about safety, that is very much in your hands as General Assembly members, as what you invest in the system and what that robust system may look like. the 4E system begins to pick up for those approximately 5,000 children at any given time that have to be removed and brought into the foster care system. When you look at the passage of the Family First Prevention Services Act, it opened up the Title 4E funding to allow us to be able to pull money down for evidence-based programming, but only for services that were listed in a newly created Title 4E Prevention Clearinghouse. And so one of the big flaws that Virginia lifted up at that time, and we have seen it play out, is instead of building off an evidence-based clearinghouse that already existed, such as the California Evidence-Based Clearinghouse or Blueprints, the federal law required the federal government to create a brand new clearinghouse, which has taken them years and years and years and years just to start getting programs in there that we can start building off of. And so there have been limitations in getting that piece of it. Virginia, under our leadership, was the first state supervised county administered system to file a federal prevention plan. So we were first in the nation to get that plan submitted.
How many states have that system? There's of the locally administered.
So
it's not that many.
But we are down to 9.
Okay, so it's not like 50 states. All right.
No.
So I'm glad we're one of 9. Thanks.
I would love to say we were the first state in the nation, but we were actually the 4th state in the nation.
Okay.
To do that, and the first state supervised county administered system.
Okay, thank you.
And so when you look at our prevention plan that's filed with the federal government, we are allowed now to be able to pull down federal funds with regards to these evidence-based programs that you see here. So if you work in this space, you'll know these, everything from home visiting across the basic different types of therapies and for some of the high fidelity wraparound. The biggest opportunity for us to be able to expand our claiming is in the last one that's on that list, which is motivational interviewing, which has been setting in a cost allocation plan that's been setting at the federal level for 2+ years. So they do not turn these things around quickly, and thus it's going to impact our ability to claim federal funds. Now, that's kind of where we're at with that piece of Family First and where we are moving as a state. In kinship care, you've heard a lot about kinship care during this administration. Governor Youngkin and now Secretary Kelly have really had this as part of their priorities. And you will see that we have been able to move Virginia's kinship placement rate. And what I'm talking about are children that are in foster care that are placed with a kinship family. That we have nearly doubled that rate since we kicked off this initiative in September of 2023. So we went from 12% to 22%. And anybody that knows when you move a state, you don't move states double digits. So for us to move that system more than double digits within that, a little bit over a year and a half, has really significant impact.
Well, we had 0 not that long ago. I mean, we didn't allow kinship care. We were opposed to kinship care, right? Until somebody, so this is all new-ish.
Well, it's new-ish. So if I were to walk you back a few years, we were actually started at 8%.
Percentages are so misleading, you know. But go ahead. Thank you.
So as you look at where we've gone with this is that we have started investing in kinship care. We are moving to the system that is getting there, though the national average is 35%. So at a minimum, we need to get to the national average. And of course, in Virginia, we don't want to do anything at the minimum. So we want to exceed, we want to excel and get above that piece of it. So we have moved that over this time frame. And something to remember about kinship care. So this is what the research tells you. Children that are placed with kin families, they have lower rates of being reabused. They are more stable. Their placements don't disrupt. They have a greater likelihood of remaining with their siblings. They have better behavioral and mental health supports, and they have a higher likelihood of achieving permanency. So when you think about why do we prioritize kinship care, this is why we prioritize kinship care, because all the research says children do better when they're placed with family members. Under a unanimous legislation that came in last year, so July 1st, 2024, the Parental Child Safety Placement Program was passed by the General Assembly and signed by the governor. It was unanimously supported, And for the first time ever, it set guardrails within Virginia on how do we work with families prior to them entering foster care. And so it sets timeframes, it says what type of supports have to be provided to families. It ended the practice of where you would have children go and stay with family members without a plan to get them back home. And it really transformed the types of services that exist within our families from that end of it. Since this went into place in July of 2024, we have had more than 300 children that we have been able to maintain in their homes by the passage of this bill and be able to keep them from coming into the foster care system. So, and that's in its infancy. We literally kicked this off, like I said, July 1st of 2024. So thank you for your support in helping us get there. Now, I want to shift you over into safety conversation. And so under Secretary Kelly's leadership, she has tasked me with leading a statewide effort, which has been dubbed Safe Kids, Strong Families. And what Safe Kids, Strong Families is it's targeted at advancing child welfare reforms across Virginia. In her opening remarks, I'm sure Secretary Kelly spoke to you about the time for reform in Virginia's child welfare system has come, and especially when we look at how do we keep our children safe within the community. So how do we prioritize family stability, reduce our reliance on congregate care, and then strengthen our workforce to make sure that our children, our most vulnerable children, are taken care of. Certainly continuing to build off of the kinship care work, empowering our foster youth, and then certainly taking advantage of Safe and Sound and all the work that we've done to try to get high acuity youth out of local agencies and into an appropriate placement. So this is what that looks like. And in the sake of time, I'm not going to walk you through all of this, but what I want to really draw your attention to is the challenges with our workforce. So these are the 6 pillars that we focused on within this Safe Kids, Strong Families structure. Under the strengthening our workforce pillar, 44%, listen to that again, 44% of our new family service specialists leave the job within 11 months. Just let that sink in for a second. If we want our families to be taken care of, we cannot have half of our workforce leaving within 11 months. We have to be able to get workers in. We have to be able to pay them a competitive salary. The average salary is $37,000 for a 4-year degree individual. You have to invest in the system if you want to have different outcomes. So I just want to draw your attention when we're talking about workforce. This is getting workers in. It's keeping those workers. It's getting supervisors that understand what it takes to keep a child safe within that home and getting the entire structure in place. Additionally, this is where that state supervised county administrator structure becomes a challenge. These are all local employees. So it's 120 local employee agencies under 120 different cultures, under 120 different hiring practices and everything that comes along those lines. The state does not really play an active role in that piece, except for having a statewide system to put your recruitment in, unless you're a deviating agency, and then you may not even use the statewide system at all. And so how do we address that issue? Safety, which is the Child Protective Services pillar. What would it take to change the way that we respond to situations involving children and families? I want to draw your attention to number 1. If you go across the 120 agencies across the state, some agencies screen out 90% of every call that comes in that they never receive a response. Nobody ever goes out and checks on the child that was called in. There is no response to it from that end of it. On the other end of that, you have some agencies that screen in 90% of every call that comes in. So that inconsistency across the state is one of our biggest concerns, especially when you look at children under the age of 3. So if you want to look at children that die and have the worst outcomes, it is almost universally children that are under the age of 3. So part of what you see focusing this attention within this pillar, what can we do to keep our most vulnerable and most at-risk children safe? How do we create a system that allows us to take the information that comes to us, get out and respond to those families and make sure the appropriate protective supports are put into place? It's also how can we leverage data analytics? How can we use tools like artificial intelligence and things along those lines? You can't put all this on a single individual. How do we as a system become much more proactive and robust in being able to do that? And the number one issue I see in problematic cases is the poor quality of assessments that we're doing with families when we go out and see them. So for the ones that we respond to, for the ones that we go out and see, we do not do good quality assessments. Part of that is staffing. Part of that is our training system redesign, which we are in the process of working on getting our training system redesign for that end of it. So thank you for those resources that came to us last year. All those are trying to get us there. And I'm going to leave you with one other thought on this pillar. 77% of all cases that were determined high and very high risk, whenever an assessment were done, are never open to services. Statewide guidance says you are to open high and very high risk cases. 4 out of 5 cases never get a service as a follow-up once we get an intervention done. That's the reality of this safety conversation. So I want you to make sure and hear these percentages. 23% of the fatalities that we had last year had a screened out complaint. Opportunities to intervene if we've got a system that is well functioning and being able to get us there. Permanency, this is the one you will be most familiar with over the years. This is foster care. We have done a ton of work in this area. The safe and sound piece of this, really focusing on how we can serve children and families. But I also want to draw your attention to the youth that are ending up in congregate care. Congregate care are group homes and residential facilities. We are seeing an increase for the first time in almost since 2008, so 17 years. We are seeing more kids go into congregate care facilities. And they are coming into the foster care system for reasons that are not abuse and neglect. So 20% of all the kids that are now in the foster care system come in for reasons that are not abuse and neglect. It is delinquency, it is parents that can't get the care for them, it is mental health concerns that are not treated within the community, and then they end up being transferred to the custody by judges that are out of options for what to do.
So when they go to congregate care, is this a CSA?
Yes, sir.
Okay. Right.
So it's a combination of Medicaid and CSA are your two major funding streams for that end of it. And we saw, to quote Scott Reiner from OCS, we saw about a $12.5 million increase in congregate care expenses last year. So this has a real drive of the impact for your local CSA budgets and then certainly the state dollars for that piece of it. So supporting our foster families, for those that are foster families, certainly understand those pieces of it, and then getting our kids back home. We struggle with getting kids out of the system once they come into the system. Behavioral health, you've heard about Right Help right now. This is the child welfare connection to that piece of it. How do we get preventive behavioral health supports before children are in crisis and then are placed into the custody of local departments? Working with our new foster care MCO, which you have heard from DMAS and others, a huge win for us to get to one single MCO to help get those sort of services to our children and families. Proud of the partnership we've had with DMAS trying to get that in place. Substance use disorders, number one driver of problematic issues that we have with families. And whenever I say substance use, I didn't say illegal substances. This is the impact on the overusage of substances with their ability to take care of our children. The prevention piece of it, mentioned this in the 4E side of this. We have the ability to draw down more Title 4E dollars, but we have to have a system that it gets us to that place. So there is federal money to help fund some of these things, but we have to set up a system that allows us to draw those funds down. And right now,
where are you in that process right now, setting up that system to draw down those funds?
So I have tasked my team with trying to figure out how to make this happen from that end of it. The place that we tend to fall flat, though, is this has to be done 120 different ways. And so you're not going to be able to maximize it if it's requiring 120 agencies to do it 120 different ways.
Let's see if we can get those folks together and you can come up with, help them see the light that we need one process. Okay.
And that's a perfect lead in to number 6. So the last pillar on this is the oversight and infrastructure. So, and I'm pretty sure Secretary Kelly mentioned this in her opening remarks, but we have the most individual agencies of any state supervised county administered system within the country. And the ability to hold those poor performing systems accountable does not exist. We do not have the first lever to hold those poor performing agencies to
It's been a long-term problem.
to a place. And as Chairman mentions, this is something you've heard me talk about before. The end of it, I can go and ask you nicely to change your practice. But whenever you have children that are not being taken care of, we have to take a really hard structural look.
Carl, going back to point number 2, number 1, centralize the intake and validity to support consistency of screening decisions.
Yes, sir.
That's going to require changes on behalf of 120 agencies.
Yes, sir.
Right? So how are you going to do that?
So, well, technically, if you want to know how this would need to happen, is you would have to change the code to have intake come in, and I'll liken it to 988.
What if we had a regional system? What if we grouped so that we had 25 agencies together and they had a regional intake system?
Yeah, so Mr. Chair, there are a number of different ways you could look at doing this from that end of it. So if you wanted to take a regional approach, there's an option to take a regional approach. What would have to change is right now, the majority of complaints that come in are taken by the local departments. And so you go through 120 different ways. I oversee the 24/7 hotline as part of what I oversee. So I see that, and then I also oversee the mandated reporter portal. So for the mandated reporters, that can go in and actually file a written complaint with us. So you would have to look at that entire system. I want to draw your attention actually to the word validity, because that's what is the major change here. When I told you about the screen in and screen out rates of that 90% screen out to those 90% screen in, is that what this would recommend is that not only do we do intake in a centralized place, but the decision of what actually meets the code for it to be a valid complaint to respond to would be handled centrally. So you're taking that from doing it 120 different ways, and if we were to regionalize it, you do it in 5 regions or 7 regions or whatever it may look like. But it is taking it from 3,000 staff across 120 agencies and putting it in the hands of a centralized, what I use the term centralized, but it could be regional, it could be one place, and in this virtual day and age, it could be a combination of a number of different things.
Okay.
And so this is the workflow that I just talked with you about. We had 93,000 calls that came into us. We actually had 102,000 that came into our system last year. So 93,000 of them were CPS. 56,000 of them were screened out. It means we did nothing with them. It means they were determined to not meet the criteria in the code. And the 4 code and the criteria is that you have a child that's under the age of 18, you have a definition of abuse and neglect that has been perpetrated by a caretaker, and you have jurisdiction to respond to that complaint. That's your 4 criteria that's set within the Code of Virginia. So statewide, 56,000 of those were screened out, which means they didn't get any type of response. That is about 67%. So roughly 2 out of every 3 are screened out. And nationally, it's about 60% for the state supervised county administered systems and about 43% for the nation as a whole. So if you want to be looking at what should we be trying to get to, is that 43% is what the national average. So we're significantly above the national average for those cases that come in that we don't respond to.
Delegate Carr.
So you were talking about the fatalities that occurred. They were the ones mostly, the larger percentage of those were out of the screened out calls. Is that correct?
So if you go back to the chart, 23% of the fatalities last year were screened out. So if you look at that bottom end, number 2, 23% of child fatalities had at least one referral that was screened out as invalid.
Okay, thank you.
Yes, ma'am.
Okay, you're going to get to how we're going to fix that, right?
Well,
you're going to get to that?
Well, that's part of the slide I just went through with you. That's what's on the table.
Okay, Delegate Gardner has a question.
Along the same lines, I started my career as a social worker back in the 70s, so that's a long time ago. But even at that point, there were standardized intake and an assessment tools that were used, maybe not evidence-based back then, but now you talk about how they get screened out. Are there not standardized intake and assessment tools that they're required to use in the 120 programs?
Yes, so Mr. Chair, Delegate, we use what are called structured decision-making tools that are provided to every local department that they are required to use, and they are administered 120 different ways, even though they are standard, even though it's the same code, even though everybody is trained in the same way, they administer them according to the way that they interpret it within their individual localities.
Mr. Chairman. So you talk about those high percentages. You have no authority to do anything about all these kids being screened out?
Mr. Chair, Delegate, that's exactly what I tell you. There's not the first code authority that exists within the agency to set standards for performance for local departments of social services, to set performance measures that spells out a corrective action planning process for how we would handle it. There are 2 specifics that exist within the code now. One of them is an authority for the commissioner to remove the director of a local department from that end of it. Regulations have never been passed by the state board to spell out how that would happen. So even though that authority exists, it's never been built out and has never been followed through. Not the Youngkin administration, but in a previous administration, we developed those regulations and then they were never signed by that administration. So they sat within that administration and then they sat there so long as they needed to be reinstituted and reset forward, which that has not occurred. So there are no regulations for how that would actually would happen.
Is this coming from the Board of Social Work?
No, this is the State Board of Social Services Regulatory Board.
Okay.
Yep. And then the second one was Senate Bill 1339, 2018-19. We had a foster care omnibus bill that was put together, and there were a couple of authorities that were put in there specifically to allow us to intervene in placement changes if the event that we disagreed with the placement changes that would occur from that end of it, and then set up a corrective action planning process for foster care only. So those are your authorities that exist within the entirety of the Code of Virginia for the state to set standards for our localities.
Last question, Mr. Chair.
Yeah, Doug Gardner.
Do y'all want to fix this?
I think you heard the Secretary. This is very much a major priority when you're looking at this work effort. We have to change the way the system functions if we're going to change the outcome for our families. You have some really good performing systems. Yes, sir.
Tell us what the best argument that the other side, if there is another side, has for why we can't change. Is our low compensation rates? That's part of it, I'm sure, because this doesn't happen in Fairfax County. I hate to tell you that. I mean, our Board of Supervisors puts $180 million into human services. But so what's unmovable? What's the unmovable object out there?
So, Mr. Chair, the best that I can answer that, just to draw you back here, is it's a combination of 3 major things. And I'll draw your attention to these pillars. One being the accountability and oversight. You need to fix that code piece of this so that there is an accountability and oversight function that exists. You have to fix the way safety services and the way the system is individually run in 120 different ways. And I talk with your agency on a regular basis in Fairfax, and they have more flexibility within their budget than the entire rest of the state combined. And so it's hard to compare Fairfax to
I'm not
how
trying to do
the other
that.
100.
I'm not trying to do that. Just they do it. They don't want to pay for it. They just have to pay for it because the state doesn't. That's their view.
And that's the way that it's the way that they function and the way that they operate. But when we look at the rest of look at the state as a whole, the way validity is done, the way the intake is done, the way that we can help protect our children and families from a statewide system is you have to change how that looks and how that functions. And then you have to address the workforce issues. None of this works if we don't figure out a way to get workers in, get them really skilled and trained, and get out and working with the families. Because, I haven't been in it since the 70s, but I've been in it since the early 90s. And our workforce is the one that makes a difference. So our supervisors and our workers that are out in the home are who make a difference within this. So it's a combination of those that are what are systemically going to change our system.
Delegate Cohen has a question. And then Delegate Price.
Thank you, Mr. Chair. I know that we have human bodies, 3,000 people who are working to make this determination, and so I certainly don't want any of them to think I'm calling for their jobs. However, do we have an opportunity to use AI or some other kind of modeling in how we make those determinations of just responding?
Yeah, so Mr. Chair, Delegate Cohen, absolutely. There are models that are out there. There are research-based models that look at this, and they have the ability to function. So they are both AI-based models, and then there are predictive analytics-based models that exist within that information that can help inform the decisions that we would be making. So, of course, you never take the people out of it. What you're doing is taking the information and helping make better decisions so they become more consistent across the state. So those exist. Now, the challenge with that, you can't implement those models 120 different ways. So that's what the researchers tell us, and that's part of what informs this recommendation to centralize and bring it to one centralized location or one centralized oversight.
Right. And may I have one follow-up, Mr. Chair?
We need to have lunch here. Because we have a lot more after lunch, too. So can you make it short?
Yes, Mr. Chair. I just was going to ask, are there particular states that have models that we could go to school on?
Yes, so Mr. Chair and Delegate, so there are states that have models. We have been to those other states and visited with those other states. As part of this work, we looked at 27 different states to inform the recommendations that are in front of you. So we have done that work. We have been there. I've personally been in a number of those myself as part of those site visits. So that's what is informing these recommendations.
Delegate Cohen, earlier in his testimony, he said that there's only 9 states that do it the way we do it. Delegate Price.
Yes, in the interest of time, Mr. Chair, I would just ask, since regulations you said had been created but not implemented before, if we could get, I don't know if that's able to be communicated to us, but I would just like more information on the vision for number 6 and then also the cost.
Yes, be happy to follow up with any of that I can.
Thank you. Thank you, Carl. I think the Secretary is, based on her positioning in the room, I think she's wants to speak again.
Yep, so I think what we're trying to do is trying to move you out of this so she can wrap up and do those pieces. Like I said, in the interest of time, there's so much more that we could go into with this. There's more in this presentation around the structure, the specifics.
We're already depressed, Carl. We're already depressed.
Yep, you've got it. So let me kind of wrap up with a couple of, I can't leave you without the data slides. So once again, how are we informing these conversations? These are the referrals that come into Child Protective Services and how many children actually enter foster care. So you will see that piece of it. We are generally #1 in the nation for keeping children with their families. So I want to highlight that piece of it. You'll see very few children that come into the foster care system because that has been a goal of ours since 2008, to keep children with their families. This is the number of children that are in foster care. Draw your attention to 2017 when we extended foster care to age 21 under a program that is called Fostering Futures. So had the pleasure of navigating that legislation through these bodies at that time. And so just look at the number of children that or youth, I shall say, adults that are 18 or over that are taking advantage of that program. So you will see it has absolutely done what it was designed to do. It is helping transition those youth to young adulthood, and we want to keep working on making that better. This was the slide I talked to you about. About 20% of children are coming into care that are not abuse and neglect. So 1 out of every 5 children are now coming to us that are not abuse and neglect. And the request relief is a big one to pay attention to. As you look at all of those from the end of it, there's been a work group and everything really focusing on that over the past year. And then just highlighting where we've gone with the kinship rate. So this is your data to follow that up. This is the number of youth that have aged out of foster care, which I will leave you with from that end of it. Our goal would be not to have a single child age out of foster care. So while I'm proud of our Fostering Futures program, the goal would be to find a permanent family for every child that enters the system, not to have them age out and go into the adult system. Here's some more information on that. 77% of our youth that age out participate in Fostering Futures. So once again, a really good slide. And then of course, our partnership with the MCO that I mentioned earlier. With that, I'm going to leave you in the capable hands of the Secretary to wrap us up.
3 minutes. 3 minutes. Thank you again, Mr. Chairman, for creating a forum where we can have these open conversations. These are conversations.
Thank you for the administration's participation.
You're very welcome. So
I'm putting my timer on right now, the stopwatch.
I don't want to rush through this, all joking aside. This is really important. This conversation is
keeping commitments is important.
A long time coming. Okay, so, Mr. Chairman, Delegate Gardner asked a great question. Do you all want to change? It's the most important question of all, and I will just turn it right back to you all. I'm not going to be here in 6 months. Another administration will be, and I think that's a good question to ask yourselves. I think after today, the answer is yes. I also, every time I do
you
something—
know how many years it took us to get kinship care over the objections of your party?
And excuse me, Mr. Chairman.
Okay. Just wanted to point that out.
I'll let that one go. I have to learn not to chase every ball that's thrown my way. I'm doing so much better. I'm maturing. I'm almost 50. So there is a joke in Virginia when you do anything big to change. And the joke is, how many Virginians does it take to change a light bulb? And the punchline is, change. So we have to change. Let me tie this up a little bit as we go to lunch. If this were a real boot camp, this started out as a child welfare boot camp, by the way. I'll get my dig in. And we had about 35 minutes on child welfare. So maybe we need more conversations like this. But if you really want to know how our system is working, talk to one of the 473 kids who aged out last year and who age out every single year. Talk to one of the siblings whose brother or sister died at the hands of someone who was supposed to love them. Talk to one of the 63,000 kids who are represented by that child abuse hotline call. Dang it, I almost made it. I should have quit when I was ahead. Who got screened out. Talk to them, because that's who I talk to, and that is why that is why I'm crying. That is why I'm tearful, because you cannot talk to these kids and not come away changed. Back to your point, Delegate Gardner. Sorry for getting emotional, but I've always said, if stories like this and cases like this don't make me emotional, I shouldn't be in my job. So let me move on without emotion. The right time for this is now. There are 3 things that we've done, major things that we've done together that laid the groundwork for something big next session. One of those things is safe and sound. When you have a kid sleeping in an office, you can talk to your local directors. They get all the attention, as they should. You don't want them in an office for a variety of reasons. It's not safe for anyone. It's expensive. It's not good for the kid, right? We did that year 1. Right Help Right Now was year 2. Kinship was year 3. This is year 4, okay? So this is why we did this study in year 4, so that we could present a plan to you all, for you all to consider. I have 3 asks in my remaining 30 seconds. 1, read the Ombudsman report and the FACT report. Oh, I didn't bring my phone. The new FACT report that just went out basically said, we do not fully understand the impact of these child deaths and these child neglect cases because we do not have an accurate way to not just collect the data, but present the data to decision makers like you so that they can act accordingly. But the numbers are not great, as we know. Read the Office of the Ombudsman report. We've got Eric Reynolds here this morning, or this afternoon, and we will be happy to send both of those around. And then the last ask that I have is to just continue the conversation so that every single kid gets the customer journey that Delegate Cole's kinship son got and nephew got. There was trouble. He got into a great kinship home. He stayed out of foster care, officially out of foster care, and now he's going to go back with his birth dad. That's great. That's what we want for every kid, right? Not this placement and that placement and congregate care home and this and that and aging out, and then guess what? The cycle starts all over. So we look forward to more conversations with you. Thank you for inviting us to your boot camp. I'm probably going to have to go after this, but I will be available through lunch for questions. Oh, yeah, I'm sure. Thank you all. Sorry again for my emotion.
And I'm sorry that we're at 12:40. I mean, it's a lot of information, all important stuff, and it was terrific that your team was here today.
Good.
Explaining all this stuff to us, and we need to keep this up because we've got a big oversight responsibility that I don't think we take full advantage of with time, and it helps everybody because I know that your team has been preparing for this. Last year they did, this year they did. They prepared for this, and we appreciate that. But we're going to be back at 1:30 to start this again. That's going to be like in 1/2 hour later than it would have been. So everyone's going to have to eat lunch in 45 minutes, if that's okay, and be back up here at 1:30. Is that good? Okay, thanks, everybody.
All right, thank you.
We are temporarily adjourned.
Okay, I hope everybody had a good lunch, and I apologize again. I had to take care of some business from my paying job. And so, yeah. So we're back here in our volunteer jobs. We're moving along with the Department of Aging and Rehabilitation Services. Come on down. Please introduce yourself and tell us what's going on over there at DARS.
Good afternoon.
Good afternoon.
Nice to be here with you right after lunch. I'm Kathy
That's the best time.
Hayfield. I'm the Commissioner of Department for Aging and Rehabilitative Services. I've been with that agency for a little over 30 years and 8 years as Commissioner. And I'm going to give you a 101 overview of the agency in 30 minutes. So bear with me. We're going to race through it. But keep in mind that as I talk about numbers, I'm talking about people. So the best way to talk about an agency and the services we deliver is to tell stories, but we don't have time for that. So I'm going to give you
just
the
give
broad
us your phone
overview.
number. We'll call you after this is over.
Right.
Okay.
So the mission of the department is to improve the employment, quality of life, security, and independence of older Virginians, Virginians with disabilities, and their families. So that's all about people. The agency is mission-driven, so very much as I walk through this, you'll see how we're providing those services to people in those different populations. But we have 6 different divisions of the agency: disability determination services, and then 3 areas that are about safety and security of older Virginians and Virginians with disabilities: adult protective services, the Office of the State Long-Term Care Ombudsman, and the Division for Aging Services. We also have the Division for Community Living, which is the division that works with individuals who have disabilities primarily, and then the Division of Rehabilitative Services, which is the employment arm of the agency. We serve people of all ages, but primarily we are an adult services agency. And we serve, and that's a slide that just kind of gives you a quick overview. The one exception to that is the Vocational Rehabilitation Division, in which we start working with individuals who are 14 and up to begin career planning. But all of the other divisions are primarily for adults, people who are older adults or vulnerable people with disabilities. What makes DARS unique is that we work with 4 different federal agencies. We are primarily a federally funded agency. 80% of the agency is federally funded. And then we also receive generous dollars from the General Assembly. We work with the Social Security Administration for the Disability Determination Services. That's a 100% federally funded program, and I'll talk about that more in a minute. We work with the Federal Department of Education, with the Rehabilitation Services Administration, in which we provide the vocational rehabilitation program for individuals who have disabilities other than blindness. The Department for the Blind and Vision Impaired provides the vocational rehabilitation for that population. And then we work with the Federal Health and Human Services Department, primarily with what is currently called the Administration for Community Living, which is going away at the federal level, and we will be providing services through the Administration for Children and Families and Communities. And in that area, we receive funding for aging services, No Wrong Door, disability programs for people with brain injuries, and centers for independent living. We receive a small amount of funds for adult protective services. We receive funding for the Long-Term Care Ombudsman program and the Virginia Assistive Technology System. And then we also receive a small amount of funding through the Department of Labor for a senior community services employment program, as well as grants from time to time that are tied to WIOA, the Title I Workforce Investment Opportunities Act. Okay, let me just go through the different divisions. The Disability Determination Services, folks might not realize it, but when they apply for SSDI or SSI for individuals with disabilities, if they are not able to work, they make that application to the Social Security Administration. But the work is actually done by the states. So in Virginia, we receive funding to determine eligibility for disability determination services, and we employ about 500 people in 5 offices across the state. About 400 of those folks work in 4 regional offices, processing about 70,000 disability claims for folks in Virginia. But we also have an additional office of about 100 people in Roanoke, where we provide the disability determination services for people in states where those states aren't really able to provide themselves. So, for example, we receive maybe 400 disability claims a week from the state of Maryland, and we provide that work for them. We also do about 35,000 medical psychological consultations for 10 other states. This is good for Virginia. People might say, why would you do work for other states? But it employs another 100 or so individuals with 100% federal funding. So we feel good about that work we do. I'm not going to talk more about DDS unless you have questions. Okay. Moving right along, Adult Protective Services. So about 12 years ago, Adult Protective Services was moved out of the State Department of Social Services and over to DARS. At that time, we were Department of Rehabilitative Services. We became Department for Aging and Rehabilitative Services in 2012. In 2013, we took on Adult Protective Services. Again, this is a state-supervised, locally administered program in which DARS provides the oversight and the local departments of social services provide the adult protective services work. We have a small but mighty team at DARS, about 14 staff who develop policy, provide training, monitor local Department of Social Services, provide the quality assurance. We feel like we've really built that program up over the last several years. In 2024, just so you have some idea, there were 46,000 reports of adult abuse, neglect, or exploitation. And I believe Carl said 90,000 in Child Protective Services, so that gives you some idea of the difference. There are 3 ways to report adult abuse: through the local Department of Social Services, through the 24-hour hotline, which is run by DSS, or through an online reporting portal that we just stood up about a year ago, and we're really pleased that we have that new system because it's much more efficient. We've seen mostly professionals using that system from the banking industry as well as from school systems and others. 60% of the reports we received involve self-neglect. So those are individuals who are aging, mostly poverty-related, who have the inability to care for themselves. 17% involve financial exploitation, and then another 12% are other neglect, so maybe a family member not taking good care of an adult parent. And only 5% are physical abuse. I don't mean to say it that way. 5% are physical abuse, and 4% are mental abuse. Just so you have some idea, about 20,000 of those 45,000 reports are of individuals in their homes. 2,500 are in nursing homes, and another 1,000 or so are in assisted living facilities. Okay, so we also oversee the adult services program that is provided through the local departments of social services. And really, these are services that are being provided for individuals to be able to stay in their homes as long as possible. So in this situation, we're providing homemaker services, we're doing long-term services screenings, we are doing assisted living facility assessments, guardianship reports. The local departments of social services do the guardianship reports for private and public guardians, and that's about 16,000 reports a year. That's a heavy lift for the local departments. And we do this work with 3 staff. We oversee this program.
Remind us, you oversee or check in on the auxiliary grant recipients. Do you also allocate the auxiliary grants?
Yes. So the dollars are maintained at Department of Social Services for the auxiliary grant, as well as for these home-based services, for adult services, as well as for adult protective services, but DARS monitors and allocates the dollars.
Okay, we have recently, as you know, increased the grant from $1,600 to $2,000. Can you tell us how has that been effective in helping you, and what's the waiting list like?
So the auxiliary grant serves about 3,000 people a year. It has helped. It's still not enough. If you think about the dollar amounts you just mentioned, it's almost impossible for a private pay to be as low as that. Usually they're more in the 5,000 range.
Well, isn't it true that the reason it's called auxiliary is you add it to your Social Security and maybe your deceased spouse retirement?
It's supplemented.
Yeah.
Right.
Yeah.
It definitely is better.
Yeah.
I will say that. It's definitely better. But we're still leaving dollars on the table that's allocated at the beginning of the year because there aren't enough assisted living facilities who will accept that rate.
Right. So we are allocating more money than you can use.
I hate to say that out loud.
I know, but
Right.
We've never heard that in government before, but in this case,
So increase the rate.
So it can't be used because it's so low.
That is the problem, yes.
Yeah. Okay. I want to come back to you and talk about your overseeing of assisted living facilities later.
Okay.
Okay.
All right. Keep on going. So I mentioned that part of the mission of the agency is protecting the safety and security of older adults and adults with disabilities. The Office of the State Long-Term Care Ombudsman is housed with DARS. It operates independently, much like the Child Ombudsman program does. It is a federally funded and state-supported program. We've received funds from both the General Assembly as well from the federal government. There are 70,000 beds in Virginia, long-term care beds, and there is one ombudsman for each 2,600 individuals. Oh, to me, personally, yes. In 2024, there were about 3,200 complaints that were investigated. The purpose of the long-term care ombudsman is to resolve problems. So we have a resolution rate of 79%. And then we also work with Medicaid managed care, where we're funded by DMAS to provide managed care advocates who help resolve problems through the Medicaid program.
Can I ask you at this point, so the health department is in charge of responding to every complaint as well. So how does it get to you?
Correct. So the health department does the licensing for nursing homes. Department of Social Services does the licensing for assisted living facilities. We are not, we're more there to provide resolution and to help individuals who are having individual problems.
Well, I thought the health department helps resolve these issues when there's a complaint. They go out and investigate whether it's valid or not and then try to help resolve it. Is that not true?
It's different. More, they're looking at complaints that are related to the license process. We're dealing, or the Office of the Long-Term Care Ombudsman, they're dealing with individual complaints, so that if they bubble up to a problem that looks like a licensing problem, the Department of Health handles those, or Department of Social Services if it's an ALF. We work closely with those agencies as well as with DMAS to improve the overall care, but
Do they send you cases to follow up on, either agency?
no,
DSS
we don't get
VD?
reports from them. We get reports from individual people.
Okay, thank you.
Yep. So the type of reports we get: lack of care, failure to provide choice or dignity, problems with admission, discharge, or maybe a person being evicted, low staffing problems, poor food. Those are the kinds of things we're dealing with, which could bubble up to be big issues that the health department would be dealing with licensing.
Delegate Willard wanted to ask a question. I'm sorry, Delegate Willard.
To follow the same line of questions that the chairman started, so do you have, I mean, I guess if there's really a big problem that's going to go to VDH and then they have the license, the licensing oversight, but do you have any sort of enforcement powers? Is it more writing letters, or which the recourse that an individual would get if there was a complaint? And I'm not talking about the food being banned, I'm talking something more in really true care.
Right. We're going to be working with the director of that agency, of that hospital or nursing home. We're going to be sharing trends, information we receive about ALFs or about nursing homes. We're going to be providing that information to the health department or to the Department of Social Services, more so than they're going to be coming to us. Does that answer your question?
Mr. Chair, yes, no, that does in part. I was just curious if there really is a problem that you're not issuing fines, you're not revoking anything. The most you can do is, well, you can escalate. I guess escalate would be the word, to go to the VDH with it.
Correct.
Okay.
Right. Okay. A large division at DARS is the Division for Aging Services. Approximately 2 million Virginians are currently over 60 years old, and that population, as we all know, is growing. I think for the first time ever, we have more individuals who are aging than we do under 18. So the Division for Aging Services is primarily funded by the Older Americans Act, and then it receives a 20% match from the state. There are 25 area agencies on aging who receive the funding through the Older Americans Act, and DARS is the flow-through agency. Okay, so in the last year, 86,000 older adults were served by the area agencies on aging, receiving such services as home-delivered meals, 2.4 million, 640,000 individuals who are aging received meals on site at area agencies on aging, which is really a wonderful opportunity for individuals to get out of their homes, helps with social isolation, and these are really important services at the area agencies on aging. Much like the local departments of social services, the adult services area, Older Americans Act dollars are used to provide personal care and homemaker services to help individuals stay in their homes, to age in place, and that's really the purpose of the Older Americans Act. DARS has about 25 employees who work in the Division for Aging Services, administering about $60 million in state and federal funds that go through to the area agencies on aging. Other services we provide in our Division for Aging Services, we provide VICAP, insurance counseling and assistance program. These are services provided also through the area agencies on aging. These are separate grants we receive. We have a farm market fresh where about 30,000 individuals receive vouchers to be able to purchase vegetables and fruit at farm markets, a relationship we have with the farmers as well as these individuals. We provide lifespan respite, senior cool care, falls prevention, driving assessments through Virginia Grand Driver, just to give you some idea of the different types of services that are provided. We also receive a small amount of funds at DARS for dementia services and oversee the Alzheimer's and Related Disorders Commission. And we have a program called Dementia Capable Virginia. Small but important services. Okay, you may have heard of No Wrong Door. This is a statewide network of public and private providers designed to streamline access to long-term care services. This is a partnership with Virginia Navigator and 211 Virginia, which are two robust statewide databases. Served about 77,000 older adults directly who receive services, and we work, this is primarily through the area agencies on aging. They're the lead, but also Centers for Independent Living, brain injury providers, as well as other community-based organizations use this tool. We have about 540 licenses for individuals across the Commonwealth to utilize this program. Been in existence for about 20 years. Okay, moving right along, the Division for Community Living. This is primarily state general funds, started in the 1990s to meet the needs of people with physical and sensory disabilities who weren't being served through community services boards or through DBHDS or any other agency. This is a partnership with 150 community organizations. And again, this is a small staff. It's basically flow-through dollars at DARS, Centers for Independent Living, public guardianship programs, personal assistance services, brain injury services, the auxiliary grant program, and long-term case management. The Division for Community Living administers $72 million in state general funds, serves about 16,000 people a year. And I'm sure those are programs you all have heard of. And I thank you for that support. Okay, and the next page in your PowerPoint gives you details about those programs that I'm not going to go through at this point. Okay, and the largest program at DARS is the Division of Rehabilitative Services. This is largest in terms of funding as well as staff. Unlike the other programs I talked through that are flow-through dollars, the Division of Rehabilitative Services are services we provide ourselves with about 500, it says 573 staff there. That's between the Division of Rehabilitative Services and Wilson Workforce and Rehabilitation Center. We have 30 offices around the state, and you see the districts are highlighted there on your slide. Again, this is federal and state dollars, 78% federal funding. In state fiscal year 25, we served 32,565 individuals. 10,000 of those were students with disabilities who were receiving pre-employment transition services. So again, that's individuals 14 and up that we start working with to help plan their career path. Just for your information, about half of the individuals served in the vocational rehabilitation program at the Division of Rehabilitative Services are people with intellectual or developmental disabilities. A quarter of them are people with mental health disabilities or substance use disorder. And then the other quarter are individuals with physical disabilities, deaf and hard of hearing, orthopedic disabilities, and even a very small percentage of individuals who are blind and vision impaired who then may also have another disability as well. Questions about that? Okay, moving right along. Okay, Wilson Workforce and Rehabilitation Center is a comprehensive rehabilitation center in Fishersville, Virginia. And this is a program where we provide pre-vocational and vocational training for individuals with disability, mostly transition age. And in this past year, 45% of the students served there were on the autism spectrum. And that's a real change from previous years when Wilson Workforce was originally established. It was established to provide services mostly for people with physical disabilities, brain injuries, spinal cord injuries. But because those services are now available locally in trauma centers and other programs like Sheltering Arms, our population at Wilson Workforce has changed to be more individuals with intellectual disabilities or on the spectrum.
Ms. Hayfield, do you have residential facilities in Fishersville?
Yes.
You do? Okay, how many people can stay there at one time?
300-ish.
Okay, thank you.
And we served 1,700 individuals there last year. And you see just an idea of the kind of programs, training programs we provide: auto mechanics, building trades, IT, culinary, manufacturing technology, and a real strong focus on soft skills, workforce readiness skills. DARS also manages some other programs that don't easily fit into the categories I just gave you. But one program that is funded 100% with general funds is we call LETIS, Long-Term Employment Support Services, and I'm sure you've heard of that before. It's about $9 million that helps people who need extraordinary supports to maintain their employment. So they might come to the vocational rehabilitation program to get training and placement, supported employment, whatever services they need to be placed in the community. But for a large population of individuals, about 5,000 people a year, they need ongoing support in order to maintain their jobs. It's one thing that Virginia has that most states don't have is a program like this, long-term supports. And I'm very appreciative that the General Assembly has continued to support this program because it's very unique that we have it. This is today primarily for people who are working in the community in competitive employment with these supports. And then we also have some other programs, the Senior Community Service Employment Program, the Virginia Assistive Technology System that provides information and assistance for around assistive technology to help people stay in their homes, to be able to go to work. It doesn't fund the assistive technology, but we have a reuse program or a try before you buy program. So it's a really great program, federally funded. And then we have a number of grants federal grants. We've been really successful, especially in the vocational rehabilitation area, accessing federal grant dollars to do innovative programming. And I'll talk through those real quickly towards the end. So some recent accomplishments. As I just raced through these divisions, give you some idea of some of the unique things we've done in the last few years. As a result of a piece of legislation that you all passed in 2024, DARS was charged to establish an online training portal for all all guardians across the Commonwealth. We launched that in July of 2025. We also launched an online portal for reporting complaints of adult protective services. That's also reduced the number of calls coming into the hotline that DSS runs for child protective services. Okay. Let me skip down the senior farmers market. We received grant funding recently so that now covers the entire state. And we've been working closely with DMAS on developing strategies to improve nursing home services and sharing our data, which is really important. Okay, and then we have these 2 large federal grants. And the EPIC grant is one that's focused on working with individuals who have the most significant disabilities, who at one time would have been placed in segregated settings, receiving sub-minimum wage employment. And thank you, Delegate Hope, for your work in ensuring that Virginia doesn't have sub-minimum wages anymore. But this is a grant so that we're focusing on having alternatives for individuals with very significant disabilities so that they can work in competitive integrated employment. And then we also have a grant through the federal government that has helped us build our partnership with Department of Human Resource Management so that more individuals with disabilities can be employed in state government. So that we could be a model employer of people with disabilities in Virginia. And we've seen some great success in increasing the number of individuals who are employed in state government.
Thank you, Ms. Hayfield. Can you tell us what you're most worried about with on your flow-through money? What is at most risk right now?
So it keeps changing. A few weeks ago, I would have said it was a long-term care ombudsman program because it looked like those dollars were going to be cut, but they're safe. I expect to see the senior community service employment program eliminated. It's not a large number of individuals, but that's a program that currently employs about 120 individuals across the state. We're feeling pretty solid in our vocational rehabilitation program. We do expect to see our support employment dollars eliminated. There are some other areas that I think we'll end up picking up that we have had funding for in the past, but it's maybe a 5% cut we'll see, not as large as some other areas of the programs. Aging services look pretty good. We're even seeing a little bit of money still sitting on the table for adult protective services, that just occurred during COVID. I'm not being kept up at night over these programs. We are concerned about our contacts in Washington because we've seen a lot of layoffs of individuals we're currently working with through the Administration for Community Living as well as Department of Education. But our dollars feel pretty good.
Okay.
Questions?
I don't see any lights up. Delegate Hope.
I appreciate you highlighting the EPIC program. Can you provide my office with an update on how we're doing on the 14C? I think it expires at the July of 2026.
Right.
And so I'd be curious to know how many people are still in the program and how we're doing. But thank you for that.
The numbers are way down, like down to 120, something like that. And 5 years ago, maybe a little longer than that, there were 3,000.
So looking into the future, what do you think is going to be your biggest need and request from the General Assembly?
The Adult Protective Services area is the complaints are going up, and as other programs are cut, I see that impacting those who are most vulnerable in the community. So I see that as an area. That's probably the biggest.
Okay, I don't see anyone else's lights up. We thank you.
Delegate Carr.
Delegate Carr.
Thank you. Thanks so much for your presentation. Mr. Chairman, I have 2 quick questions.
Certainly.
All right. I think it's about eyesight. I think it's slide 16, the Division of Rehabilitation. You may have said this with Delegate Sickles, but, you know, of that federal funding there, how much of that do you anticipate, you know, the green swath, how much of that will be cut?
In the Division of Rehabilitative Services?
Yes. Uh-huh.
Right now, I would just be giving you a wild guess. but I'm guessing in the 5 million-ish of a 100 million program.
Thank you. And then one other question. I just heard a presentation recently. They called it the Forget Me Not Cafe with dementia and so forth. How are you all connected with that, or how are you working with that?
That's not a program that is one of our vendors.
Okay.
I believe that could very likely be a vendor of Department for Behavioral Health.
All right.
Medicaid waiver dollars, but they aren't a vendor for competitive employment.
Thank you.
Certainly.
I don't see anybody else's light on. Thank you for all you're doing. I really
Thank you.
appreciate it. I still personally want to understand better your relationship with your ombudsman and the 2 licensing agencies and how you work together. And I don't recall when hear these outrages in the newspapers that your agency being listed. But maybe I'm wrong. Maybe my eyes just glazed right over it.
You probably didn't.
Okay.
Right.
So, okay.
Right. We do a good job of staying out of the paper. Yeah.
Okay. Thank you very much. Keep up
Thank
the good
you.
work. Appreciate it. Okay. Next, we have the director, Arnie Owens. Mr. Owens, please come down. I see you in the audience almost every time we open our doors. And I wonder what you're doing here all the time. You're watching us. And tell us how long you've been with the Department of Health Professions and what you're overseeing and your biggest challenges.
Well, good afternoon, Mr. Chairman, members of the committee. Always enjoy coming down here to meet the people's representatives.
Getting you out of the office.
That too. Our offices are out on the west end of Richmond, or Western Henrico.
I heard that's where all the rich people live.
Well, I don't know about that, but it's good to get downtown, and be a part of all of this great work. But yes, I am the director of the Department of Health Professions. I'm joined here by Erin Barrett, who's our director of Legislative and Regulatory Affairs. You probably have already seen her down here a lot.
Yes, sir.
She's also my senior advisor and a right-hand person. So. She's here to handle the hard questions if I get some later. But,
you won't get any from us.
Let me make sure I can get the clicker going. There we go.
We'd appreciate it if you help us overcome our, our length of our day here. We messed that up. So you can help us catch up and we'll all like you better.
I'll move quickly because I know everyone is sitting on the edge of their seats waiting for DMAS.
I know. I see our bosses. I see our bosses out there.
But Mr. Chairman, this is our mission: enforcing standards of practice, providing information, licensing. Bottom line, we want to do everything we can to ensure that we have practitioners in Virginia who practice safely and who are competent. I also want to point out we are DHP. We're not VDH. We get confused sometimes. We regulate healthcare professionals. There's a difference between your normal professional occupation, tradesman, and a healthcare professional, because a healthcare professional is healthcare, really. It's people delivering care to other people. So I always like to point that out. That's one of the big differences. Quick agency overview. Of course, we derive our authority from Title 54, the Code of Virginia. We serve as the umbrella agency for 13 health regulatory boards. You're familiar with those 13, biggies being the Board of Nursing, Board of Medicine, Board of Pharmacy. We have over 350 employees at DHP. Again, we're the umbrella agency, and by that we mean we provide an umbrella of support to the boards, and that includes IT and HR and finance and procurement and facilities, that sort of thing. Together, we're licensing around 500,000 healthcare professionals across 62 professions. The number today is actually around 506,000. We're pleased with that. We regulate and inspect 4 different types of healthcare facilities, dental facilities, funeral homes, veterinary facilities, but also want to point out pharmacies, because that's a big task that we have, and we're especially concerned about pharmacies because they're critical to the provision of health care around the state. We also regulate nursing education and pharmacy technician training. I do want to point out that we're a special fund agency. And by that I mean we don't get appropriated dollars. We don't get general fund dollars. We're totally reliant on the licensing fees paid by our various practitioners. We do run our budget through the appropriations process for approval, but it's really more to get an authorization to spend the funds that we already have on our account. So I just want to make that clear. We do have to absorb every pay increase passed by the General Assembly, out of hide, so to speak. So just be aware. We do
never raise your fees.
Well, we do appreciate the pay increases. Don't get me wrong, and our staff especially appreciates that. So thank you very much. These are the 13 health regulatory boards we have currently. Those are the numbers. Board of Nursing has the largest number of licensees, Board of Medicine next, and Board of Pharmacy. We regulate all pharmacists and pharmacy techs. I do want to take just a second here because there was a discussion earlier this morning with PDH on healthcare workforce. Over the last 3 years, we have added over 44,000 new licensees in primary care and behavioral health care. I wanted to point that out. In primary care, and I'll just shoot these numbers out, they're not on the slide, but we have today 7,600 more nurse practitioners, 9,600 more registered nurses, 4,463 additional MDs, over 1,400 new doctors of osteopathic medicine, 1,857 PAs. And on the behavioral health care side, we've got an additional 3,538 licensed professional counselors, 270 more clinical psychologists, 4,337 additional LCSWs. So those are new licensees, and all of this is, of course, in support of the Governor's Right Help Right Now effort of behavioral health transformation.
So some of those were bringing people in from other states that had a license in another state, and we license them here now?
We do license by endorsement, so whoever we can get in here, we're happy to bring them on in. I do want to commend the General Assembly on a couple of actions that you all took in the 2024 session, because this is significant in my opinion. You passed out legislation that created 2 new behavioral health licenses, behavioral health technician and behavioral health technician assistant. We have just started issuing those licenses. Of course, we have to promulgate regulations once the legislation becomes effective, but we're doing that now. I think it's going to really help the behavioral health care workforce in Virginia. I want to salute Delegate Willett, also House Bill 1499, which I'll never forget, because in that bill, he created a master's degree in clinical psychology license, and we've dubbed that the psychological practitioner. I was informed that yesterday we finally got that final regulation kicked out of the Office of the Attorney General. It's now over in the Office of the Governor. Move that forward quickly and get to licensing those new practitioners. So thank you.
Well, sure. Well, I thank Delegate Willett for that good work. Something he can talk about when he's running down the road in those commercials.
That's right. Well, you know, we're growing the behavioral health care workforce. DHP programs, I'll just touch on these briefly. We have our health workforce data center, which helps inform the healthcare policy debates and development. We can show you where the practitioners are throughout the state. We can give you a total number of licensees in various parts of the state. We can also give you a per capita number in various parts of the state. Not surprisingly, the totals are much larger in the metro areas and they're fewer in the rural areas. And we can talk more about that. Prescription monitoring program, I really like to talk about this because this was the type of program that was created in the early 2000s, prescription drug monitoring programs. SAMHSA sent out seed money around the country to get these up and running. We have one here in Virginia that's been operational since the mid-2000s. It's funded with a trust fund that resulted from a settlement with one of the big drug companies. You may recall back in the early 2000s, problems with OxyContin abuse out in Southwest Virginia, and it just got worse. And at any rate, we're funding the PMP with the trust fund dollars. We do get some CDC funding that's routed through VDH. We've applied to the Opioid Abatement Authority and gotten a couple of years' worth of additional funding from them. We have a grant application in with them right now, hope to hear soon. But we're very pleased with that program. I especially like it because it's a mechanism that's used by prescribers, but also dispensers, the pharmacists doing the dispensing at that end of the cycle. But I especially like it because it's a great screening tool for a physician, for a primary care physician, who see that, well, maybe I'm looking at a patient here with a substance use disorder problem, and they can then do this after the screening, maybe a brief intervention, referral to treatment. So it's a great program. We have our health practitioners monitoring program. This is designed for licensees that may have a behavioral health care problem. Maybe it's a mental health issue, maybe it's a substance use disorder, but if we can get them into treatment and monitor them, but keep them working, that's a good thing. Of course, if we can't do that, then the board may have to take their license from them, but hopefully we can get them into treatment, get them to recovery. That's, of course, the best option. Board licensing, we license practitioners. Now, I know we've talked about hospitals, talked about nursing homes, and the VDH has their role in that. DSS, of course, licenses assisted living facilities, but we license the actual practitioners that will operate in those facilities. Just want to make that point. 62 professions, lots of variants. In general, to be licensed, you have to meet specific education, training, and practice standards as are defined in code and in regulation. All the details available to the public on our website. Licensing staff at DHP have to ensure that all the requirements are met. We do have online applications. We can do it all very quickly, but there is a human in the loop to just check all of that to make sure it's good to go before the license is issued. Once licensed, the licensee is expected to abide by Virginia law and regulation. Not all of them do, and that leads to one of our follow-on slides. Each licensed profession has a renewal requirement. Many license or renew their license every year. Others, they're on a 2-year cycle. Board of Medicine, for instance, a 2-year cycle. But that's a continuing process. We do have the bad actors, as I mentioned. So we have an enforcement division. They receive, well, I'll just say we have 75 investigators around the state in 4 different regions who will investigate any complaint that comes our way. Our enforcement division receives complaints against the actual practitioner and then conducts investigations, and they do that for all 13 of our boards. A complaint can be phoned into us, it can be emailed to us, it can be sent via letter. There's a form, a complaint form on our website. They can fill that out and get it to us. Regardless how it comes in, our intake folks at the enforcement division will take a look at it and we'll follow up. The most serious cases are priority A cases. I'm sure you're familiar with the case here in Richmond, in Rico, a while back with an RN and the tragedy around issues there. Those are the most serious cases. There aren't many of those, but we do have them. The types of cases that you would see investigated include, abuse and neglect, drug diversion, drug tampering, felony convictions. We will take your license if you've been convicted of a felony in Virginia. We'll learn about it. we'll take your license. We'll do the same if you've been suspended in another state and we learn about it. We'll do that very quickly. We're required to do that by law, so we don't necessarily, well, we do it because it's an important thing to do. You see here just a breakout of the cases. Over on the far right, the key point is that cases submitted keep going up. I don't know if people are angrier, I don't know. We don't necessarily know what the reason is, but there are more complaints. We receive the complaints, we investigate. This will show you the process. The complaint will be filed. Enforcement Division will receive it. They'll ask a question right up front: does DHP have jurisdiction? We may not have jurisdiction. It may be a facility problem, in which case it gets tossed over to VDH. Is the allegation or the complaint a violation of law or regulation? It may just be belly aching, or somebody doesn't like someone. But if there is, if we believe there has possibly been a violation of law, then our enforcement investigators will go to work. They'll assemble a case file of all the evidence. They'll submit that to the board. The board will take a quick look at that and do what we call a probable cause determination. Has there been a violation of law or regulation? If the answer is no, case dismissed. It's gone. If it's yes, then we have a team of in-house attorneys that will assemble an entire case package and prepare it for formal proceedings or disciplinary action. Worst case disciplinary action is a formal hearing. That's the sort of situation where the end result may be the suspension or the revocation of a practitioner's license. That's very serious because that license is their livelihood. And so they obviously take it, a respondent would obviously take that very seriously, and we take it seriously because we want to ensure everyone has their due process as a part of this proceeding. It is an administrative hearing that's conducted. It's not a criminal proceeding, but it looks, if you were ever to attend one of our board formal hearings, it would be very much kind of like a court proceeding with the assembled board and the board president and Commonwealth represented by an assistant attorney general or one of our in-house attorneys, and then the respondent, of course, hires their own defense attorney. So it's a good process. The bottom line, though, we want to ensure that the public is safe, but we want to ensure that a respondent has their due process rights. Providing information is another thing we do. Our website is really the key mechanism for getting that information out there. If you've ever been on our website, you can go right up front there and see license lookup. It's on the front page. You can click on that, and you can put in the name of pretty much anyone you know and see if they're licensed to practice, and get some information on that particular practitioner. Case decisions are up there. Public orders are posted within 90 days of hearings. We regularly communicate with licensees to share the newest laws and regulations. Board of Medicine sends out board briefs basically every month or so, every quarter. We work with the media to inform and educate the public. We do get calls from media representatives. We respond to query. We have our communications director standing by, and we do everything we can to keep the public informed. Regulations and laws, you all know the process. The General Assembly passes a bill, governor signs it into law. We then promulgate the regulations. So we're not authorized to provide interpretations or legal advice regarding laws or regulations. The law says what it says. If they want an interpretation, go talk to a lawyer, but we just look at the plain reading. Each licensee is responsible for knowing and following applicable laws and regulations. That's part of their license. And of course, you have our website there. You can go on our website look under each of our boards, and you'll find the specific regulations. You can also find the link to the appropriate section of Title 51. Regulatory challenges, do want to talk about that for just a second. Complying with the requirements of the Virginia Administrative Process Act may cause delays in implementation of a law. I'll just mention, if you want to bypass that, the exempt action is a process, but that isn't always possible. Laws must become effective first, and then once they're effective on a July 1st during the year, then drafting of regulations can begin. Some regulations require extensive drafting and additional meetings with a lot of stakeholder input. We really value our stakeholders and their input to the drafting of the regulations, because in the regulation is all the detail to implement what's in the actual statutory language. The process may take up to 2 years for full implementation, just FYI. And that, in a nutshell, is an overview of the Department of Health professions. And I'm happy to take any questions if there are any.
It's important work. Do we have any questions from the members? Delegate Tran.
Thank you so much, sir. Can you help me understand when a board considers recommendations to regulations, the relationship that the board and the department have in finalizing regulations related to licensure? I'm thinking specifically about my refugee license bill from 2 sessions ago.
Yes, Ms. Barrett can help me out a little bit with that, but the bottom line is when legislation is passed, the board will take up that specific legislation if it affects their section of the code, and they'll develop the implementing regulations. It's a process. We have to run the notice of intended regulatory action up through the governor and then back down, and then we'll develop a proposed regulation, run it up the chain again, back down, and then finally we get to a final regulation. But Ms. Barrett may want to provide some additional detail because it can get a little bit convoluted.
Yes, Delegate Tran, thank you for the question. For that particular bill, depending on how complex what the board is directed to do is, it can result in very heavy regulatory drafting, which in particular that bill does because of the requirements that the board has to put in place for the training. So while that process started with the NORA early, before the board even started talking about the specifics, the board itself began developing the regulations for the training with stakeholder input. The NORA actually moved fairly quickly for the regulatory process, and the board is still drafting the clinical requirements. So we're hoping to have that before the full board later this year for the proposed stage, but then it still has an additional stage to go after the proposed stage with the final stage action.
Okay. Well, thank you for coming today and sharing that with us. This is definitely boot camp information here for folks.
Thank you, Mr. Chairman. Thank you, members. Appreciate it.
Thank you, Mr. Owens. Now, I know a lot of people have been waiting for Cheryl Roberts to come because she's always a bundle of joy. She loves her job. And she's a lawyer, too, which surprised me when I first learned that some years ago.
Yes, I'm a lawyer by training. Hi, good afternoon. Even though you're making a joke, I was telling everyone if I had known, I would have came in with a song. But what I'm going to do is I'm going to have 3 things we're supposed to do today. One is to talk to you about cardinal care, in particular to talk about foster care, okay, and how that played in cardinal care. Obviously, I'm going to talk to you about the big, beautiful bill, simplistic, quick, but to get some of your answers done. And then Will is going to talk to you about a question that you always ask, like once you pass the bill, what happens to it? And particularly when we have to do a waiver, okay? So we'll give you some of the process answers.
A waiver from CMS, the Center for Medicaid and Medicare Services.
Yes, we're going to talk about them a lot today. They
Okay.
play a bigger role.
Otherwise known as the feds.
Yes, and I have to see how to get that, make sure I can do it. That's better for me, you're right. Right now, we're at 1.8 million Virginians Children are still important to us. As you can see, we have about 545,000 kids. But the expansion population is now number one in terms of our population. We still are the only carrier that goes from babies and pregnancies all the way to long-term care and nursing homes. What you're going to hear and you're going to see a lot, you probably got bombarded with this, is our name change to Cardinal Care, right? I guess you've seen that everywhere now. We're trying to get that across. You can see that this is our delivery system, and you should notice those are the plans, and I'm going to talk a little about that, and our fee-for-service. So everything is being modeled in Cardinal Care. So if you think about our dental program, it's called Cardinal Smiles. See, so you just can add that to the prefix. Remember, if I was here last year, I was hoping and praying that we could get actually through Cardinal Care. We were in the middle of a lawsuit. But I can successfully tell you we got through that, and we were able to implement on time on July 1st and was able to move it. And the thing I'm proud about is none of you have called me to tell me it was horrible or you got lots of constituents. And so that means it was good. And we moved a lot of people. We went through one other plan, so we moved 115,000 people in one day. We moved the foster care kids, and we have done that basically very well. I'm very proud of the team that worked on it from top to bottom. These were the 10 things we had promised you. What I want to explain quickly here is that while we were waiting, we were not just waiting. So one of the things we did and spent time doing is developing our oversight and compliance. We actually developed a new division for compliance. I also had made sure all the teams got trained again in managed care, and all the teams again got trained in oversight. Because the goal of the exercise is not just for us to do this. If we don't have the oversight, then obviously it won't work. And the last thing I just want to mention is we did something no other state had done. What we did was take all the RFP promises, you know how you get promises in the RFP? We all took that and put it and made it an addendum to the contract. So each plan will have to keep the promise they made. We moved the 1.7 million people into the program. The new program plan was Humana. That's the new one who entered our program. Melina left and left gracefully. I want to give them credit because they helped with the transition. I'm going to talk about foster care because that's the passion program. Communication, second to the outreach, and we did for unwinding, we did here, and I told you about the contracts. I want to talk a little bit about foster care because actually that is one of the key pieces of the program is that we went to one single plan for foster care. That means if you are either a foster care child, an adoption assistant, or a former foster care eligibility, you're getting moved into Anthem. And the reason that is that, as you know, is that, you have probably heard it from my colleague, is that in the middle of a crisis, that's the wrong time to ask you what your health insurance plan is and trying to figure that out. That helps DSS a great deal. But what we also did here was Anthem hired a woman who I really do want y'all to see and meet. Is phenomenal. Her dedication to this program, she used to be a former foster care child, and so her focus and her passion is really unbelievable. They have hired staff in trauma and child welfare and supports, and the goal to basically get the child through all the different levels. These are some of the added benefits that they added to actually above what we had even asked for. Everything from a Chromebook, because as you know, when kids are used to their Chromebooks in school and they lose it or they don't get any more when they leave, this is to make sure they continue it. Clothes for kids, online classes, they're doing a lot of things. But the biggest thing is they're working with kids with trauma, and they understand then that that child needs not just day-to-day things, but extra things that you have to be able to add depending on the trauma. And you have different kinds of foster care kids. You have foster care kids who are in for the long term and kids who are in for the short term. And so you really do need that concentration. So that's why I want you to say that. Why did we do Cardinal Care? To be the platform. I'm also going to do one more plea. We got 26 foster care kids who are going to college. Wonderful. Wonderful. What we're doing right now is adopting them, and I just wanted to give that offer to you. What I do is when I went through Target, I had one time saw that, you know how when you do your college kids and you get them all the stuff and the quilts and the stuff, foster care kids don't get that. So if you're interested in that, let us know, because we would love for those kids to get taken care of. That's what we're doing. We're working with our plans on that, but I want those kids to be okay, you know, when they first start off. So if you have an interest, let me know. All right, the hard one, right? Let's talk about the bill. All right, the biggest thing I want you to get from this is two things: we do nothing. We can't implement without you. This is a governor, General Assembly, agency discussions. Nothing can be done without the whole discussion. So when you all ask the question, it's going to be all of us working together. And the second thing is, a lot that we're trying to do now is CMS implementation is waiting for guidance. So in the places I'll tell you I don't know, I really don't know. Now, the one thing I will tell you is an advantage is we talk to CMS often, obviously, but some things they don't know yet either. The big ones. Okay, let's start here with eligibility. Starting in January 2027, they're going to have redeterminations every 6 months. That's a big step, no matter how you put it. It's going to be hard, and there's no question in terms of the types of resources it's going to take. I had heard the question was asked earlier about Cover Virginia. Obviously, we'll be expanding the services in Cover Virginia. One of the things we're going to be asking CMS to do, though, is allowing contractors to be able to actually finish the eligibility, especially for things like this. So we'll be asking for things along the line, too, but we do know that one is coming. The second one is interesting. It's called duplicate enrollment. They call it concurrent enrollment. It's, for example, someone lives in Virginia and Tennessee, and they forgot to tell one or the other where they're really living. We have a program like that already. We call it Paris, in which we do that work. But obviously, CMS has a bigger landscape. They can see the whole country. And so what they're doing is they're going to give us files. But the reason I bring up that you have to wait on CMS is, even though it says effective January 2027, we got an email last week saying they're going to talk to us in August. So some of these dates are here, but it doesn't mean that CMS is going to have a different date. Okay, so that's why I said we have to wait. So we'll be getting the files probably in the fall and probably starting to work on those files probably earlier than later. The second one is the death master file. That's for people who are deceased. We're doing that now using VDH data, but this is going to be able to use federal data and actually have us to do that by 28. Obviously, this is immigrant eligibility federal match. It affects us mostly on the emergency services. On the emergency services, it will change our federal match from 90% to 50%. Most of the other things that we've seen in this here, it doesn't apply necessarily to Virginia, apply to some other states. The PERM rate, and I know that's hard. Every 3 years, we get an audit from the federal government we call PERM. It does both eligibility as well as medical care. On the eligibility, it's checking to see if DSS had done it correctly. And on the medical care, it's basically saying, did we pay the claim correctly? Good news, bad news. Good news is that we're under 3%. So on one hand, I should exhale and say, that's good. Bad news is that as I watch my colleagues in other states have high numbers, I do have to caution we don't want to get high numbers. So we'll be watching that. And one of the things you have a...
Yeah, you could finish that sentence, but I have a question.
Excuse me?
You go ahead and finish that sentence.
Yeah, what we're doing now is one of the things we do regularly in our department because of that, just before this happened, for a couple of years, is that we keep the PERM cycle going all the time in order to make sure that we're looking at errors all the time so that we never get to a point where we go too high. But we are watching the fact that we know that if we go over 3%, will be a penalty.
Okay, my question was on the third blue arrow point, payments for services for an emergency medical condition furnished to an individual eligible for expansion except for their citizenship status. So that means they're not a citizen and they come to the emergency room, they're not going to pay 90% anymore. That's what that means.
Yes.
They're going to pay 50%.
50%.
Okay. Okay, thanks.
Right now, when we enroll someone, we are willing to go back 3 months for retroactive coverage. That's concerning because what you normally do when someone applies, obviously, let's say I apply in April, is that as we're pending the claims, the person that still has services, we usually go back to April, even though we may enroll them in July. Here, what we're saying is that that will limit retroactive coverage for 1 month for the expansion group and 2 months for everything else. And so that will be a change. Change administratively, change for the providers, okay, in terms of learning how to do that. The last one on this slide is about the nursing facility rule. It never was implemented. So even though it got changed, it hasn't been implemented, so it has no real effect. In terms of the money, again, what happened is we had talked about this briefly, is there are two things to know. There are provider taxes and state-directed payments. Both of those are above what we pay for Medicaid. So in other words, you have Medicaid reimbursement, and that we do. We pay the hospitals, providers, we rebase them. Actually, last year you saw the rebasing numbers, and this is above that. So the provider tax and the state-directed payments are above that. There are three things that are going to happen. One, starting July, you can't have new ones. Okay, there's a moratorium on new. So the application that we put in that the General Assembly had approved, we did get that in before July 1st. So it's done, it's in CMS. But anything new, no. Second thing is going to happen is there's going to be a gradual decline. It starts in 3 years, but you'll see that there will be a decline in two places. One, any place that we're paying above Medicare, they're going to bring it down to Medicare over the couple of years. And the second one is a very complicated thing that I'm not going to try to do that talks about 3%, 6%, but basically it's a tax decline that starts in 2027. Any questions? Okay. This one is the one that's probably the one that I find interesting. It's going to be interesting to do. This is community engagement and work requirements. It'll start in December 26th. CMS is supposed to give us guidance this fall. We hope it's earlier because we need that time to implement. What it says is that the person who's in expansion must have 80 hours of work, community service, education, or a combination of both. The whole is we don't know the definition of work, community engagement, or education. Okay, I could go on about what that could be. And that's going to be the creativity. The second thing that's going to be hard is to figure out to track it. We'll have to figure out a way of tracking it. The good news was that the exemptions list got longer. Okay, so even from a month ago, the exemption list got longer. You can see here that obviously we have pregnant women. It went to children to age 13. And so I believe the state may have some more leeway in terms of that, but we are watching that.
Talk about how that's going to work a little bit more.
Some of it we don't know, okay? But what should happen is that at the time that you enroll for expansion and the time that you have re-enrollment, you definitely know those are going to be stopping points for us to do a check. What we don't know if they're going to ask periodically in between that. And that will be some questions. What we also don't know is how much leeway they're going to give the state. In terms of definitions.
The MCOs can't do this?
Excuse me?
The MCOs can't check on the work?
Well, this is interesting. They purposely said here that they felt the MCOs would have a conflict of interest. So they did not want them to be the one that actually gathered the information. Does it mean that the MCOs cannot do outreach and education? I'm sure. And are they going to allow us a waiver? Remember in outreach, before we were not allowed to use the MCOs for outreach, and they gave us a waiver during unwinding. The question here is, will they give us a waiver here? I don't know.
So, Cover Virginia in this case.
We're definitely, obviously, Cover Virginia is going to be expanded, no matter how it looks, because we're going to need them for calls, because DSS is not going to be able to take all the calls. We'll probably be using them as an information site. But in terms of whether or not they'll be able to process everything, we need CMS approval.
So they might be able to verify the work requirement. Cover Virginia might be able to do that because they don't have a
conflict
of interest.
They don't have a conflict.
But you don't know whether that's the case yet.
Not yet. But I also expecting that vendors are going to be developing apps. We've heard that rumor in terms of saying that way the person can actually key it in themselves.
So we're going to have to buy everybody smartphones that are in the expansion
Well, they already own the smartphone based on what I could see. But the question will be is even verifying it. But the big numbers I don't know, and I'll be honest, is the definition of what is work, community service, and education, and how that's going to work in timing. That really is going to be key. And now a snapshot, not a bad snapshot, is education. You could be in school until May, but if your re-enrollment is June, you would say, I'm not enrolled, you see? So what I don't know what that definition is. I'm assuming, and I'm hoping, that we'll be back here to talk to everyone about what does the state have leeway in. And that's what I hope will happen. because there's no way that CMS is going to be able to go to that detail.
So do you expect to suggest to CMS how this should work, or are all those states working together to get some better instructions from CMS?
The Medicaid directors are planning to work with CMS so that they can get some structure.
Okay.
Cost sharing. We got rid of cost sharing, actually, a couple of years ago. I think you all knew that with the expansion. What happens now is, and we have to have some cost sharing. The amount will be of dispute. We have to also figure it out. Before we had $1 and $3, and what this says is that we have to have $1, at least $1, but no more than $35 a service. So that will be an item of discussion. I'm going to tell you the last two. This is going to be good. And actually, Delegate Tran, I thought of you. This is actually saying that we could actually do home-based community services without requiring that the person needs to be institutionalized. Obviously, that has a cost, but it is broadening the option, and it gives us that option for a lot of people if we want to think about that later in the road. Okay?
Can you explain to everybody what that means, the significance of that? Because the current process right now
says you have to be nursing home eligible, right?
Okay, so that means you have to fail 4 out of the 5 of the decades of living and only have $2,000 to your name.
Yes, and here it's giving much more flexibility. And so we'll be able to, but again, they haven't defined it yet, but they're saying they're opening it up so that it's not just that you have to be institutionalized or eligible for institutional. Gives you some broader places. Costs money, but it gives us some flexibility in some places.
It would cost money, but it's at the Medicaid FMAP.
Yes.
Okay.
This is the one I think that I guess the Secretary and I are most excited about, is the Rural Transformation Program. That gives us $100 million, assuming we get the first application in, and then a second $100 million if we compete and win. What that's going to do, and essentially, I'm going to give this here, is the first $100 million is for us to distribute, whether we do this for rural hospitals or FQACs or providers who have that. We'll be working together and probably putting together a group. Let me go back. We're hiring a contractor to help us to put that together. The application will have to be in probably by November, so it's quick. But we want to be able to do a good swath of the state and start to talk about that. That's going to be interesting and good, because there could be, this is what I'm looking forward to. I mean, there are people and stories we know where people could use the help. And this is an opportunity we could actually look at that. All federal money, so we have some leeway there. The next half of
Can I
it
ask you
is
a question about that? We have hospital systems here that have a hub hospital and several rural hospitals that aren't on the critical list, that we only had 6 of those out of 300 some in the United States. But these hub hospitals are keeping these rural hospitals going. They're not necessarily profitable. How is that going to be handled when we try to seek a compensation for the rural hospitals when we have a situation like that, where we have hub hospitals in bigger cities subsidizing rural hospitals? It's fairly common in Virginia.
It is, and that's why I'm hoping that we can put together a work group, and that's what the governance group is going to put together to answer those questions, because DMAS doesn't want to do this alone, okay, and make the decisions on who and how this goes. So we will have to have some of those discussions. And, you know, we don't know how complicated it will get, but what I hope for this is the first $100 million we have to apply for by November, and so that's what we're going to be working on with the contractor. And then the second $100 million is competitive. And to be competitive, that's where we have to focus on population health. So one is more of a direct payment, the other one is more subtle. Here, where you're looking at it is you're looking at population health, places that we have opiate disorder issues, places that we may see diabetes as high. We're looking at rural areas that we have problems with health and figuring out what kind of opportunities we can give them in order for them to flourish. All right, I went through it fast, but I hope that it was at least easy to understand.
That was quick. Do we have any questions? This is real important stuff. Okay. I can probably think of some more questions. Okay, Delegate Tran.
Thank you, Mr. Chair.
Can I just ask, I was thinking also from the earlier conversation about the unwinding process and lessons that could be learned to apply to a more regular redetermination of eligibility process, the one every 6 months. Do you have thoughts on what are lessons learned that you could apply here to make sure you're reaching out to all the, I am not a mic, to reach out to all the affected community members, particularly those that are immigrant and or non-native English speakers?
You asked me 2 questions. Let me go down here, okay? One, I think the agency realizes that the whole push for education, we just saw that with Cardinal Care, has to continue. Okay, so it's not a stop point. It has to continue. And to be honest, as I said before, we had to learn how to talk to different generations. Okay? So this was the first time, if you see, and you'll see now, we're swamping social media because we realized that that's the expansion group. This expansion population is a social media, text, hate to say that, TikTok group. I mean, this is a group in terms of education. So that's going to be pushed. The second is ex parte. What can we do systemically without having to talk to the person? And that was a lesson we learned in the unwinding. That will take some work, okay, because obviously some things we could do electronically, some things we may need to add additional contractor help, okay? But the goal, if we can, we would love to get to a point where we do less of asking people to go to DSS for routines and more that we can do electronically. So we'll figure that piece out. Believe it or not, and she can come and talk to you, Sarah Hatton, who also does our eligibility, has been very focused on access and language, as you know. And we have done that I think, fairly well, always working on it. Very conscious of that, okay, in terms of that. Our plans have requirements about what they have to do, but obviously as we start rolling this out, we're going to be very conscious of our populations. Different populations will have to have different things. And honestly, in some places, like in Northern Virginia, NOVA's going to have to help us. So we know that, but we have to go up front. Okay. I'm going to let Will talk about what happens when you get a bill. And we're going to make a joke, Yes?
But we have Delegate Willett on the line here who wants to ask a question, and then we have Delegate Cohen and Delegate Shin, so you're not getting out of here that quick.
Sliding out? Okay. Go ahead.
You're too popular, Cheryl. No, I know you're dealing with a lot. Just a couple quick questions that may not have quick answers, but in terms of getting your arms around how to do this semi-annual qualification, you're still doing it in terms of the level of effort, what that's going to take. You don't have a number for us yet on that.
Not yet.
It's still.
Not yet. But I mean, we already know that it's going to be hard on the localities. And that's why we're trying to think of everything we can do to pull it from that. So not the routine one, the routine one. We understand they still have to do some work, but the routine one we would like to work on doing as much as we can to do electronically, as much as we can to use a vendor, because it will be too much on the localities.
Good. Mr. Chair, just one and I think the chairman asked one of my questions, which was, we're gravely concerned about the rural hospitals and the impact, so at least there's some money we can get for that. Tell me again, is it that you said we're going to get $100 million?
Well, I have to apply for it. We
have to apply for it, but at least that's allocated, and we have to compete for the additional 100. What did you say? I missed this part. You're saying, is it that second $100 million, if we do get that, has to go to population health efforts? Did I hear that?
You saw the list that we had on the deck.
Yeah.
Those are the issues that we need to be targeted and work for. And so those are the things that of a provider, let's say, is a provider, like one of our arts providers who does opiate care in the Southwest, that would be a good one to say this will help their project because it's supposed to be targeted more to population health.
Okay. I just want to be on the record saying there's so many things to be concerned about from the big bill, but and the impacts actually on the hospital, it's affecting all hospitals, not just rural hospitals. Just several of us were on the Rural Healthcare Committee. We were in some of those hospitals that are on that list that are closed. They've already shut down obstetrics. They're only this far away from shutting down the rest of the hospital. So I'd just say that's got to be one of our highest priorities.
One of the groups we were supposed to talk to is you. You're on our list, by the way, already, to talk to your commission. But yes, we're very conscious. As you know, maternal health is one of my pet projects, and concerned about watching some of the maternal units closing, which makes the woman go 2 hours out. So yes, that will be a discussion. But it's also, like he said, owned by a big hospital in a hub. So we'll have different discussions. Mhm.
Okay, Delegate Cohen, who's not a member of this committee, has a question.
Hello, Delegate Cohen.
Yet. So just piggybacking actually on Delegate Willett, do we know in real dollars what the reduction is going to be for hospitals? When we had on your previous slide, the one that said supplemental payment and provider tax slide, what's the bottom line, do we know, for our hospitals?
We're leaving that to be more speculative, and I'm going to tell you why. Still waiting for CMS guidance, honestly. And for example, we don't know how eligibility is going to play against this. So it's hard to take a snapshot picture, a real snapshot picture. So we can give you speculative answers, but not real hard answers yet. I'm expecting CMS to give more direction on that sooner than later because they're getting pressure from the community, from the hospital association. So we'll start to get that guidance, I assume, sooner or later.
Do you have a follow-up? Delegate Shin.
Thank you, Mr. Chairman. Mr. Chairman, I think it's what seems obvious to me is that the impacts of H.R. 1 are just throwing up additional barriers for folks accessing healthcare. And so I've got some questions here that might be quick questions and maybe one that's a larger one. But the first one is I saw you talk about the death master file, and I wondered how frequently currently it's being utilized because the mandate coming down from the feds is now going to be to do it every quarter. Is that correct?
Yes. And we monthly look at VDH's data.
So currently it's monthly and we'll go to a quarterly. Is that right? Then you're going to go to a quarterly
to go to theirs. What we have to figure out is will we keep VDH's or we'll only use the quarterly? And again, that will be a discussion point within us to say that. Because like right now we do this automatically, right? But the question is they want us to use the federal one.
Okay. The second one I had, thank you, Mr. Chairman. I'm sorry, I have a second question. When we talked about the providers' reimbursement rates being dropped to match the Medicare levels at 100%, do we have an estimation of how that's going to impact providers who are willing to give care as medical or Medicaid enrollees or Medicaid providers?
No, we haven't gotten to that point. In fact, I meet with the Hospital Association next week. But no, we haven't gotten to the point to say that. What does it look like? Because it's also, be careful, it's 3 years out. And so they're speculating what will it be 3 to 14 years out, and that's the discussion point. Because nothing changes in the first 3 years.
And Mr. Chairman, just one more, if that's okay with you.
Delegate Chen.
It sounds like there's a lot of tracking that's going to be required of DMAS from the redetermination eligibility along with the work and volunteer education hours and getting those definitions out. Are the feds, at the federal level, are they providing any sort of support associated with the overhead costs that will inevitably be associated with all of this tracking, the additional staff bandwidth, all of the promotional and educational materials? Is there any plan for additional support?
They provided us minimum numbers, okay? We're going to have to, the state is going to have to come up with the admin money, right?
Thank you, Mr. Chairman.
Thank you.
It came out to, I think, $2 million apiece, and it's not enough money.
It's going to be, we'll be waiting with bated breath for your budget submission this winter.
Yes, it's going to be of interest, particularly.
Yeah. Delegate Willett, did you take your? You're good. He's good.
Okay, I'm going to bring Will.
Okay, Will Frank.
Mr. Chair, good afternoon. Will Frank, Senior Advisor, Legislative Affairs at DMAS. I'm going to give you a quick overview of what DMAS has to do when the General Assembly tells us to do something that occurs every January. As you know, Medicaid is a state federal program, so to implement a lot of these items, most of these items that you tell us to do, has to go through a very strict procedure process involving the state and the feds. And the only thing, if you take away one thing besides this is complicated, please let that be, give us a call when you work on these things to provide technical assistance to help answer some of these questions about what would go into a new program to be implemented. So I think most of you have my phone number. Feel free to give me a call as you work on these things. Kind of to start with, again, to go through this quickly, hopefully keep you on track. The first step DMAS needs is to get authority from you, from the General Assembly, either through legislation or budget, to authorize us to move forward with a program You've seen, I think most of you on here have introduced bills giving us authority to move a new program or to change an existing program. And then a lot of times also appropriations is needed. Funds are needed through the Appropriations Act to either hire a contractor that is subject matter expert to help develop it, conduct a rate study if that's needed, hire additional staff to manage it if that's needed, pay for the services as they are, or increase the rate. So not only legislation a lot of times, but also appropriations are needed. Next, also, once we get that authority, then we have to kind of scope out what the service is going to be. Is that, what are the different components of it? What are the functions of it? Who will it serve? We do, a lot of times, we might hold, depending how complicated it is, it's a lot easier to scope out a rate increase versus standing up a brand new service. We might hold a series of work groups with providers, advocates, members to discuss the potential impacts of it. We might hire a contractor with expertise in this to help develop that proposal. If we have to hire a contractor, it has to go through the state RFP process and procurement process. We have to work with the managed care organizations, sister agencies, stakeholders to train folks, to educate providers on it, and really look at a communications plan to make sure that we're reaching out to the appropriate people. One thing to flag for you is there is a variety of ways that we have to implement these programs. It comes through kind of different channels. One of those are waivers. You hear a lot of discussion about Medicaid waivers. Medicaid waivers are authority by the federal government to waive federal rules on Medicaid. It allows us to implement some different programs that are outside of those rules. Usually they're time limited, between 3 to 5 years. You'll hear us also talk about state plan amendments, SPAs. Those are dealing with addressing Medicaid programs within the rules. The waivers are when we start looking outside of standard Medicaid rules. Here's some examples of different waivers. 1915B is managed care. 1915C is community supports instead of hospitalization. A lot of you have heard talk about developmental disability waivers, CC Plus waiver. 1115 waivers are demonstration waivers to implement new programs, the arts waiver, SMI waivers. 1332 waivers are state innovation waivers that aren't specifically dealing with Medicaid, but healthcare and health insurance in general. And then 1135 waivers are dealing with health emergencies, declarations of disasters, things like that. And depending on what service you're talking about, we might need to amend different waivers. We might need to not only deal with that, but also a state plan amendment. Once we get the authority, we have to seek the federal approval. We have to submit documents to CMS. We've talked to many of you about this. These are either state plan amendments, waiver amendments, or both, where we have to explain what the program is, the impact, how it's going to be reimbursed. These documents were required to submit them ahead of time to the Department of Planning and Budget, to the Native American tribal groups that operate clinics. And once we submit it, CMS has 90 days to review that. And again, I've worked with some of you on some of these issues. They either can they review it, they can approve it, deny it, or they can stop the clock for more questions. That happens a lot of times where they'll come back to us with questions. We'll answer their questions as they review it. Some of these processes could take a few months to over a year for CMS to approve this, and DMAS can't move forward with implementing the new benefit or the change without that CMS approval. Once it is approved by CMS and funds are appropriated for this change in the program, DMAS might need to hire staff to manage the program, to develop the program. That takes through the state employment process. A big thing that a lot of people don't think about is system changes, whether IT changes need to be made to our Medicaid enterprise system. That has to be done too. And then a big part is the communication requirements, public notices, comment periods, reaching out to providers, the Medicaid members, all that is done. And then we also, depending on the benefit, DMAS has to promulgate regulations that goes through the town hall and the regulatory process. We have to update provider manuals that goes through also the town hall process. I'm not going to go through all these, but wanted to provide you with a list of questions that might help you as you look into potential benefits, just to think about the different impacts of it. Again, the one thing I'd like to share is we're here to provide technical assistance. If you work on developing any of these, give us a call. We can tell you how it would work, what the different components would be to implement it. And I would also suggest do that sooner than later as you develop it. Give time to kind of let us know what you're thinking, and we'll be able to answer any technical questions that you might have. And that is it, Mr. Chair.
So, Will, I have a question, because last year we were trying to create a new waiver for a brain injury waiver. We've discussed this over the years, whether to have one or not. We have several Virginians in a facility in Braintree, Massachusetts that we're paying for, and we wanted to pass a waiver to bring them back to some residential facilities in Virginia. The way that DMAS is proceeding now is not how the advocates of this thought it would be. Can you explain that a little bit? Because I think you're looking for nursing homes to do this, and that's not what the advocates were looking for now. The way you're proceeding with this, is anybody, Tammy's not here, I see.
No. I don't know that I have the answer to that, but I would be happy to get that.
I guess my point is, I know what you're trying to do here because we send you a bunch of crap and you would like us to work with you ahead of time before you get that. But we in this case, we tried to do that last year on this case. Not me personally, but I was trying to help people. I'm very sympathetic to this cause. I was trying to help people, and we thought we were doing something, and now it's just stuck somewhere, not moving forward. So anyway, maybe there's something we can get back to later.
Absolutely.
Okay. All right. No lights are on. Thank you, Will.
Thank you.
Everybody remember that. That was a lesson for us, if you weren't listening. we took the lesson. Okay. And now, Heather, is it your turn? Okay, thank you. From the Department of Behavioral Health and Developmental Services, and I think you've been promoted since you last testified. Is that correct? You're Deputy Commissioner now?
Yes, it is.
Well, terrific. Congratulations on that. And
thank you.
You have one of the hardest over in that agency, and maybe Director Roberts would disagree with me, but I think your agency got the hardest job in state government.
Well, thank you, Mr. Chairman and members of the committee. As was mentioned, my name is Heather Norton, and I'm the Deputy Commissioner for Community Services. Thank you for inviting me and my colleague, Angela Harvell, who's the Deputy Commissioner of Facility Services, to talk about the Virginia waiver rollout and the Hiram Davis Medical Center closure. Let me do that. First, I'd like to give you an overview of the 3 types of developmental disability waivers. After being assessed, individuals are assigned one of these 3 waivers. The Building Independence Waiver is for individuals who are 18 years of age or older and who can live mostly independently, usually in their own home, controlling their living arrangements in the community with minimal supports. Our Family and Individual Supports Waiver is for children and adults who live with their family or in their own homes and can be supported through functional, behavioral, or medical supports. And our Community Living Waiver is for both children and adults, but are in need of residential supports and services or 24-hour care, whether that be through sponsored residential or through group home services. Almost 19,000 individuals currently receive services from one of our 3 waivers, which is 2,000 more people when we met with you a year ago. The QR code links to a guide for those individuals and families about resources and processes for individuals who are receiving DD waiver services. You may find it helpful as well to understand the waivers and available services in more depth. There has historically been a long waiting list for waiver slots broken down into 3 categories. We have our priority 1, which is individuals who need services in a year or less, priority 2, who need services in 1 to 5 years, and priority 3 for individuals who are seeking services in 5 or more years. You can see on the slide that we have the numbers of people waiting in each of those 3 categories. You're all aware of the Right Help Right Now goal to eliminate the priority 1 waiting list, and the General Assembly agreed to a phased approach to add 3,440 slots, as well as provide a 3% rate increase each year of the biennium. Although numbers on the priority 1 list continue to grow, we've already made a big dent. Since July 2024, 2,718 people have been assigned a slot, and we are very confident that the 3,440 people the governor committed to funding slots for will receive waiver services. We will, excuse me? Yes, sir. And we appreciate that. We will continue all of our coordinated efforts to ensure these slots and needed services are getting to the families who urgently need help. Another piece of this is the licensing process to get providers up and running. We recently reduced the time it takes to get licensed for certain priority services. These priority providers are now able to become licensed within 30 days. It takes a well-coordinated effort to ensure that these slots and needed services are getting to the families who urgently need them. We are ahead of the curve because we made a streamlined and more efficient process to allocate slots and address potential barriers. Now, instead of taking up unnecessary time holding meetings to determine who gets a slot, we are administratively assigning slots when that's possible. And this is possible when the number of slots allocated for somebody or for a CSB are more than or the same as the number of people on the priority 1 waiting list. The process on this slide gives you a sense of the extensive steps we move through from the General Assembly allocation to the local level to ensure the slots are assigned fairly and on a timely basis. And just so that I can go through that, what we do is we hold regional waiver slot assignment committee, or we hold waiver slot assignment committees at each of the CSBs. If they can't be assigned at a CSB, then we go to a regional slot assignment committee, and if they can't be assigned at the regional level, then they go into a statewide pot and are assigned statewide.
Heather, have you gone through that entire process now so that you have reallocated a waiver to some other region? Has
Correct.
that happened yet?
Yes, sir. So what we have is, I believe, when I looked at the numbers earlier today, 98% of the FY26 or 25 slots have all been allocated and assigned to a person. So I think there was like a remaining 15 or 20 slots that needed to be assigned to somebody.
Yeah, that wasn't really my question. Because I think I like the fact that you're trying to be flexible and use them all.
Yes.
But within 12 months to take them and say no one's going to use that, which CSB is going to give up a slot?
It depends on the region, but for example, in Region 4, RBHA didn't have anybody on the Priority 1 waiting list. Right now, I think there's like 4 CSBs that don't have anybody on the Priority 1 waiting list, 4 CSBs that have 1 person on the Priority 1 waiting
And those
list.
were reallocated regionally?
Correct.
And then they were used in the region?
Yes.
Okay, so none of them have been reallocated statewide yet?
Not to my knowledge. I think we've been able to use all of them within the regions.
Okay.
All right. If a CSB cannot assign a slot in 90 days, it first goes to the region and then to the state based on percentage of individuals on the waiting list. And here's the information I was just talking about. More than a quarter of the CSBs have between 0 to 2 people on the Priority 1 waiting list. It is no surprise that the CSBs in Northern Virginia have the most individuals on the Priority 1 waiting list. We are working through this systematically with the CSBs and other partners to ensure all 3,440 people across Virginia who were promised a slot receive the waiver services that they are requesting. As I mentioned before, 2,018 individuals have been assigned on the Priority 1 waiting list have been assigned a slot since last July. The General Assembly provided 1,720 slots in both fiscal year 2025 and 2026 for a total of 3,440 slots. Since we are sending all the allocations to the CSBs on a quarterly basis, that works out to about 430 slots per quarter. The fourth quarter slots have been available to the CSBs as of April 1. We are allocating slots quarterly, so the visible reduction in the list will be slower, but it will be done hand in hand with CSBs to ensure services are ready to go. Another piece of this, again, is the licensing process to get providers up and running, as I mentioned. DBHDS estimates that over 150, closer to 170 waiver slot assignment committees were completed this year. The regional support team unit that are responsible for organizing the waiver slot assignment committees and assigning the slots have done a phenomenal job with the fiscal year 2025 slots. Never before has that many slots been distributed in that amount of time, and our team and the CSBs are working to get 4 times the typical amount of slots out the door. For example, Fairfax has been holding monthly WSACs because of the amount of slots allocated to them.
Well, hold on a second here. Out of the 3,440, Fairfax Falls Church has over 1,000, but they've been only given maybe 200. Last year was 199. This year was how many? 400 maybe. I don't know how you're going to get 3,000 done when one CSB has 1,000 of the 3,000 on the high priority list. How does that math work?
So it means that as we continue to assign to different CSBs, they will, we will fill up, we will not need slots in certain regions, and then they'll go over.
They haven't received a slot from any other region
yet.
Okay, so I tell them they're going to have 600 coming soon.
I think that this year, because we've seen such a reduction in the waiting list for some of the CSBs, like I said, we have 4 CSBs with no individuals on the waiting list, 7 CSBs with 1 or 2 individuals. 12 of the CSBs have 2 to 15 individuals, depending on their slot allocations. They may not be getting, they may not need their slots in the second, third, and fourth quarters.
All right, well, it's going to be hard for them to do them all in the last little bit, but I appreciate the thought behind it. And one more question here on, maybe it's on your next slide, but the slots assigned in 2025, 1,713, you know that those individuals are receiving services?
So I actually pulled that data because I knew you would ask me that question. And as of, as you know, individuals who receive a slot have 150 days to identify services. And so as of quarter 3, 80% of individuals who have actually have authorized services for the slot that they received.
Okay, they have, so 80% have them authorized, and they're about to start, or they've started?
The authorization is the start of the service.
Okay, so that's the same.
Yes.
Okay, so you're 80% of 1,700. Yep. Okay, thank you.
And with that, obviously a waiver slot is life-changing for people who desperately need one and ready to do, and we are ready to do this work again for fiscal year 26. We are so grateful for the support of the General Assembly and the Governor. And that concludes my presentation on the waivers, Mr. Chairman, and I would be happy to take any questions before turning it over to Angela Harvell to discuss Hiram Davis.
How are the nonprofit partners in your program, how have they reacted to the fact that we funded 3,400? Because one of the reasons we did it was to assure the private sector that there would be money out there for them to invest. Is that proven to be the case?
I think we continue to experience challenges in terms of staffing and getting supports and services in place, depending on the supports and services, but we have processes in place and are working with our partners and the advocacy organizations who support them to make sure that, we're working on developing a DSP pipeline and curriculum with high school students.
Okay, DSP, tell everybody.
Oh, direct support professional, sorry, thank you. So we continue.
A lot of people are watching out there across the Commonwealth.
We continue to partner with our advocacy organizations and the providers that they support to gather information, learn from them, make sure that we're addressing issues. We have a providers issues resolution work group and a systems issues resolution work group. One is working directly with providers, the other is working with individuals and families, really to look at the things that are challenging the system to be successful. So looking at administrative burden and the work that we're doing. One of the big initiatives that the Providers Issues Resolution Work Group recently took on was streamlining our competency requirements because they were multiple pages long. There were redundancies with them, and so we're hoping to streamline that so that it'll be less cumbersome for our providers in terms of implementing them.
Oh, I'm sure that'll be welcome out there. Do we have any questions? Anybody? Okay.
All right, I'm going to have Angela come
report.
up. Thank you.
Thank you so much.
Good afternoon.
Good afternoon. It's good to see you.
Good to see you again. Thank you so much for inviting us to talk about this very important topic. So, Mr. Chairman and members of the committee, as you all remember, back in August of last year, we announced the intent to close Hiram Davis Medical Center in Petersburg, Virginia. The decision did not come lightly. We had been experiencing some major infrastructure failures and issues with our physical plant services within the building. And while we have made major strides in ensuring that we mitigated the more imminent concerns at the facility, we are still very much concerned about what is to come due to the age of the major systems that the facility is still utilizing. And with those systems that we've identified, obviously that includes the electrical system, the HVAC system, the water systems, piping, and the building was built in 1974, so as you can imagine, without any major renovation, we are in a situation where we're caring for medically fragile, complex individuals in an area that none of us would necessarily want our loved ones to be in. And so we're trying to be good stewards for the Commonwealth and ensure that not only are we providing quality care for the individuals, but we're also providing safe therapeutic environments for our staff as well as for our individuals that are entrusted in our care there. We have, as I mentioned, mitigated several of the concerns that were more imminent. We had elevator failures. We also tackled Legionella within the pipes for several years, and we successfully mitigated that earlier this year. If one of these major systems failed, we would have to find placements for those individuals very quickly. And if you, as many of you have visited the building, our patient areas where they reside are on the second and third floor. And so that means that we would be doing the best that we could very imminently to get them out of the building into a triage area potentially, and then activating our VHOS system to ensure that we can identify placements across the state to accept them. The other issue with the imminent failure situation is the fact that we would have to vacate the building for up to 2 years for those renovations to occur. So while we've been able to ensure that we have some continuity of care with the renovations that we have been able to do, the major systems must be offline for 2 years for those renovations to occur. As you can see on the slide there, we have a census of 32, and there's 32% occupancy from our total capacity. 18 of the individuals are individuals with IDDD, 8 are mental health individuals, and 6 of them have dementia. There are 3 individuals that are planning to discharge this summer. They are all individuals with IDDD. 2 are moving to DD waiver group homes, and 1 to a community nursing facility. The other thing that I will mention about the major renovation is that the code will require us to bring the building completely up to CMS certification codes and building renovation codes that are current right now. And so that would be what would trigger the entire building to be renovated, not just for us to be able to complete one component of a building renovation.
But we're planning to close it, aren't we?
Yes, sir.
Yeah, okay.
Yes.
Well, everybody supports that, I think, that I know of. As long as we can take care of the 32 patients that we have there, you're looking for the right care for each one of those, right?
That is correct.
Yeah, thank you. Yeah.
So on the next slide, once the 3 discharges that I mentioned on the last slide occur, there will be 29 individuals remaining at the facility. I know your slide says 30, but it's actually 29. We do regularly talk to the families and to the authorized representatives.
So do we.
Yes, sir. And this is a requirement from the DOJ settlement agreement, and it's also just best practice that we stay abreast of individuals' preferences. And so we do offer least restrictive placements, and if a family is ready to move forward with discharge planning for individuals from Hiram-Davis, we certainly do honor that. It's not something that we're pressuring them to do right now. But from what we've gleaned in years past and more recent conversations, we do feel we have a good grasp of where individuals would like to be placed. And so that is the information that you see on the slide there. We do have enough waiver slots for individuals, as an example, if they would like to move into the community, into a waiver group home. And there is also the ability for them to continue what we consider training center placement at Southeastern Virginia Training Center in Chesapeake. That is the effort that you all supported with the $3 million to upskill 10 beds at Southeastern Virginia Training Center for skilled nursing facility beds. Right. So for the 15 individuals that would be left with DD, who remain after the upcoming discharges, based on conversations, we believe that 60% are likely to choose waiver group homes, 33% are likely to choose the option we are building at Southeastern, and 1 individual, which would be 7%, to a community intermediate care facility. So any questions about that?
Well, this is a sensitive subject when you're talking to the parents about them, so you don't want to pressure them, but you are making sure everyone knows the alternatives.
Absolutely.
And we don't have a deadline for closing the building yet. I mean, it should have been closed last year or 5 years ago, but.
Yes, sir. Well, later on in the slides, we'll be discussing the process that we must undertake to close a state facility. And so while we're trying to do our due diligence and sort of plan simultaneously, there's only so much that we can actually put in place, but we're obviously thinking about all the aspects so that we can be successful and make sure that we keep people safe.
Sure. Delegate Walker's been involved in this process, and I think he has a question now.
Well, maybe I should let you go ahead and finish explaining or presenting the refugee program, because I do have 2 constituents that are of the critical care state. And I've been part of some of these presentations. I've been doing Zooms as well as Mr. Chairman and I have been over there to the facility. So go ahead and finish, and then I may have some questions afterwards regarding the location.
Thank you, Delegate.
Yes, sir. Thank you. So from 2011 to 2020, Virginia closed 4 of its 5 training centers, leaving Southeastern Virginia Training Center in Chesapeake, Virginia. And our Southeastern Virginia Training Center's population is decreasing over time, and there is enough space there to accommodate 10 individuals from Hiram-Davis Medical Center. So if you've been to that campus, it's a campus of 15 homes, much like group homes that you would find in the community. There are 5 beds each, 5,000 square foot homes, and the census there is about 65 right now, and so we have 10 placements available. So we would be renovating 2 of those homes to skilled nursing facility beds, which is the same level of care that the individuals currently receive at Hiram Davis Medical Center. And this would include all of the regulatory requirements. We have been working very closely with VDH. They have been out to the facility. They have toured the homes with us. We're working with architects to ensure that all of the requirements and standards are included. And we're also working with them on the certification requirements for our staff, our policies, and everything that you would find in a skilled nursing facility. Of note, we have concerns that about adding additional nursing beds across the Commonwealth where they may not be needed. As we mentioned, based on our information that we're aware from the ARs at, or the authorized representatives of the individuals at Hiram Davis Medical Center, that only about 10 or less of the individuals would continue to choose training center placement. And it's very important that we continue to comply with the Department of Justice expectations around least restrictive environments for our individuals. And so we need to be careful when we're thinking about increasing the number of skilled nursing facility beds across the Commonwealth.
Are you worried that we're doing that?
Not with our current plan, sir, but again, a final decision hasn't been made, and so we have to ensure that we're going through the process that's been outlined by the code.
Okay. Thank you, Ms. Harville.
All right. So on our next slide, let's see here. So in August, when we announced the closure process, there were about 164 staff members at Hiram Davis Medical Center. As of spring, 12 staff members, or 7% of the facility workforce, has moved on to new positions. Staff there are highly skilled, dedicated, and we know those positions are in demand in other private sector locations, and we certainly have enough vacancies across our state facilities as well where they would be welcome. We're actually taking a look very closely at our 2 facilities in Burkeville, as well as Central State Hospital right on the campus with Hiram Davis Medical Center. Positions may be available at central office and or Eastern State Hospital, but we're also giving individuals the opportunity to move across the state to any of our state facilities, because our ultimate goal is to ensure that there are no layoffs for those staff. They are dedicated employees. I have worked with them myself in my 26-year career with facilities very closely, and they provide quality care for those individuals that they serve. So 31 positions will be moving to Central State Hospital. Those are areas of service that will be built out in the new Central State Hospital footprint, and so it's very easy for us to transfer those services over there. Hiram Davis has provided services to Central State Hospital, and now they would just be doing that in-house, as well as other safe facilities if it's needed.
How far along, or when is that building going to be finished?
January 2027, substantial completion.
Okay.
So almost there. It's shorter than it has been, sir.
Delegate Price.
Yes, thank you. I just, before we left this staff slide, I just wanted to see, I know that limiting layoffs is very important, but just wondering about the ability for lateral moves for the staff. Can you speak a little bit to that? Because I know, I mean, if someone is, banking on a certain salary in order to feed their family, keep their house and all of that, are we able to shift them to, a similar pay rate, or is this trying to just,
yes, ma'am.
I don't mean to say it, but just like get them wherever you have openings?
Yes, ma'am. We are moving about 31 positions or more over to Central State Hospital. That includes the position or the FTE itself plus the funding. And then other individuals, we're looking to find like vacancies across the other facilities. And when we started this process, we indicated that we wanted to ensure that the staff remain whole or in a better position than where they are currently. And so we're still committed to that. Our Human Resources Department is meeting with each staff person individually to get a better understanding of what their preferences are. We're also offering other opportunities in the way of training for leadership or other skill building opportunities for them. This is very much what we did when we closed the training centers as well. And we just want to ensure that the staff know that we're supporting them and we're going to do what we can to ensure that they remain employed. If they decide not to stay with DBHDS, we would also be working very closely with our stakeholder partners, Community Services Board. We would, offer letters of recommendation, anything to ensure that they remain employed. Yes.
Okay. Well, please continue.
All right. So on the next slide here, this is talking a little bit about the process that I mentioned earlier, Chairman Sickles. Virginia Code requires DBHDS to start a consensus and planning team to ensure a careful plan is developed for the individual staff and community services involved in closing a state hospital. This is a very regimented process. This is the first time that DBHDS has activated this process or gone through it. It was very new to us, but I will say our planning team has done an excellent job. They have created several subcommittees, one supporting patients, one supporting staff, and building community services. That's all requirement within the code. They have ensured that the meetings have been public, they are recorded, they are posted for anyone to listen in to. They have ensured that they have captured all of the feedback from the stakeholders. The committees, the subcommittees are very diverse, and they are a makeup of everyone that would be involved, from advocacy groups, families, opportunities for individuals to participate in any association that would be involved in this process. We have worked hard to ensure that this is a transparent process, and each subgroup's plan are due to our commissioner by August the 1st, and we will be weaving the 3 plans together to create one comprehensive stakeholder-informed plan. We will make sure all stakeholders have an opportunity to review this final plan prior to its submission, and once the plan is complete, the code requires us to present it to the Joint Commission on Healthcare to make recommendations to the General Assembly. And budget language requires us to provide the plan to the money committees by November the 1st of this year. And this last slide is meant to provide a general overview of the draft timeline for the proposed closure, so you can sort of take a minute to see if you have any questions about that timeline. It includes the planning team process, a potential time frame for JCHC recommendations on whether the plan should move forward, and lays out other important milestones like the certified skilled care homes opening at SCVTC. The construction for those homes we're planning to start in November of this year with a completion date in May of next year. Our mission will be to develop the best stakeholder-informed comprehensive plan possible for your consideration. Then we will be ready to implement the plan or adjust our direction based on that decision. This deliberate planning process would not be possible if there is a building failure that I mentioned earlier, because of course the immediate course of action at that point would be to ensure individual safety and to make sure that they have a place to be. So finally, I'd like to end by restating our commitment to working closely with families to transition their loved ones to a new setting that is safe, fulfilling, and provides the supports that are needed in accordance with individuals' preferences. And we are committed to keeping as many of the 152 staff that we greatly need as possible. So thank you, Mr. Chairman and committee, and happy to have any questions.
Thank you, Ms. Orville. You're doing a great job over there. Thanks for coming up to visit me recently.
Yes, sir.
That was nice of you. Didn't need to do that, but I appreciate it. Questions? Okay. Delegate Walker.
All right. Thank you very much for your presentation, especially that last slide as far as the timeline is concerned. And I've been on these planning Zooms, and of course, as I mentioned earlier, I have 2 constituents that have patients there that require the skilled care. I heard recently, and I have met with the commissioner as well regarding this. But you indicated you want to keep as many of the personnel there in Petersburg, associated with the Hiram Davis right now as they're making this transition. And while Chesapeake is in the discussions, and I think you indicated it hasn't been finalized yet, is there a possibility of the few skilled cares, I don't know if it's a dozen or less, staying there in the Petersburg area? Are there any other facilities, cottages? Because I understand that there's going to have to be a lot of renovation or some renovation over in Chesapeake with some of the cottages they have to accommodate some of these more severe individuals here. So I guess the question is there still any possibility of staying in the Petersburg area with a few individuals that require the skilled care in some facilities?
Mr. Chairman, Delegate Walker, there are multiple opportunities that could be considered by Joint Commission on Healthcare. The two that we outlined as an agency were to close the facility and ensure that individuals receive safe care of their choice in the community or at Southeastern. Other options would be to renovate Hiram Davis Medical Center and or to build another facility. The issue with that is that for the latter two opportunities, the individuals that currently reside there would have to move for a minimum of 2 years. If we were to renovate the building, could be longer. To build a new facility, it would be even longer because, of course, building a new facility could take potentially 4 to 6 years, and if they're imminent failure, then they would have to move out of the old footprint. And so it's a very complex situation. It's nuanced in exactly which choice that the General Assembly may make. I know that there has been some discussion regarding whether we would build group homes on that campus for individuals that are currently there. I will tell you that there are no current structures, even from the old training center, that would be feasible for that to happen. We would have to start from scratch. And the department does not have plans or cost estimates of what that particular option would take.
Okay. Well, thank you for that information because, you hear different things as the ball is still moving here. And so I know Chesapeake is probably the likely of the easier of the ones trying to get rehabilitated in time with the funds that have already been appropriated. So that's the reason I just want to bring that up. So according to your timeline here then, the groups that are meeting together are going to present a plan. Then that will come to us or the money committees in January so we can take action in the first of the year or back in session here.
Yes, sir.
All right, this is helpful because the patients, parents communicate with me pretty regular. I mean, they're probably almost the most correspondence I get is from these individuals. And I can understand here because, when the facility was there in Lynchburg, where I'm from, and everything moved, I think that's probably the concern of one of the individuals that passed away in that transition there. So just trying to be sensitive and concerned with theirs, and you guys are trying to do the planning and do what's in the best interest of all parties involved. So I appreciate this information here, and we'll just see how this plan unravels or how it develops,
Yes, sir.
moving forward there. Yeah, I'm about unraveled too, because I promised my wife I'd be home for dinner, and I'm going to be late now. So, but
give her my
that's all,
phone
Mr.
number. I'll
Chairman.
give you an excuse. I'll tell you were.
Thank you,
just
sir.
copacetic.
Thank you, ma'am.
All right.
Thank you, sir.
Thank you. Any final comments or questions from Ms. Harbell? Thank you for all the work. How many years have you been with DBHDS now?
26 years in September.
And you used to be director of a hospital, one of the hospitals?
Yes, well, Southeastern Virginia Training Center for
Okay.
5 years, facility director there, but I also worked on the Southside campus for 15 years between Southside Virginia Training Center, one of the training centers that closed, and also Central State Hospital.
Oh, wow, okay.
I've been with
Well,
Central
I know
Office
you've
for
got
about 5 years.
you've got the longest construction project in Commonwealth's history going on down in Petersburg. Now, I think you're going to be building, when they finish HRBT, you're still going to be building that hospital.
Yes, sir. Thank you so much for your time.
Okay, thank you. Need to call the Corps of Engineers on that one. Okay, anybody else have any final comments? Delegate Willett.
Thank you, Mr. Chairman. Thank you for getting us together. Thank you for this incredible education and to the agencies. And I know what many of us are wondering, because we're all students here, we all love to learn. You're saying, what can I do next to learn more? And I will say, but wait, there is more, because tomorrow morning, go home, get some rest, then tomorrow morning at 8:30, up on the 7th floor in the North Conference Room, the Virginia Health Workforce Development Authority is holding, I won't call it a boot camp because that would be stealing your branding, but a session for us to learn more about graduate medical education. There's been a lot of discussion today about health workforce. One of the big holes essentially we're trying to fill in Virginia is dealing with the residency program, getting more residents, keeping more residents, and we've made some changes to the GME program. This is going to cover that. So I encourage everyone to join us tomorrow at 8:30, and then you can come to the Joint Commission on Healthcare at 10 a.m. It's another full day, Mr. Chairman.
Healthcare all the time. I'm going to be there for part of it. So anybody else? Someone, we can't let Willett have the last word, can we? Okay. Well, hearing no objections, we are adjourned.